Thank you. Thank you very much, Dr. Vijay Jawar, for your valuable talk on cutaneous manifestations related to COVID-19. Thank you, sir. I invite Dr. Vijay, sir, please take your seat here. I invite Dr. Neeraj Pandey, moderator, to conduct the panel discussion management challenges of post-COVID health disorders.
Sir, your mask is there. Sir, you have fit your jog very fast. Good morning, everyone. At the outset, I'd like to thank Scientific Committee and Organizing Committee of Telangana State CUTICON for giving me this opportunity to moderate such august panelists and to interact with such lovely audience. With this, can you please play this CVs of, thank you. So today we'll be discussing on management challenges of post-COVID alopecia or telogen effluvium. We will try to differentiate whether the regular telogen effluvium and the post-COVID telogen effluvium are same, or is it a new entity which is coming up, and it's how challenging for us to counsel the patient and to manage these kind of cases are. And COVID has done one very interesting thing in between so many plethora of, I'll say, the bad news which we heard last year, and along with this, one thing which it compelled the, I'll say, the public to understand the dermatologists are the real trichologists. So this is what good thing has happened with post-COVID telogen effluvium or the hair loss which we are encountering in our day-to-day practice. It's not working. Where is the, oh, sorry. So, you know me now. I won't get into this. I am confused when I am moderating a session what to ask, what to leave. But with this, I like to introduce my eminent panelist, Dr. Vijay Jawar, who is currently President-elect. Does not require any introduction. And sir, I congratulate you for the thumping victory. On behalf of all, please give him a big hand. And he has known for his excellence in academic dermatology, which you have already witnessed in the previous lecture, the skin manifestation during the COVID and the post-COVID scenario. Then Dr. Padmavati Surapaneni, or Dr. Padmavati, is known to be, I'll invite you, please come on the dais, Dr. Padmavati. Dr. Padmavati belongs to Hyderabad. You all know that she is director and the owner of Pragna Hospitals, if I'm not wrong, and she is known for his excellence in aesthetic dermatology, be it facial contouring to body contouring to Botox to fillers to lasers. So I invite Dr. Padma. Our next panelist is Dr. C. Uma. I'll try to pronounce the name rightly. It's Uma Chakravadhanula, if I'm right. It's Uma Chakravadhanula. So she is consultant dermatologist with IDEA Clinic, Institute of Diabetes, Endocrinology and Adiposity Private. Publications are publication in PubMed, conducted clinical trials in chronic idiopathic urticaria as primary investigator. She has paper presentation on biological and palmoplantar psoriasis in Dermacon, Kolkata, January 2017, paper and poster presentation in biological in palmoplantar psoriasis in Gene to Clinic International Psoriasis Conference. She has multiple award honors and achievements. Her area of interest is psoriasis, urticaria, and she is interested in conducting patient awareness programs at community levels and educating people in preventive health. So our next panelist is Dr. B.Y. Praveen Kumar. I'll invite you to be on the dais, sir. He is consultant dermatologist in Glen Eagles Global Aware Hospitals, ex-faculty Prathima Institute of Medical Sciences, Deccan College of Medical Sciences. He's speaker and panel member in various journal level CME state conferences. His area of interest is dermoscopy, dermatopathology, trichology, clinical dermatology. So with this, I invite you all to be a part of this panel, which will be a challenging one in terms of, because this is a new entity. See, there are not much of guidelines which we have to treat post-COVID hair loss. So I won't get into this, what diffuse hair loss is, but there's a major challenge always clinically to differentiate between telogen effluvium versus female pattern hair loss or chronic telogen effluvium. This term telogen effluvium was coined by Kligman, which we all know in 1961, to describe the state of increased shedding of otherwise normal telogen hairs. Primary, secondary, we know rest of the things. In 33% cases, no trigger can be identified. Functional mechanism of the shedding is immediate anagen release. And this usually resolves in 3 to 6 months, which we all know. But is it different with the post-COVID hair loss? We need to discuss with our panelists. So coming on to this, the important points in management of diffuse hair loss is etiopathogenesis of hair loss, the trigger. Clinical signs and symptoms associated with hair loss that can differentiate with the entity. Diagnostic modalities needed to diagnose the type of hair loss. Most of the time it's clinical, I'll say 99% times. Therapeutic option needed to be considered. There are many now, and every day you're getting a new agent in the list. Importance of patient compliance in the treatment of hair loss, which I think is the most important one. So with this, I'll thank Dr. Bhumesh Kumar. He has given me this duty to just inform you all that next week, or the 3rd, 4th, 5th, SARKD is organizing a conference, Dialogue in Clinical Dermatology, which is World Congress. And for CUTICON, Telangana delegates, the registration fee is just 7,000 for next 2 days during the conference days, which is otherwise 25,000. So post-COVID alopecia, I'll start with Dr. Padmavati. Is it different from regular telogen effluvium? Do you think clinically this hair loss is different? If it is different, what different exactly it is?
So I think post-COVID telogen effluvium is more severe, and the amount of hair fall, the hair shedding is more in chronic telogen, acute telogen effluvium post-COVID. And also the onset of symptoms are also a bit earlier than the regular telogen effluvium. If you have other factors of telogen effluvium like a dengue or typhoid or any major stress in the family, it may take like 2 to 3 months for the patient to start telogen effluvium, but we see in post-COVID era, within a month or 1.5, the patient is coming with a severe hair loss.
Okay, so you think it's delayed than the regular telogen effluvium?
It's earlier than the regular telogen effluvium.
Because many a times we are seeing patient comes and says, I had COVID in April, now I am having a diffuse hair loss. Say in the month of November, December, it's almost after 6 months.
So maybe that is with the stress, but the people who have an acute symptoms of COVID, we are seeing that telogen effluvium is coming more earlier, and then the amount of hair loss is also more. If there is this type of asymptomatic infections, then maybe we are seeing it is a bit late, and then in a COVID era, the telogen effluvium we are seeing not only in the infected patients but in the family members also, maybe because of the stress and strain they are going through all this pandemic, and then maybe the financial losses, the loss of jobs and all.
So, Vijay sir, I have a question for you.
Yeah.
Do you think that those who have suffered with severe COVID and treated with high-dose steroids and other immunomodulators, do they suffer more severe loss as compared to the normal COVID, those who
Yes, your observation is correct. Your observation is correct. But only thing is, they are not telogen effluvium as such. Drug-induced alopecia probably complicates the issue of hair loss in patients of COVID-19.
Okay, it's a double-edged sword, telogen effluvium plus drug-induced hair loss also,
Yes.
which is what the normally experts say. With high-dose steroid and COVID telogen effluvium in last 6 months. Do you think that number has increased? Now
Yeah,
we have become more trichologists than dermatologists in last 6 months?
Yeah, sir, definitely trichology cases or telogen effluvium cases per se have increased, and when inquired into, at least 40 to 50% have suffered COVID. Sir, if you permit me, just in the last question, I would like to invite your attention to an article which has stressed upon both the drug-induced and also the post-COVID. But they suggest, because the incidence of the hair fall has started only after 50 to 60 days after COVID infection, so that may not be related to the drug influence per se as such, because any drug-induced telogen effluvium would again come into 3 months period. But whereas here in viral post-COVID telogen effluvium, it is occurring a bit earlier. So chronologically, probably whatever telogen effluvium we are seeing in more severe patients, because there is high CRP, there is high inflammation, high inflammatory markers. So they all constitute per se to the death of the hair follicle, to the death of the, to pushing the hair follicles into their telogen phase.
I'll add to one more clinical paper is there in which it says that with high dose steroid, the effect lasts for the next 4 to 6 months. Yeah. See, this during the COVID. So that's what is adding to the delayed hair loss post-COVID. This is one thing which we have to understand. Now, Dr. Oma, the question is, see, there are many a times patient will come and they'll say that there is no trigger to this diffuse hair loss, but they'll give history. When you interview, then they'll come to the conclusion that yes, somebody in the family or the many family members had COVID during that time, but they were RT-PCR negative, they were not diagnosed, they didn't have any symptom. So are we making a retrospective diagnosis of COVID now, because are we relating it to the COVID, or it's a different entity now?
Even though they are not RT-PCR positive, what you are saying?
See, there are subset of patient in which there is no history of COVID, but in the family there is history of COVID.
Yeah,
there are many. They'll say yes, my brother had, my mother had, or my father had, but when I was investigated, my RT-PCR was negative. So do we tell that maybe you had COVID that time? What conclusion you make with this?
Yeah, even though it is negative, maybe they suffered asymptomatic, maybe with the no symptoms, maybe RT-PCR may be negative, but they suffered little about the COVID. So that is one thing. Another thing is because of family members, they suffered with the COVID, the stress also factors that also can cause the hair loss.
I agree with this.
Yes.
Actually, stress was one important factor behind the sudden onset of hair loss in multiple family members.
Yes, I agree.
That is one thing. Another thing is early onset telogen is also there, but long also we are seeing. The long COVID syndrome, we are stretching more than 6 months, 6 to 9 months also. So people are experiencing hair loss more than 9 months also, affecting last year, and still the hair loss is there. That has not been controlled with whatever medications we give, and that is also we are observing.
A final question regarding the last slide.
Yeah.
Actually, there are multiple systemic comorbidities occurring post-COVID, and probably that has added to the hair loss.
Yes.
Sir, is this telogen effluvium a prolonged telogen effluvium post-COVID? Yes. This is what I want to ask with you also and with the audience also, with the reason being this is a new entity for us. Because normally what we say, your hair loss will be controlled in next 3 to 6 months or next 3 to 4 months. But what we are seeing sometimes it's going beyond 6 months also. What the hair loss started in April, May, and then now still they are saying, yes, doctor, it's under control, but still a lot of hair I'm seeing shedding down.
Yes.
So this is one observation which we all have seen in last 6 months. So coming to Dr. Praveen. What are the cardinal questions that should be asked to patient with DHL? What are the questions generally you ask when you see a patient of diffuse hair loss, be it post-COVID, be it any other trigger?
Usually, just like in any case of telogen effluvium, sir, we have to rule out the other causes of telogen effluvium, or is it per se telogen effluvium or anything other than that? So the duration of hair loss, the amount of hair loss, and pertaining to history within the 6 months period regarding any vitamin deficiencies, sun exposure, drug history, viral infections, psychological or emotional stress, and physiological stress factors such as viral infections and surgeries, all these things, hormonal imbalances, we would go into that. And per se, sometimes I try to ask the questions of, is there just hair thinning or hair fall as such?
Okay.
Then we try to go for the clinical examination. In drug history, sir, mainly in case of COVID, there is history of, as you said, excess amount of steroids, sometimes heparinoids. They are also known to cause telogen effluvium, and they may be with several other drugs, such as comorbidities, diabetes, hypertension, or other thing, where they may also amount to this, and we have to rule out definitely all other nutritional deficiencies, etc.
Agree. Well summarized, Dr. Praveen. There's one thing which I would like to ask again. How do you quantify the hair loss? That it's telogen effluvium. How do you ask the numbers, and how do you certain it it's more than 100 or less than 100, and whether it's diffuse or not?
Yeah, sir. So usually they themselves, patient themselves, sometimes they carry lumps of hair that every day when I try to take bath, earlier it was not there. Now I get this much of clump of hair. So I try to just amount them, whether it was the same earlier and whether it is the same now, or else is it increased? And if it is so, in what duration? And the amount of hair, usually that will try to give approximate number of this.
Fair enough. So my general questions are, when you wake up, you see a lot of hair lying here, there on the pillow bed. Then when you comb it, whether it comes in bunches, it comes in strands. When you wash, it goes down the drain in bunches or strands. These are the normal questions which quantify the number of clinically the number of hairs. So we know about everything has been summarized well by Dr. Praveen. Duration, there is one important history which we always get. The change of residence makes a difference, change of water makes a
hard water, sometimes we feel like, there is a hair fall. I don't know the scientific evidence behind that, but yes, we see. But when we ask them to use those softeners and then change the water, they feel like, the reduction in hair fall and change of place. Not only the stress of change, and then change of their diet and their lifestyle can make a difference and cause a acute telogen effluvium sometimes.
Everyone will agree that it's always for short term, these kind of complaints, be it change of residence, be it change of water. Is it for short term hair loss? Is it something like, say, for a month, for 15 days? Or does it go like telogen effluvium for 6 months, 3 months?
Yeah, there are a lot of acute telogen effluvium when they change the place, and then change of water, sometimes it may prolong. But in these cases, I think it's not only the stress or water, we have to dig into it if they have any deficiencies or their dietary deficiencies. That is one thing. And if they have any chronic illnesses which they have precipitated when they change the place because of the stress, like autoimmune diseases, all this, I think if anybody have a telogen more than 6 months, I think we have to definitely think it's not only stress, we have to see any underlying condition. Definitely.
Agree. So one important point, initiation and withdrawal of minoxidil therapy or oral contraceptive pills has to be asked, because either way they can cause diffuse hair loss. Dr. Praveen was about to make some point, please, and make it short and crisp, please.
Pardon, sir? I didn't get you.
You were saying something, please.
Yes. Earlier, sir.
Yeah.
Actually, when you said shifting from water and place, here in Urdu, in Hyderabad, there is a saying of abo hawa. So abo hawa mein farak hota hai. Actually, the thing is, it is not in the water or in the air, but because you have moved from one place to the other, the stress prevails on your mind. That itself may induce telogen.
With this dialogue, I remember a very famous dialogue during old Bollywood movies. इनको पहाड़ों में ले जाइए, इनकी आबो हवा बदलिए, ठीक हो जाएंगे. So this is what you were saying. I got it finally. So both hyperthyroidism and hypothyroidism.
Jokes apart, actually, sorry for interrupting. One of the Australian authors, they conducted a study on hardness of water and exacerbation of cutaneous diseases. So they found out that hard water is associated with exacerbation of atopic dermatitis as well as the hair loss because of roughening of the cuticles, what they have mentioned.
Agree, sir. So now the frequently asked questions by patient with diffuse hair loss or telogen effluvium, which every day we are getting these questions. How do we answer it? Because this is kind of, I'll say, the practice management questions also, and very, very practical. This, what are the politically correct and logical answer to the patient frequently asked question? Something like, how much time will it take for my hair loss to stop? Now, related to this, pertaining to this post-COVID hair loss, how do you answer that? It can be the same question, will my lost hair grow back? So Dr. Oma, will you take this question, please?
So this is
Either of this.
Yeah.
These are the questions which are generally asked. How much time will it take for my hair loss to stop?
Yeah, as the hair cycle is 2 months, normally I tell the patients at least you have to wait for 2 months to recover. Whatever the medication or whatever the treatment we start, at least you have to wait for 2 months to recover your thing. That I suggest first.
Timeline is important.
Yeah.
Generally, we quote timeline when we are. This is the only thing which entitles us as a dermatologist, trichologist to quote timeline, because we are aware most of the time, in 96% cases, this timeline, this telogen effluvium honors the timeline. This is what I always say.
Yes.
Timeline is very, very important how to answer this.
But for the
yes.
given patient, we do not know how long lasting telogen effluvium would be. So politically it will be correct
Yeah.
for the patient. I tell this way that see, you are asking a specific question, how much time it will take for you to recover all my hair loss. So I tell them that this is not dependent on doctor or the medications, but the immunological system disturbance that has to recover from your own body. So how fast you recover from that immunological insult is more important than what the drugs and doctor can do for you. And that probably convinces patient most of the times.
So this is one entity which gives you confidence to quote time actually, as compared to any other dermatological disorder. If it is telogen effluvium, most of the time a doctor can be right. This is one entity which gives you maximum credit. When you are treating a patient, you know that yes, we can. This is going to be recovered. This is other as compared to all other dermatological disorders. So will my lost hair grow back? Yes, normally we say it takes 6 to 8 months. It's true with the post-COVID hair loss also. You all agree with this? Just yes or no?
Yes, sir.
Okay. And then comes, doc, by this speed I might become bald very soon. How do you answer this? Dr. Praveen, you have mic. Please continue.
Sir, I would say that in telogen effluvium, all the hair has died because of the stress.
Patient does not know it's telogen effluvium.
No, sir.
This is a question from patient.
No. I will tell them that this is all because of COVID and they have died. सब लाश है, मर गए, फिर जिंदा होएंगे. अब फिर जिंदा होके बढ़ने के लिए थोड़ा टाइम लगेगा.
कितना टाइम? This is what they ask.
Can I answer?
6 महीने, 8 महीने.
No, I keep on telling them, if they are not adequately convinced or if the stress of the patient is too much, then I sometimes tell them that see, we do trichoscopy, see the hair roots are intact. So that is a clear indication that you are going to get your hair back.
I'll come on that, sir.
So then patient gets convinced.
Normally what we say...
How I counsel is telogen effluvium is nothing but hair shedding. They are not losing hair because the body has gone through some stress, which the hair follicle is not an exception. So they are shedding the hair and the hair will come back. If you say that, I think they'll be happy, and then Google also helps them to read that, like, telogen effluvium is a hair shedding, it's not hair lost. And other thing is, coming to the timeline, how I counsel them is, maybe the hair cycle to revert back, if everything was corrected, takes 2 months. And for you to get back your lost volume, it takes another 2 to 3 months. So your hair fall treatment should be at least 4 to 6 months for you to see that your hair is grown back or you're comfortable. And if you give them that much 4 to 6 months timeline, everybody will stick on to the treatment,
Yes.
apply the minoxidil, and then they'll get back to normal.
Timeline is very important for compliance actually. So this is normally I say कि जितने जा रहे हैं उससे ज़्यादा आ रहे हैं, चिंता मत करो, and next 6 months you will be okay. There's one line saves everything. Now there are subset of patients in which we go for a lot of investigations also, because the primary thing which we do when we say this amount of hair loss, or we diagnose the case as a telogen effluvium, There are a battery of tests which we'll discuss, but most of the times we see that the tests are either the serum ferritin is low, minor, or maybe hemoglobin, or maybe anything, but there is no I'll say any thing which is favoring your diagnosis in terms to the patient. They are saying everything is normal, फिर क्यों हो रहा है? So how do you answer that? All my investigations are normal, why this telogen effluvium? You will get this subset of patient and they ask the questions. So how do you answer that? I'll ask Vijay sir.
Yeah.
Just to you. This question is just to you, sir. You are the senior most. We'll learn a lot from you.
Can you please repeat it?
Achha.
All investigations are normal. Then why this hair loss?
Can you repeat the question, sir? फिर से बताता हूँ मैं आपको, sir. There are many there is subset of patient in which we go for investigation, but there is no obvious finding in that. And they say my all investigations are normal. Then what do you do? How do you counsel them?
ये सिस्टम में abnormality नहीं है, ये आपकी इन्वेस्टिगेशन बता रहे हैं. That is what I tell the patients. कि investigation tell us that your hemoglobin levels, our other counts and other systemic parameters are normal. But the hair loss is because of the acute insult that has happened to you. And in fact, it is good that rather than affecting the other important organs in the body, it has affected your hair. That is what I keep on telling the patient.
That's it.
One thing is I can tell, because hair is the most last part to get the blood supply, so that first thing, whenever there is a stress or anything, first to lose your hair. So you have to wait for some more time for the diet, improve the diet and all that, then it will definitely improve. Because people will think they don't concentrate on the diet and all that, they just come and they just taking one pill, everything will be corrected. That is not the thing. So you have to concentrate on your diet and stress levels and all that. That is more important than what the treatment we give.
Dr. Padma, so quickly, how do you advise on diet? Many a times patient will ask what diet I should take.
So diet for hair, I say it should be a balanced diet, high in protein, and then they have to take fresh fruits and vegetables for their vitamins and mineral content, and dry fruits and nuts. And I advise most of my young patients they should not skip their meal.
Do you ask, are you vegetarian or non-vegetarian?
I definitely ask. If I don't ask also, they'll tell me. If you give a supplement, give me that it have a green dot. So I have to have a list of protein, which vegetarian protein and the non-vegetarian protein.
Why I asked, reason being, for vegetarian what diet you advise, for non-vegetarian what kind of diet you advise? Because as we know that vitamin B12 is one of the, now we are getting to know more, that is one of the bigger causes for diffuse hair loss.
Yeah.
So do you advise those kind of diet, say something diet rich in vitamin C, vitamin B12 or any other micronutrients?
So I specifically tell them if there are vegetarians, you have to add more sprouts, almonds, and then olive oil and all, which contains more of vitamins, minerals and B12. I think if they start on a balanced diet, that would be okay. But in all of my patients, apart from the diet, I like giving a supplements, which most of the doctors nowadays, they say no need, because they lost the hair in telogen effluvium and then they need an extra supplement for the hair, regrowing hair.
Incidentally, I remember one of my patients.
Yes, sir.
Post-COVID, he felt he was feeling very weak. So doctor asked him to take the protein supplements because of the hair loss. And he started eating too many eggs. And because of, the hair loss actually worsened there rather than improving.
I agree, sir. Now this is one question which most of the female do ask. Can I use hair color? Just yes or no? A message to the audience. I'll start from Praveen.
Sir, I say them, you
yes
can
or
use,
no? Yes or no? No,
yes,
no,
you can use
no
hair
Kani.
color.
Yes or no?
Yes.
They can do hair color.
Yes.
Sir.
Yes.
And any with caution or something? Nothing.
No, not particularly.
I'm talking about during telogen effluvium when they are losing hundreds of hair per day. How do you counsel them? Do you allow them to use hair color? Achha, Dr. Padma.
Yes.
Yes.
If they don't color, they lose more because stress will be more.
No, sir. No. I say no.
Why?
So
That's what I want to know. Why no? For others, see, all three panelists, the hair color is a stress buster. for the female patient. They color hair, they feel happy, so they don't think about hair loss. This is what the message they are giving. But for you, you have said no. Why no?
Why no? Because if at all any allergies, if they have anything, so that may develop any reactions, and that itself can increase the hair loss. That is one thing.
Agree. That's had been proven actually. This is what, but it depends. It depends. See, it depends on
Rather than density, they are more worried about the hair color.
See, that's a very tricky question. That's what it varies from, I'd say, dermatologist to dermatologist. You think, and then what kind of patient are you treating? We generally see how psychologically disturbed the female is. If you're allowing her to apply color, maybe after a few days, if she see the increase in number, कहेंगे सर आपसे तो पूछा था हमारा तो और बढ़ गया. So this is how we get patients also. So not an issue. Like coming on to these investigations, I think this is one of the most focused and the most important slide of this panel discussion. And I'll ask just one panelist, and that is Dr. Uma. On investigations, you have to just one by one summarize these questions, then we'll go on to the next question. And if anybody else want to add any other thing, they can chip in anytime.
The routine investigations like serum ferritin is very important, the stored iron, and vitamin B12, vitamin D. And you can share the link. Normally, I also do the liver function test also. So why the liver function? Because most of the people now they are having more of even though they are not deficient with the any vitamins or anything, most of the people they are observing more of absorption disorders and digestion problems. I do ask every patient about what about your digestion like, and what is the absorption we don't ask, but the digestion like. Are they having any acidity and all that? That time normally.
Can I restructure the questions, please, ma'am, rather than getting so deep? The main investigation, the primary investigation, which you first write on your left side of the prescription. This is what I want to know.
Yeah, LFT I do because I just want to see what are the any elevations and liver is correct or not. That is the LFT is a compulsory I do. Vitamin B12, vitamin D, serum ferritin. These are the normal routine investigation. Apart from that, if they have any additional underlying factors like PCOS or anything, that additionally we do the things, and any underlying problems like diabetes or any other metabolic disorders, that also we see they are correct or not.
One thing I'm missing, that is thyroid.
Hypothyroid and all. Hypothyroid.
I make it a point to investigate the patient, to investigate for the hypothyroidism. Post-COVID hypothyroidism, I don't know how many of you agree, but I have seen more post-COVID hypothyroidism than the routine OPD patient. Hypothyroidism is common post-COVID.
Actually, do you investigate in each and every patient, or you see, suppose the case of telogen effluvium is there, we know that in 3 to 6 months is going to be normal?
Hypothyroid, TSH is a basic screening for me.
Okay. I mean to say, in each and every case of diffuse hair loss or telogen effluvium, do we investigate or do some clinical findings and then you investigate?
Generally, patients have already investigated before coming to me, but if
they are not investigated, will you like to investigate each and every patient?
Yeah, I like to add thyroid function test.
A basic hair profile is something like hemoglobin, serum ferritin, vitamin B12, vitamin D, maybe zinc, thyroid profile. Then you see hyperandrogenism. Then you have to rule out PCOS if the other symptoms are. This is what the basic I understand. Then there are advanced investigations. There is battery of tests then. So, does the result of investigation change our treatment plan, Dr. Padma? Just in one line, yes or no?
Definitely yes. If there is a positive deficiencies, we will add, thyroid will add, and as you rightly said, like PCOS is one thing. If a young lady comes, maybe telogen effluvium will be precipitating their female pattern alopecia. So if that comes positive, then yes, for that also we need to change our plan.
Most of the time we start with either there is I'll say combination of so many nutrients. Already whatever the deficiency is this, you are giving it. So does it change?
But still yes.
Suppose something like we are giving cyclical therapy, it has everything.
Yeah, cyclical therapy will be a daily supplement, like daily requirement, but there is a deficiency, I'll definitely increase the correcting dose of the specific vitamin.
To calm the anxiety of the patient.
Yes, that's why it's required, should be done. And this one test which is important is anti-Mullerian hormone, may be an indicator, and testosterone levels may be checked in mixed alopecia. Advanced test to rule out autoimmune diseases, but generally we don't do it because the clinical symptoms are more pronounced. So which clinical test you do commonly to confirm the diagnosis? Just one, Dr. Praveen.
Sir, the moment the patient tries to present with these symptoms, we do hair pull test. And prior to hair pull test also, we ask them whether they have taken head bath or when did they comb the hair.
Mm-hmm.
Second, a phototrichogram, which is TDL, but still it can help. Then third thing I would do is trichoscopy to rule out other possibilities. And overlap of AGA, female pattern or male pattern alopecia, which can become predominant. And in case of trichoscopy, the presence of short recurring hairs, the presence of white dots, the presence of coiled hairs, they all suggest some vitamin deficiencies or nutritional malnutrition.
Okay, there are other methods also. Trichoscopy we have already discussed. Does it play any role in aiding the diagnosis, treatment and prognosis of telogen effluvium? Because you are doing it regularly, please do.
Sir. In telogen effluvium, acute telogen effluvium, we don't actually see much change in case of acute telogen effluvium. But suppose it has been delayed, there can be short regrowing hairs and white hairs, which are white dots, which may be present. But occasionally, when it is overlapped with androgenetic alopecias, peripilar halos or diversity of the hair changes can be seen. Sometimes when there is a chronic telogen effluvium overlapped with iron deficiencies, we may see coiled hairs, etc.
And most importantly, anagen hair loss is seen in the post-COVID drug-induced.
Yes, agree. That I mentioned right at the beginning, sir. So should medical treatment be prescribed, or does it have any significant influence on diffuse hair loss, telogen effluvium once you diagnose it, once you know that in next 2 to 3 months everything is going to be absolutely normal? This is non-COVID hair loss I am asking. So if you diagnose a case of telogen effluvium, so does medical treatment is required? Why should we give it?
By experience, I found that, sir, though there is lack of literature, I find that hair supplementation with vitamins definitely have a role to play in hair growth, because several cases where we try to reassure the patient that hair would regrow, probably we all have, or probably many of the patients we see have a subclinical deficiencies or subclinical deficient reach of the nutrients to the hair.
Now coming on to very this burning question, lot of things we are discussing about minoxidil in this forum also, and now the newer minoxidil is there, acetosomal minoxidil. So your take on minoxidil in telogen effluvium, should we use it, should we not? Yes or no, that's it.
I don't use in acute telogen effluvium.
Dr. Vijay sir.
Not in acute, but
Yes.
in chronic, non-responsive, then I...
Chronic. Okay, to acute nobody of us are using in acute. This is one message. To be prescribed or not in women with diffuse hair loss, say it's chronic telogen effluvium, and what percentage? So Dr. Padma.
So in men or women, I take the same. Like if it is a telogen effluvium acute, I don't use minoxidil, and if it is going to be chronic, I do.
Dr. Oma, advantage of cetosomal minoxidil over conventional minoxidil. Do you find any advantage or not? Or they are same?
We just started using cytosomal.
Achha.
Maybe it is little more per se, maybe I don't have much experience, but maybe from last 4 months I've just started.
They
So
say
it
that
is,
bilipid layer of the
they
molecule
say something,
has
but
got deeper
as a
penetration.
patient, I
that is
don't
what company
think,
claims. I
Yeah,
am not
company
sure
claims
how.
that, yes.
Agree.
It's okay. So feel is that something has benefited.
We are done,
Ah,
sir.
that irritation
think
part
3
has
minutes.
reduced most of the things.
The advantage is better patient compliance and better penetration and efficacy. This is what the company claims. We are still, it's an early phase. Maybe after a year or so we can comment a little better on this. So again, this slide is there. This is on the instructions of Dr. Bhumesh, the organizing secretary of this conference. He has announced that there will be special registration fee for the CUTICON Telangana delegates. This is 7,000 rupees. And there is a specific DICD 2022 stall on 25th and 26th December. You can go there and get yourself registered. And where there is a live cadaveric workshop, hands-on workshop, and the newer aesthetic innovations in aesthetic dermatology. Now the role of nutritional supplements, biotin, We have already discussed about it, Dr. Praveen. You were mentioning this. Biotin is useful at RDA limits of 30 microgram in nutrition supplements. But there is no evidence to suggest that additional biotin over recommended daily allowance is useful in hair loss until the patient is deficient in biotin. So this is what it's sufficient to use biotin in each and every patient. But I don't think there's not fun to use it, and there's not proven as such. So consensus recommendation is saw palmetto is thought to have similar effect, but there are so many new things, grave tea regress, cyclical therapy. So you want to add something, please?
One anecdotal experience I can add. One doctor I was treating, and she was prescribed biotin. She felt biotin is the only drug every dermatologist is giving. So with the low doses of biotin, she was not responding. She started taking 2 TID for a month or so, and she landed up in a frank hypothyroidism. And then I later on came to know that this is a high excessive biotin levels in the body is associated with hypothyroidism. So even for the medical patients, you must inform them that don't overdo it.
Now this is a rapid fire question round, sir. I'll start with Dr. Praveen. Use of finasteride in women, do you use it? Yes or no?
No.
Okay, great. Pass it on to Dr. Vijay. Sir, oral minoxidil used in diffuse hair loss in women in telogen effluvium. Do you use it or no?
No experience, sir.
Dr. Padma.
This
oral minoxidil again.
Yeah, I started using when the patients
In
are
what
not
dose?
complaint or they are not responding to topical minoxidil.
Okay. Dr. Uma, are you using oral minoxidil in case of telogen effluvium?
No, not yet. I have not started any movement.
Chale, so I'll ask on. There are so many. There is side effect profile also. There's period edema,
Said
then
it
headache.
is
A
in
lot of things
diffuse
are
hair
there.
loss, not telogen effluvium, right?
Proper evaluation is required, and need to check whether the patient is hypertensive or not. A lot of things in there. Then chronic telogen effluvium in young girl and 35 to 40 years of women. Does your plan changes or any specific treatment plans, Dr. Vijay sir?
I don't think the plan should change. It remains the same.
Any specific plan which you will change, or it will remain the same? But this is what
specific treatment change.
I am not able to get it, sir. Not audible. Plan will change or plan won't change?
No, it doesn't change the plan. I'll treat the same way. Actually, telogen effluvium is something where patient assurance is more important than the unless there are some additional factors causing hair loss.
Okay, sir. And Dr. Uma, the final question. Oral spironolactone and diffuse hair loss in women. Do you use it or not? If you use it, what's your experience and what dose you use it?
Only when there is an indication. Otherwise, routinely I don't use oral spironolactone for the diffuse hair loss.
Not get. So
No.
can you please repeat the answer, please?
Associated with polycystic, or we have any other?
Agree. Role of peptides, Procapil, Capexil, etc. Your preference and why? Or these are just stress busters, Dr. Padma. These are just stress busters. Or
So
for the
in
doctors?
telogen effluvium, I
We
do
have-
give peptides, but I'm not a good fan of Procapil or Capexil. I like Aminaxil and then Redensil.
So this is
They
the final
really work.
question, a final word by you or all. An ideal prescription for telogen effluvium, your preferences, how do you start your prescription? What exactly, it's just 3-4 things when you write on the prescription in a telogen effluvium, what are the constituents exactly? I'll start with Dr. Uma.
The first, my preference is the diet.
Diet.
And reducing the stress levels, proper balance, that is balance in
I'm
nutrition,
talking-
good
this
sleep.
This is counseling, ma'am. I'm talking
Yeah,
about
that is the-
prescription.
Okay. If there are no other deficiencies or anything, just giving a supplement and counsel the patient, wait for
Supplement.
2 to 4
Like
months.
counseling, we understand.
Yeah,
Do you
2
give
to 4.
supplement? Do you give peptide? Do you give anything on the prescription? You say that everything will be normal in 4 to 6 months.
No, giving a supplement and wait for 2 months. Then,
Dr. Padma.
yeah.
Your punchlines. How do you treat punchlines when you talk?
Telogen effluvium is, I already mentioned, it's hair shedding. You're not losing your hair. You're not, in hormonal thing, you lose hair, but this is shedding, and you'll get back your hair. Relieve your stress, eat healthy, you'll be back to normal.
Acha.
I tell the patient you are lucky because your hair loss is because of telogen effluvium rather than any other scalp disease.
discussed this. So it's counseling, which is to maximize the patient compliance with this. You have concluding remarks. If you want to say anything about telogen effluent, you have to give any message, take-home message to the audience. Just one line, anybody can take this. Just a message to the audience, what is the final take-home message to treat telogen effluent, sir?
So to conclude, telogen effluent is a common presentation, especially in this COVID pandemic. What patients need is investigation for associated abnormalities in the systems, if it is there, or associated vitamin, multivitamin or iron deficiencies, if they are associated. If not, then it is easy to treat and easy to predict the improvement of telogen.
Easy to treat and easy to predict. This is
Am I right?
good.
Am I right? Do you
Easy
agree
to
with
treat,
this?
easy to predict. Okay. Thank you very much. With this, I thanks to the patient audience and thanks to the warm panelist. Please give them a big round of applause. Thank you very much.
I thank Dr. Neeraj Pandey and his team for interesting discussion. I thank organizers for giving me the opportunity to chair the session. Thank you.
I request all the panelists and the moderator to please assemble at the photo booth. I now request our next session chairpersons, Dr. Ramchandra Tarak sir and Dr. Sudhavani madam, to kindly continue the second session, which is on papillosquamous disorders. Good morning, all.
Good morning, all. Now we move quickly to the next session, that is papillosquamous disorders. So now I invite Dr. Purna Chandra to talk on how I manage generalized lichen planus.
Here it is not coming.
Dr. B. Purna Chandra, I am requesting.
ఇక్కడ రావట్లేదు కదా. I can take my laptop, no? If I click, I keep the laptop. Here it is not coming. So I can keep my laptop, no? No, I cannot just turn and there are so many things I have to explain. Yeah. Yeah, please. This will sync here, no? That will sync. Management. Yeah. Slideshow. Shall I start?
Please start the session.
So, respected chairpersons and my dear friends, a very pleasant good morning to all of you. On the outset, I thank the management TS IADVL for giving me an opportunity to speak on this occasion. So my topic today is management of lichen planus. So there are not many studies on the management of lichen planus. So whatever the studies I could get, I summarized and presented here. Coming to the introduction. So lichen planus, it is a chronic inflammatory and immune-mediated disease of stratified squamous epithelia affecting the skin, hair, nails and mucous membranes. So lichen planus, it is derived from the Greek word lichen, which means to lick or what eats around itself, and it is the Latin word planus meaning flat. So the etiology is complex and multifactorial. Coming to the epidemiology, the incidence is 0.14 to 1.27% of the general population, and prevalence of oral lichen planus is 1.5%. And most oftenly it affects the middle-aged adults, that is around perimenopausal women, and it is rare in children. There is no sexual or racial predilection is noted, but in patients with oral lichen planus, females are more commonly affected than males. Coming to the etiopathogenesis, so it is not much understood. It is complex and multifactorial. There are some theories that are put forward, that is basically it is a T-cell mediated immune disease, and humoral immunity, it plays a minor role. So it doesn't have much effect on lichen planus. And there is racial predilection is also noted. There are some few haplotypes associated with lichen planus, that is HLA, A3 and A5. And there is the pathogenesis, it is briefly, it is summarized in 3 steps. That is, one is antigen recognition, there is lymphocyte activation is there, and keratinocyte apoptosis. So in the antigen recognition, there are mainly self-antigens are there, self-reactive antigens that are present on the keratinocytes. That explains the pathogenesis of autoimmunity. That is, basically lichen planus is considered to be an autoimmune disease. There is self-reactive autoantigens that are present on the keratinocytes that are recognized by the CD8 cells on the lesional skin of the lichen planus. So sometimes there may not be always self-directed antigens, but there may be drugs also, contact sensitizers in case of oral lichen planus, that is dental restorative materials, sometimes hepatitis C virus or hepatitis B vaccination. So these autoreactive antigens, they release associated with MHC class 1. They release interferon gamma and tumor necrotic factor alpha, and they also stimulate CD4 and CD8 cells along with MHC class 2, and they localize the Langerhans cells and other dendritic cells to produce interferon gamma. So once there is antigen recognition is there, so there is lymphocyte activation. So after there is lymphocyte activation is there. After oligoclonal expansion, there is once the oligoclonal expansion of CD4 and CD8 cells are there, and they produce interferon 2, interferon 4, 10, interleukin 2, that is cytokines, interferon gamma and tumor necrotic factor alpha, which are important in the pathogenesis of, that is, keratinocyte apoptosis. So why I am going through the pathogenesis means many of the drugs, they act here. So without knowing the pathogenesis, probably we may not know the mechanism of action of the drugs where they act. So next, coming to keratinocyte apoptosis. So once the exact mechanism of keratinocyte apoptosis is not known, but some theories are put forward, that is the tumor necrotic factor alpha that is produced by the T lymphocytes, it interacts with the tumor necrotic factor alpha receptor that is present on the keratinocytes and causing apoptosis. Second one is there is granzyme B that is produced by the T lymphocytes that causes keratinocyte apoptosis. And one more theory is FAS-L ligand that is present on the lymphocytes. It interacts with the FAS ligand that is present on the keratinocytes that causes keratinocyte apoptosis. So coming to the disease association, so though lichen planus is, since lichen planus is an autoimmune disease, it is associated with other autoimmune disorders like hypothyroidism, especially in oral lichen planus, and there are diseases, it is associated with diseases of So diseases associated with other autoimmunity, that is alopecia areata, ulcerative colitis, vitiligo, morphia, lichen sclerosis, etc. One more thing is it may be associated with other dyslipidemias. That is, high lipid levels may be associated with lichen planus, though it is not almost neglected disease. We don't do much investigations in lichen planus, unlike psoriasis. But here also there is dyslipidemia, so it becomes mandatory for us to, in case of specially generalized lichen planus, to rule out dyslipidemias and to rule out the risk for the cardiovascular risk in patients with lichen planus. And it is associated with even infections like hepatitis B, hepatitis C virus. And hepatitis C virus, there are some studies telling that there is not much association and it is mainly geographically dependent. So geographically dependent meaning patients who are coming, that is where the endemicity is more, especially in Middle East, Africa and Asian countries, routinely we have to do hepatitis. Coming to the clinical variants, I am skipping this. So complications, there are many clinical variants, probably might be knowing. Complications, there are acute complications, chronic complications. Acute complications, it is mainly itching. So the patient will have some disturbances of sleep. And if in case of oral lichen planus, sometimes it is usually asymptomatic, but most of the times it is associated, if it is involving the, if it is erosive lichen planus, it causes difficulty in swallowing. And there are chronic complications like after once the disease is under remission, it causes post-inflammatory hyperpigmentation, which is a cosmetic concern. And oral ulceration, it leads to scarring in the mouth. And there is alopecia, scarring alopecia is present. And nail loss may be present. And cancer. Cancer risk is most common with hypertrophic lesions and often with ulcerative variant of lichen planus. And it is usually it is considered as 1% chances of turning into squamous cell carcinoma is there in the literature. And there are systemic complications are there. As per se, lichen planus, they don't cause any systemic complications. It is mainly because of the medications what we use. Routinely, but if at all it is needed, there is deposition of IgG, especially IgM, fibrinogen mixed with apoptotic keratinocytes. And dermoscopy, usually there is white crossing lines, that is Wickham sign, we call it as, with dull red background and peripheral arrangement of facials. Usually we don't go for cytokine profiling because it is mostly a clinical diagnosis. If at all needed, we can always estimate the cytokine profile. And patch testing also comes into role in case of lichen planus, especially in oral lichen planus, because dental restorative materials will cause oral lichen planus, and it is not, and it doesn't have any prognosis on the disease actually, and it is not associated with cutaneous lichen planus, and there are actually no imaging studies that are required for the diagnosis of lichen planus. So coming to the management, my today's topic. So despite the high prevalence of the disease and variety of therapeutic options that are available, there are no national and international guidelines that are put forward for the case of lichen planus, unlike psoriasis. So this has prompted the European Dermatology Forum to develop guidelines for the treatment of lichen planus. And here the lichen planus, what they did is they nominated some experts, and they were entitled to report their choice of preferable treatments. Then these treatments were put in a chronological order, so that gives a best preference of treatment. So I am going according to the European Dermatology Forum, the guidelines that are put forward, because there are no national criteria available for the treatment pattern. So objectives of these guidelines are to control symptoms and minimize damage, and the treatment should be associated with the severity of the disease and less possible side effects, and also should improve the quality of the life patient, because it is mostly itching will cause, and they have cosmetic concern. And the aim of the treatment is to reduce the itching and shorten the duration between the onset of the disease and resolution of the lesions. So out of all the treatments that are available, so corticosteroids till today, it becomes the main treatment for lichen planus, especially topical corticosteroids. Other treatments except for topical corticosteroids, they are all offline management. Then symptomatic treatment, you give oral antihistaminics, preferably sedative antihistaminics should be given. And because sedative antihistaminics, they have associated some sleep disturbances are there, they are more prone for accidents, they are mainly avoided. But otherwise sedative antihistaminics are preferred here. And topical antipruritics are given to lessen the that is itching. Then the first line treatments, I told you already that all drugs except steroids are offline management. The topical corticosteroids, especially if in case of localized disease, even in generalized disease where the other treatments, along with other treatments, you can go for topical corticosteroids. Usually super potent topical corticosteroids are used, that is triamcinolone, fluocinolone acetonide, and betamethasone dipropionate and clopidogrel propionate, all these are used. And triamcinolone intralesional injections, especially given for more hypertrophic lesions or unresponsive lesions, that is usually we restrict the dosage for 20 milligrams per ml every 2 to 4 weeks. And systemic corticosteroids, oral or intramuscular injections if lesions are unresponsive to topical treatment. Here the most preferred treatment is oral prednisolone, that we give usually 30 to 60 milligrams or up to 80 milligrams per day for 4 to 6 weeks, or intramuscular injections of triamcinolone we give. And acitretin 20 to 35 milligrams, that is, these are the first line treatment that is mentioned in the literature, that is, and oral cyclosporin. So second line is broad. Second line is, according to European Forum of Dermatology, second line is broad or narrow band of UVB and combination of UV with acitretin, that is Repuva, and topical calcineurin inhibitors and sulfasalazine. Then coming to the third line, there are many drugs that are included in the third line. So the list goes on. So now I go to the in detail of the first line treatment, that is topical corticosteroids. The mechanism of action is mainly anti-inflammatory, that is through genomic and non-genomic action. Here we use mainly non-genomic action because there is delay, always some delay in the treatment when we use the genomic action is used. Even if therapeutic levels, I mean whatever the blood concentrations of steroids are very high, but the action will take some time. That's why we use usually high pulse corticosteroids, that is in the pulse form we give, that usually it takes non-genomic action. So duration, the topical corticosteroids I mentioned earlier, that is usually triamcinolone and all these things we give under occlusion or just like that. Usually once a day application is enough. There are some studies mentioning even twice a day is as efficacious, I mean once a day application is as efficacious as twice a day. So we usually restrict once a day application. Or in hypertrophic lesions it may be under occlusion. So it is mainly once a daily application is given, because to reduce side effects and also to reduce tachyphylaxis. So, and before taking up topical corticosteroids, the routine investigations you do, that is complete blood picture and all those things you have to do, and if at all needed, we have to switch over to simultaneous systemic corticosteroid. Side effects that is as usual expected. There is atrophy, acneiform eruptions is there, hypertrichosis and pigmentary changes. They are more prone for infections and allergic contact dermatitis to excipients of the drug. Then intralesional corticosteroids, the mostly we use triamcinolone. The indications are relatively when few lesions are present and hypertrophic lesions that are not managed with just topical corticosteroids, and particularly resistant lesions. And we restrict the total monthly dose of triamcinolone usually to 20 milligrams per month to prevent HPA axis suppression. Then systemic corticosteroids are given. That is where there is unresponsive to topical treatment, and when atrophic lesions are present in the evolution of the disease, that is an indication to switch over to systemic corticosteroids. And if it is the disease is acute generalized, even in acute exanthematous form of LP in children, we go for systemic corticosteroids. And the mechanism I told you, that is genomic and action and non-genomic action, and they have effect on the cytokines. So they suppress monocyte and lymphocyte action and modulate levels of inflammation, and they have effect even on B lymphocytes, that is not used here. So dosing is prednisolone, oral prednisolone 30 to 60 milligrams per day for 4 to 6 weeks with efficacy.
Dr. Purna Chandra, please conclude. Your time is up. Please conclude.
Ma'am, is not audible.
Your time is up.
Yeah, okay.
Please.
So prednisolone, it is in the form of oral prednisolone. We give 30 to 60 milligrams, and as low as 15 to 20 milligrams is also sufficient. And 30 milligrams per day with gradual reduction for 10 days. There are different options are available. 30 milligrams per day you can give without any gradual tapering for 10 days, and 5 to 10 milligrams per day for lichen planus. And intramuscular injections are also preferred. That is 40 to 80 milligrams for 6 to 8 weeks, and pulse therapy in the form of oral betamethasone and 6 milligrams of oral betamethasone once weekly for 3 to 6 months, and methylprednisolone in the form of pulse therapy also we give. So these are the side effects. And so I'm skipping all these things and I go for systemic retinoids. Systemic retinoids, these are these are mentioned in the literature with cutaneous LP along with oral LP, and here again they have effect on the cytokines. And the most common preferred retinoid is acitretin, that is 25 to 30 milligrams, even up to 50 milligrams, but the doses that is mentioned in the literature is 20 to 35 milligrams per day for 6 to 8 weeks, and they have good effect. But there are once the drug is stopped, there is recalcitrant, I mean the lesions reappear, but how the lesions are appearing and how they are managed, there is no mention in the literature. Okay, there are other drugs, that is etitrinate and isotretinoin are also used, but they are compared to acitretin, their efficacy is low. So these are the possible side effects. And the acitretin, isotretinoin, though they are given for long period, there are not many side effects mentioned, only cheilitis is mentioned, so that can be managed. Then coming to the most promising drug, that is cyclosporin, the dosage, that is particularly generalized LP, oral LP, erosive lichen planus and severe cutaneous lichen planus resistant to corticosteroids and retinoids, we give cyclosporin. The mechanism of action is it has effect on the lymphocytes basically, and the dosage is 3 to 5 milligrams, though, but less dosage as much as 1 to 2.5 milligrams is sufficient to cure the lesions. So, and clearance of the lesions is noted in 6 weeks, and dosage increments can be done every 4 weeks, but dosage reduction can be done without any, they can reduce the dosage at any time, but increments are needed only after 4 weeks. And children, they need higher dosages because of renal clearance.
Dr. Purna Chandra, please conclude.
So nephrotoxicity, if it is there, you can always reduce the dosage, and if at all that serum creatinine levels are not coming down, you can always, you can just stop the drug. So then phototherapy Phototherapy, it is mainly narrowband phototherapy, and bath puva therapy, that is actually important in case of lichen planus. Bath puva is more potent than oral puva. So topical calcineurin inhibitors, hydroxychloroquine 200 to 400 milligrams, interferon alpha 2b in case of hepatitis C virus infection. Okay. And metronidazole, tetracyclines, dapsone, sulfasalazine, grisofulvin, thalidomide, azathioprine, methotrexate, mycophenolate, mafetil. So low molecular weight heparin, this is the new drug that is actually it is given 3 milligrams subcutaneously weekly once, that is for many months it is given, and it has promising results. This is the new drug that is mentioned in the literature. And biologics. So biologics, the main biologics that are used is alifacept and adalimumab, efalizumab and basilixumab. So to summarize, these are the drugs that are acting on different levels of pathogenesis, and these tetracyclines mainly they are used in matrix metalloproteinases. And take home message is all the drugs except topical steroid preparations constitute off-label treatment modalities. The natural course of LP must be kept in mind when initiating any therapy, and many patients have spontaneous regression. Equality of data surrounding LP treatment must be analyzed, and potential risk must be low before attempting to start these off-label treatments. And systemic steroids in the dosage of 30 to 60 milligrams per day for 4 to 6 weeks can be given for generalized LP. Betamidazole in the form of oral mini pulse, that is 6 milligrams once weekly or 5 milligrams twice weekly can be given. Topical steroids particularly popular in children, and if the efficacy of cyclosporin is promising, but if there are recurrences with cyclosporin, they can be managed with topical corticosteroids. And other therapies that are included is narrowband UVB, systemic retinoids, that is acitretin, that is mainly used here. And biologics that can be tried is alifacept, efalizumab and basilixumab. Basilixumab mainly used in oral lichen planus. It was not used in cutaneous lichen planus. In mild cases, symptomatic treatment is enough. What are the future perspectives means the lichen planus, actually it is not many studies are available, so probably we should take up more studies, and oral and cutaneous LP should be clearly separated since the modalities of clinical evaluation and treatment are different. The duration of the disease before the start of the treatment and type of the lesion and involved body surface area should be detailed. The major criteria for efficacy should be based on objective criteria, and global evaluation should be considered only as accessory criteria. And erosive and reticular mucous membrane lichen planus must be separated, and research concerning adopted topical treatment should be continued. And the new promising treatments are topical cyclosporin, especially in oral lichen planus, and extracorporeal phototherapy, and even retinoids should be tested in large controlled trials. And quality of life studies should be helpful in evaluation of oral lichen planus, and large randomized controlled trials in cutaneous and mucosal LP are warranted to improve treatment. So if I have experience with cyclosporin, whatever that type of generalized lichen planus, I am going for cyclosporin, but not many patients I have tried, but the results are promising. With that, I conclude my session. Thank you.
Thank you, Dr. Purnachandra, for the elaborate presentation. Now we move on to the panel discussion. I request Dr. A.G. Rao sir, Gnaneshwar Rao sir, who needs no introduction, to conduct panel discussion on management challenges of psoriasis in special situations. And I request sir to invite panelists, sir.
A very good morning to all of you. I thank Chairperson Dr. Sudhavani, with whom I had an opportunity to work with her. And I thank the organizers for giving me this opportunity to moderate the panel discussion on a common problem like psoriasis. So when the topic was given to me, it is a regular topic that has been talked about in a number of fora, and I thought there should be some practical problems which all of us face. I thought we will discuss under special situations like the pregnancy and children, and in liver disorders and the renal disorders, where the patients are faced with problems, and we would like to learn from each other to solve the problems which we face. Now, with this few remarks, I start. Now, I invite Dr. B.N. Reddy, Professor of Dermatology, working at Medicity Hospital. And I am not able to read his biodata since he has not sent me. And next I request Dr. Naeem Saadat Hanif, who is Professor and Head of the Department of Dermatology at Deccan Medical College. He is an young academician who has about 27 publications to his credit and had about 43 presentations. He authored many chapters, and his area of interest is psoriasis, lichen planus, vesicular disorders, and quite a number of other topics also. Now I request Dr. Anand, who is a senior consultant in KIMS Hospital and is also attached to the Anchala Parthasarathy Institute. He has been associated with it. He also couldn't send his biodata, so I am not able to have the full profile of his achievements. And next I invite Dr. Vikram Kumar, who is a young budding dermatologist who has a lot of interest in the hair transplantation. He has done more than 400 hair transplants. And he has about 3 publications and about 8 presentations. With this introduction of our erudite panelists, we move on to the topic of psoriasis. Can I have it in this?
भाई वो पीपीटी उस पे कॉपी कर दो ना, वो लैपटॉप पे कॉपी करना दो.
Laptop not working, eh? Achha, okay. Okay. So let us move on to the topic of psoriasis. How do I going to manage the psoriasis in pregnancy? Because where the health of the mother and the child is at stake, and one has to be very careful in prescribing medicines to the pregnant woman. Now, all of us know that about 40 to 60% of the psoriasis patients, they improve during the course of pregnancy. Only a few number of patients, like 20% of them, they worsen. And much worsens is in the puerperium. And about 30% do not change the course of psoriasis. Now, coming to the therapy, so I would like to ask, start from Dr. B.N. Reddy. Not audible.
So most of the pregnant women actually, they don't suffer much with psoriasis. Sometimes there may be a spontaneous recovery, sometimes worsening. Only few cases there is worsening of the psoriasis. So the time-tested treatment, I prefer to go for narrowband UVB And nowadays you can give TNF alpha inhibitors. They are also pregnancy category B drugs.
Yeah, next, Dr. Purnachandra. So what will be your choice? No, we are dealing with the cases wherein there is extensive psoriasis, that is moderate to severe psoriasis, where you need to give the systemic therapy. So topical therapy may not be adequate enough to treat the patients of psoriasis in them. So what is your choice? What will be your choice of treatment in them?
So sometimes the psoriasis, they may, in pregnancy, they may end up with pustular type also. So then I can go, if, first 3 months I will avoid the steroids. Probably next, after 3 months, first trimester is over, I may go for systemic corticosteroids in a low dosage.
Systemic steroids. Okay, you want to go for systemic steroids in first few...
First trimester I avoid.
Avoid, okay. Yeah. Systemic steroids you want to give?
If it is not controlled with topical corticosteroids.
Okay, okay. Dr. Naeem?
I will probably use cyclosporin cautiously, sir, in case of extensive psoriasis. But before that, even phototherapy, wherever it is available, narrowband UVB therapy is a safe therapy that should be always utilized first. And then if we are hard pressed to use any systemic drug, my choice will be cyclosporin.
Cyclosporin,
yes.
Okay.
Biologicals, of course, they are also safe. TNF alpha inhibitors, they are category B. But I don't have much experience with biologicals in pregnancy in psoriasis. But I rather give cyclosporin.
Ranu?
Yeah, first is narrowband UVB, sir. I will recommend narrowband UVB. Then second option is cyclosporin.
Okay. Dr. Vikram?
Definitely I will go with topicals first, then phototherapy. Lastly for steroids.
Phototherapy, you want to give POA therapy?
NBUB.
NBUB, right, okay. Now, even the cyclosporin also is not that safe, though there are literature wherein they have given, they have been giving, and then the outcome has been very healthy fetus. But the only problem is it can give rise to the premature rupture of membranes, and then there could be a growth retardation also. So these two, except these two problems, there is no other problem that cyclosporin can give the adverse effects. Okay. So what would be the next choice? For example, what is the other choice? Suppose if you don't have the narrow bandwidth therapy, you don't have the cyclosporin, what are you going to do then? Do you have any option of going for biologics?
Yes, sir.
Yeah, etanercept can be given. Say beyond 16 week also we can administer etanercept.
So the topical therapy that should be avoided in these cases is coal tar, anthracene, calcipotriol and salicylic acid. These cannot be given. They cannot be used because of various reasons. And systemic, you should avoid POA therapy, methotrexate and retinoids and apremilast. Though apremilast has been a latest addition to the our armamentarium, but still it is not advocated in case of pregnancy.
Sir, one point. Interestingly, tofacitinib can be used in pregnancy.
Which one?
Tofacitinib.
Tofacitinib. Tofacitinib. Yeah.
It is indicated.
In first trimester?
After first trimester, sir.
After
first trimester.
Okay.
The latest evidence is showing like tofacitinib is safe. Apremilast definitely not. There are no studies.
But in view of the impending side effect of infections,
yes, sir.
Do you advise still tofacitinib?
I am talking about literature, but I have not used it, sir.
Okay.
I would like to avoid as much as possible.
So, any one of you have used the biologics in pregnancy? Dr. Anand, Dr. Vikram?
No, sir, I didn't use it.
Vikram, no. But there is a lot of literature in the biologics that have been used in the Western countries. Now, probably because of the insurance policy that goes with the availability of the drug. Whereas biologics have not been that rampantly used by us as compared to the Western physicians. So these are the category drugs So category B drugs are the biologics, adalimumab, etanercept, infliximab, ustekinumab. So the topical drugs are also included in this as a category C drug, anthralin, calcipotriene, corticosteroids, sorlin, the systemic drugs like cyclosporine and corticosteroids. So next, what are we going to do? Use it. So this is about same biologics. No, out of all the biologics, which one is been accepted or FDA approved in pregnancy? These are not approved. All the uh, biologics are not approved. Only one is approved, that is certolizumab. Certolizumab is a TNF alpha inhibitor that is approved for the usage in pregnancy. So that being costly, and I also don't have any experience with the biologics. So it's only the theory that we are discussing here. So now, given the choice, you go for only the topical therapy plus you want to go for cyclosporine. Now, which period you want to give cyclosporine? The first trimester, second trimester, third trimester? Purnachandra.
Sir, it is second trimester onwards.
Okay.
First trimester we try to avoid.
Okay.
Since these drugs belong to category B, can be given in first trimester also.
But only problem is first trimester, generally even the gynecologist or anybody, they don't advise any drug.
We avoid all the drugs first trimester, including vitamins also.
Yes.
Thinking something happens to the child, they will blame you. That is the reason we avoid. But most of these actually drugs, whatever is JAK inhibitors or trials are not done so far.
Yeah,
because of the same reason, including apremilast.
Yeah. How about systemic steroids? If you are required to use systemic
Sir,
steroids?
in pustular psoriasis, yes, systemic steroids. Okay. But in other types, I would not like to use, sir.
Okay, when do you want to use?
Again, after first trimester.
First trimester.
Yes, sir. After first trimester only. But systemic steroids are comparatively safer than what it was believed to be earlier. Nowadays, there is a large evidence to say that they are by and large safe.
No, what is the dose you want to go to?
As less as possible, sir. Like 0.5 mg to 1 mg maximum of prednisolone in terms of prednisolone.
But we should not cross the immunosuppressive dose.
Yes, sir.
Immunosuppressive dose is, more than 20 milligram per day.
For more than 3 weeks.
For 2 weeks, yeah.
Yes,
so that is a right of the way, what we have.
Yeah.
Okay. But Anand, what is your opinion?
Thank you, sir. So the first trimester prefers steroids only. Still the disease is not controlled, it's aggravating, then I will give cyclosporine also.
Mike, closer please. Close.
Still I prefer steroids only. Still if the disease is not controlled, then we have to weigh the risk and benefit ratio.
So
still,
given a choice, you want to go for steroids rather than going for cyclosporine?
Cyclosporine, and even in the first trimester if required, because cyclosporine active metabolite 6-mercaptopurine doesn't cross the placenta. So cyclosporine first trimester also, depending upon the risk and benefits.
But in general, the consensus
in generally, the second trimester is better.
Yeah, consensus is you should avoid any drug in first trimester. You try to manage with either topical steroids or topical emollients, and then, if need be, you can give a systemic steroids. Yes. Okay. What Vikram?
Same, sir. In first trimester, I will avoid.
Okay. No. What is the effects of biologics on the fetus? What is the effect of the biologics?
Suppose if the biologicals were continued behind 16 weeks of pregnancy, and the last dose usually recommended first week of the last trimester. Beyond that we should not give. Then it crosses the placenta. Antibodies, IgG antibodies crosses the placenta and form the babies also. They will stay up to 6 months after delivery. So in the babies who took the biologicals in the mother, it's better to avoid all the live vaccines. And there are one report where BCG vaccination was given, the child was died. After BCG vaccination, mother who took the etanercept. So up to 6 months, we should not supposed to give the live vaccines.
Yeah. So that's mainly because the biologics, they cross the placenta mostly there is active passage of biologics to the fetus during the third trimester.
Yes.
So first and second trimester there is minimal. So this ideal would be to put the patient on first 2 trimesters. You can start the biologics. So that is it. I mean that's what the literature says.
Even adalimumab and infliximab is detected in the children neonates also.
Yeah,
like
it can be, yes. No, these antibodies, these biologics can be detected up to 6 months of life in the infant. So naturally, during the first 6 months, you don't give any live vaccines like BCG. So coming to the lactation. So what are when do you advise the lactation? The patients are on
cyclosporin active metabolite won't present in the milk, sir. We can give safely cyclosporin.
Which one?
Cyclosporin.
Cyclosporin. But still the literature says you should not...
Cautious use is advocated, sir. Cyclosporin can be cautiously used, especially avoiding the breastfeeding for 4 hours soon after taking the cyclosporin dose. Yeah. That is one practical method of giving.
Maintain the gap of the drug and the feeding.
Yes.
So that is the time one should avoid. Yes?
We can go with the phototherapy again.
Okay. Now, the other drugs where you should avoid the lactation is infliximab, adalimumab, etanercept, and ustekinumab.
If satralizumab is available, that will be the first preference.
Yeah, satralizumab, yes. But other biologics, they are not been given green signal regarding lactation.
It doesn't cross the placental barrier.
Placental, yes. What is this? So, what are the vaccines since the children born to the mothers on biologics? So
all the live vaccines should be postponed.
But one vaccine that has been given green signal to go ahead for in these patients is your MMR and varicella vaccine. So that can be given in the neonate. During that too is a booster dose, not a regular dose.
That too in booster dose.
Booster dose.
That too is in mild immunosuppressive. According to CDC, mild is 20 mg of prednisolone more than 2 weeks of time, or 0.3 mg of methotrexate per kg body weight.
Yeah.
The mild immunosuppression, then we can take risk and benefit, can give the booster dose of MMR or varicella.
Yeah, MMR and varicella vaccine can be given only the booster dose, not a regular dose.
Not regular dose.
Not regular dose. Yes?
And all DMRDs.
So the take-home message is non-live vaccines cannot be given. Some technical issues.
Even not only pediatrics, even adults also, whom we are going to start the biologicals or DMRDs, especially pneumococcal and influenza vaccine we are giving, especially biologicals and rituximab or secukinumab before starting.
But they should be given before.
Before, at least 4 to 6 weeks before. Ideally 4-6 before.
So there should be a gap of 4 weeks
generally. Yeah, pneumococcal and influenza, both are being given.
Yes. That too you should use the polysaccharide, not a live one. Polysaccharide pneumococcal vaccine.
Pneumococcal polysaccharide vaccine.
And the gap after having given biological should be like after the period of efficacy of that particular biologic, whatever biologic we are using. For example, in case of rituximab, he was mentioning it is 6 months, like that.
Patients are asking biologics who are on COVID, on biologics, they are asking COVID vaccination.
Non-live vaccine we can give safely on DMRDs. No, it is a non-live vaccine we can give safely.
Yeah, however, there are some reports of severe psoriasis being treated with ustekinumab. So this is the first report of a 22 years old lady who was given the ustekinumab in the management of psoriasis, and she had a normal child. So this gives us the experience of your boldness to use the biologics in these cases of pregnancy. Probably yes, in the future probably we will be able to use the biologics in pregnancy. So this is also one more study where ustekinumab was used during pregnancy.
Sir, there are any studies on secukinumab? Because ustekinumab is not available. Secukinumab during pregnancy.
No literature is available on the secukinumab. Only the literature is available on the TNF alpha inhibitors and the IL-12 and 23 blockers.
Yeah, IL-12 and 23.
Now we move on to the No, this is a child about 12 years old child, girl with extensive psoriasis. So what will be your choice of drugs in the management of psoriasis? Dr. Purna?
Sir, my first choice is cyclosporine.
Cyclosporine is costly, it may not be available or affordable by the patients. What is the next choice?
Methotrexate.
Methotrexate, yes. No, what is the experience you have in treating the children with methotrexate with the least age? What is the smallest child who had psoriasis and you used the methotrexate?
Sir, 10 years.
10 years?
10 years. I've started.
Okay.
So least possible dose 5 milligrams, then slowly increase up to 7.5 they are responding.
Okay. What is
I
your
prefer
choice?
to use methotrexate.
First choice? First choice?
Yeah, first choice.
Right.
Then phototherapy.
Okay. Okay.
Sir, wherever phototherapy is available, definitely phototherapy is the first choice, narrowband UVB, along with emollients. Second choice would be methotrexate. Third will be cyclosporine for me.
Dr. Anand?
Yeah, apart from topicals, phototherapy, narrowband UVB therapy, methotrexate, cyclosporine, and of late, apremilast is also indicated in adolescent children. And biologicals also you can consider is affordable.
Yes.
Like etanercept or adalimumab. Even above 6 years old, secukinumab can also be given 150 mg. And if it is more severe, still not responding, tofacitinib can also be given.
Tofacitinib, yes.
It's depending upon the response.
Okay. Okay. Vikram?
Sir, first initially I will go to with the topical emollient steroids along with the narrowband UVB therapy. If still not responding, then methotrexate at...
personal choice?
Yes.
Personal choice. What is your personal choice?
For narrowband UVB therapy.
Narrowband UVB therapy.
Then
But
still not responding, methotrexate in 0.1 to 0.4 mg per kg per day.
No, with narrowband, but the problem is availability.
Yes.
And costly treatment the patient.
If not available, I will go with methotrexate.
Methotrexate, yes.
If still not responding, then apremilast I would try.
No, regarding the liver toxicity, no, as compared to the younger patients, older patients, how about the children? What is the level of the side effects in them?
Personally, I have not seen much changes in the liver.
What is your experience? Dr. Anand?
Not much since liver toxicity.
No.
Very limited cases.
No, you see more of patients having side effects of methotrexate in adults as compared to that of the children?
In the children, it's less compared to adults. I don't know, probably the reason would not explain, but I didn't see any cases of like liver toxicity of methotrexate in children.
Yeah. Nine?
Same, sir. My experience has been not many side effects. I've given for 13 to 14-year-old children in some cases. And 0.2 to 0.7 milligrams per kg body weight, not crossing 25 milligrams in total. That is the recommended dose for children.
How long you have given? How long you have given?
Sir, in one child, actually, she had pustular psoriasis. So I had been rotating between methotrexate, cyclosporine, acetretin. For that child, I remember, I think I must have given for 3 to 4 months. That's the longest I
gave. 3 to 4 months?
That's all.
Okay, why not beyond?
Because it was not responding, so I had to move on to acetretin,
right,
basically.
Now, what is the longest duration you have given, Dr. Purnachandra? Methotrexate?
Sir, 3 months.
3 months?
3 months.
Anybody has got more than that experience of giving methotrexate to children?
1 to 2 years also again one child is there, 1 to 2
Yeah,
years.
it can be given, provided you have the monitoring of the liver function tests. You can always go ahead. as long as the liver is normal, probably yes, there is no immunosuppression, he can go.
But someone requiring methotrexate for that long, should we not consider other alternative therapies? Because
Yes,
if
definitely yes, definitely yes.
because obviously once the response is there, we need to taper and stop.
No,
that would be the choice.
The problem is the moment you taper it, again it recurs.
No immediate
and
tapering.
Sometimes they will stop on their own also, some few weeks non-availability of the drug, because they will stay in the outstations like that. Then it recurs. Again we will reintroduce it.
Yeah, reintroducing is okay probably, but I think if someone requires for continuously for that long, we should be exploring other options, my feeling.
In adults, we continue to use. We don't change the drug if the patient is responding. So why do you want to change in children?
Sir, even in adults, my choice is to taper it and stop it after the good response is seen. It's a psoriasis is a seasonal disease. I don't want to put them on years together continuously, sir.
No. What we do in the adults, generally, we continue with the drug. If the patient is responding, we continue with the drug. Maybe as long as he develops a remission of 80%, we stop the drug then. But having responding, as the patient is responding, we'll continue the drug. And why you want to change when the patient
For how
is
long do you
responding?
continue, sir? Like even after the response is seen, complete response is seen, for how long do you continue the methotrexate, sir?
Which one?
Methotrexate.
In whom?
In adults or children. Suppose they have already responded, good response is seen, but for how long you want to continue, sir?
Wait till 80% of remission is there, we stop.
That is okay, sir. I'm in line with you, on the same page with you on this matter. But after having complete response, for how long do you continue? Like, do you continue indefinitely?
No, we stop the drug.
Not indefinitely, no, sir. That's what I wanted to say.
Stop the drug.
Usually literature says we should wean off per week dosage 0.1 mg per kg should be
I
weaned
have
off
not
and
done
then
it.
stop.
I don't weaning off methotrexate by
Yes, once
skipping
80%
one day,
is
skipping
achieved,
one day.
then we need to wean off.
Alternate week you want to give. No, alternate week we want to give methotrexate.
Reduce the dose.
Reduce the dose. Okay.
If there is no response actually, you can add one more drug.
Okay, yes.
After
That's
6
combined
months
therapy. You
observation.
want to go for combined therapy.
Combined
therapy. Okay. Now, what is other next option? What you have in children? What are the other drugs about retinoids?
Yes, sir. Definitely acetretin can be given.
Cyclosporin.
Cyclosporin can be given. Yes. The only constraint is the availability and the cost of it, where the patient can afford.
It's available.
Okay, what is your choice in using retinoids?
Again, acetretin should be tried to avoid in adolescent females, especially,
Time is up. Time is up.
12 minutes.
5 minutes, okay.
It is.
12 minutes.
Yes.
Okay. No, retinoids, no, acetretin is, yes, acetretin is a good drug, particularly. But how many people have, how many of you have seen the side effects of retinoids in children?
Definitely there will be hyperlipidemia, sir.
No, hyperlipidemia will be there, the growth retardation will be there, the fusion of epiphyses is there. But how many of you first have seen the side effects?
Personally, I'm not.
If any of you have
Except for local side effects, something like peeling of the skin and those kind of things, no side effects. I have not seen any.
No, is it related to the dose?
Yes, sir. Definitely Indianized version we really give low dose only.
No,
maybe
the literature says otherwise. No, the choice of therapy would be about narrowband UV therapy, this first choice, then methotrexate, cyclosporin, and then your acetretin, plus with phototherapy about 80%. One has to do the serial skeletal X-rays every 6 months when the child is on retinoids, acetretin you want to put. The other things that can be used is POA therapy and biologics and apremilast also. So when the child is on retinoids, at least 6 monthly X-rays are mandatory to know whether there is any growth retardation. So that is what the literature says. And one more thing is
biologics. I think etanercept is approved for more than 4 years.
Which one?
Etanercept for more than 4 years, and secukinumab for aged more than 6 years.
Yeah, that we are coming to that. We are coming. No. So regarding the usage of retinoids, so there is no relation between the dose and the duration. There have been reports of usage of the drug acetaten for about 5 months to 10 years. There have people used for neuroblastoma and other things. No, we are talking about the biologic that have been approved is etanercept more than 4 years. All the TNF alpha blockers have been approved. Ixekizumab that is approved for 6 to 18 years. Ustekinumab for more than 12 years. So this FDL approval for all these drugs. So it means since the intense study has been done, so we can go for the usage of these drugs. Recently there has been a report of CUTICON. Dr. Anand was asking about CUTICON. So we have a search of literature where they have used CUTICON in 9-year-old child successfully.
Now FDA is approved above 6 years, sir, CUTICON.
That is it.
Above 6 years is approved.
I couldn't see the literature where it is approved. I haven't seen the literature where it is approved for children.
No, it's approved, sir. It's approved. Recently it's approved. June it is approved.
What is the age it can be given?
Above 6 years.
Above 6 years.
Above 6 years we can give.
Even adalimumab, sir, above 6 years.
So vaccination, we already discussed this. What are the vaccines that should be given? No, there is an interesting article published in the Journal of Osteopath Medical, where they have studied from 1985 to 2021, there are about 9 cases of retinoids, that is acetaten, being used, and they have compiled the data where the epiphyseal growth fusion was observed. So only about 9 cases, almost 20-25 years, there is only 40 years, we could see only a very few number of epiphyseal fusion due to the retinoids. So it is so rare, I think we should not be so scared about not using retinoids in the children for the fear of this arrested growth retardation in children. So retinoids can be given safely, at least 6 months to 1 year, it can be safely given, as the literature shows. Now, coming to the apremilast, so anyone of you have used the apremilast in these patients?
Yeah, I usually say in pediatrics patients also apremilast, like low dose, like sometimes 10 mg OD, 10 mg BD, 20 mg.
Was it tolerable?
Yes, they are tolerable. Few children are tolerable, few children there is gastric effects. Even
Okay,
that can be seen in adults also.
Okay.
But low dose, not
How long did you give the patient apremilast?
I have given for 3 months.
3 months.
3 months. And power plantar psoriasis patient in children I have given for 3 months.
Continuously?
Yes, continuously 3 months.
Okay. There are no
No.
side effects. Okay. Anybody else used apremilast in
I
children?
have given above age 12 years, 20 mg twice daily. Sir.
Okay.
Usually responsible.
No, in combination or single drug?
Single drug along with topicals.
Along with topicals. Okay. So this drug probably, yes, it can be. There is a recent article in JAD where they have used this apremilast in 14-year-old boy. Though it's not been approved by the US FDA in children for psoriasis. So, I mean, that has to be taken into consideration before we prescribe, looking at the legal angles. Again, there is one more study published in JAD on the moderate to severe psoriasis, and they have studied many 42 patients, and which has given about 79% of response in the children. So apremilast is one drug, yes, probably it has not been explored. Either in adults also, it is not used much in psoriasis. How often you use apremilast in psoriasis? In adults?
Sir, it is like all or none phenomenon. The problem with apremilast is if it works wonderfully. If it doesn't work at all. So I have had mixed results, efficacy wise as well as adverse effects wise. Some people are so disturbed by the adverse effects within the first week, even with the starter kit also, that nausea, diarrhea or headache can be so troublesome that they don't want to go back to it again. So those kind of mixed results I've had. So in some patients may be useful, but not a mainstream drug for me, sir.
Not mainstream.
Yeah. Yes, especially palmoplantar psoriasis, I prefer apremilast. And second is above 75 years old age psoriasis patients also, I prefer low dose of apremilast. And like 10 mg they can tolerate, 10 mg or 20 mg they can tolerate.
So how are the side effects in them with 10 mg?
10 mg is, rather than escalating in a 1 week, what I will do, I will slowly escalate, like 5 days 10 mg, next 5 days 20 mg, like that I will slowly escalate. Because the problem is 1 week if you escalate and suddenly they develop the side effects and they won't prefer the drug again. Abruptly we have to stop the medicine. Suppose in some people low dose also I am seeing good results, especially palmoplantar and old age people like 20 mg, 30 mg, 10 mg also they are seeing good results. So sometimes what I will do, I will combine with the apremilast, low dose of apremilast with methotrexate also. And sometimes apremilast with secukinumab. If psoriatic arthritis is there, arthritis, options is methotrexate, apremilast and biologicals. If they are not affordable, then I will combine both apremilast and methotrexate. If they are affordable, I will combine with biologicals plus apremilast. And in one patient, I have given apremilast plus methotrexate plus secukinumab, 3. Still, the disease was not under control.
What was the age of the patient?
Is around 45 female patient.
You couldn't control with 2 drugs. It has
3. So secukinumab plus apremilast plus methotrexate. Methotrexate 20, apremilast 60, secukinumab 300 mg.
Okay. So, but it's rare. I mean, at least patient responds to 1 or 2 drugs. A combination of 1 or 2 drugs can be.
Yeah, definitely it is a good drug, especially if psoriasis is there, infection, secondary infection of psoriasis is there. Then in such cases, septicemia is there. Apremilast is a good option. And transaminitis patients, mild transaminitis liver problem is there, then apremilast is a good option in mild to moderate.
How often you see the transaminase elevation in the
with apremilast I didn't notice, sir. In one patient only I had a liver cirrhosis patient, because we don't have any option, he is not ready to take secukinumab, then we started apremilast, then with 30 mg BT, then enzyme levels was raised. For him we have to stop. And remaining patients, they tolerated very well, apart from the routine side effects.
Okay. So now,
even GI side effects are very less when compared to adults in children. And I had the opportunity of treating even progressive alopecia areata. It was giving very good results.
apremilast?
Yes.
Progressive alopecia. Progressive alopecia you are talking about? Okay. Literature is there, studies? Okay. Okay. Now, one more point is, as far as the liver toxicity is concerned, the children are less likely to have the side effect of on liver as compared to the adults. So that's what the literature says. So the children are, the liver is more compatible with the usage of methotrexate.
Probably the enzymes are not that developed in the children compared to enzymes, liver enzymes.
Liver enzymes?
Probably, I don't know.
No, but that's what I was
saying. Cyclosporin, I was reading, is transferred to the children also, but it is not that effect because enzymes are not that developed liver enzymes, so there is no side effects of.
No, what literature says is the children are more acceptable as far as the toxicities of liver is concerned. The adults are more liable to go for the side effects of methotrexate rather than the children. Children have more tolerance in not developing the toxicity of methotrexate. So, the patient having an extensive psoriasis, what will be your choice of treatment in Purna in liver disease?
Definitely narrowband UVB.
Right, okay. What are the other options?
My choice is cyclosporins.
Cyclosporin. Okay. Cyclosporin is not to be considered in cases of liver disease because it is metabolized.
So actually, very low dosage also it
very
will
low
work.
dosage.
So
Okay.
usually less, even 1 to 2 milligrams, not.
But only problem is you cannot give for more than 2 to 3 months. It's only the drug which can be used in the crisis. not a regular drug which can be used for 6 months to 1 year or so.
So then biologics.
Biologics, yes, okay, yes. Have anybody tried the apremilast?
Sir, sorry to interrupt. Time is up, sir.
Okay, fine. Now last question.
You can add apremilast in hepatitis.
You used in apremilast. So, no, what was the situation where you used the apremilast in them?
Hepatitis B, when it's not active, you are giving. Of course, hepatitis C, actually you can completely treat, wait till 6 months, meanwhile manage with some other drugs.
Okay. So the problem is with biologics is the reactivation of the hepatitis B virus infection, particularly. So that's the reason why the people are given lamivudine when they develop the reactivation of the hepatitis B virus. Okay. So what is the experience of other panelists that are Naeem, liver disease? And
Sir, once again same phototherapy and low dose cyclosporin and apremilast. Yes, of course, technically one can use. I have not used. I have not got an opportunity to use like that.
Which one?
And apremilast. And there are some unexplored drugs. Probably we use them less often, like hydroxyurea and razoxane. These are two safe drugs to be used in liver disease. I don't have personal experience. As per literature, they're supposed to be safe.
Raman?
So apremilast I prefer in
First choice. First choice, right? Okay.
Then TNF alpha blockers or secukinumab.
But most of the literature says the TNF alpha inhibitors are the first drug of choice in them. Narrowband UV therapy, of course. Plus other choices, apremilast and their biologicals. What, Vikram?
Same, sir. I would go for topical therapy with narrowband first line.
Okay.
Then secondly, apremilast.
So that finishes our panel discussion. I thank all my panelists for having contributed tremendously for the knowledge update in usage of psoriasis, usage of biologics, apremilast, methotrexate and other drugs. I thank you once again.
Thank you, Dr. A.G. Rao, sir, and esteemed panelists for wonderful moderation and the inputs. I thank organizers for giving me this opportunity.
I now request the chairpersons, speakers and the panelists to kindly assemble at the photo booth. I now request the next chairpersons for the session 3 on recalcitrant dermatophytosis, Dr. D. Subhash Reddy sir and Dr. C.H. Ramohan sir to kindly take over the session.
Good morning, Varundal. Today is third session 3. Topic is the recalcitrant dermatophytosis. I am chairing with Dr. C.H. Ramohan. And next, moderator is the Dr. Saple. He is the well-known leading dermatologist from Mumbai. I think he doesn't require any introduction. Proceed the session, sir.
यहाँ से आपको ये सिर्फ देखने के लिए है, आपको मैं वहाँ से सिस्टम में LED पे दे रहा हूँ सिस्टम से, यहाँ पे आपको देखने के लिए ये पॉइंट है, ये पॉइंट है।
First, पूछना। I requested to Dr. Saple deliver his lecture. Once again, I am telling Dr. Saple is well-known, renowned, leading dermatologist from Mumbai. proceed to the session, sir. Very interesting topic, reconstant dermatophytosis. Nowadays we are facing a lot of problems. We learn from him, you, sir. Proceed the session, sir.
Hello. Hello. Oh, yeah. Thank you, sir, for introduction, and thank you, organizer, Telangana IADVL, all of you, for giving me this opportunity to share my experience about dermatophytosis. Of course, many junior people may not be knowing, but I am coming to Hyderabad since '94, and this is my 42nd session in Hyderabad only. So probably the senior people may be knowing. Hyderabad always I like, especially for this paradise biryani. That is the thing I enjoy. So talking about this dermatophytosis, all of us, I think, yeah. Can you project the another one? Not this one, other one, yeah. Dermatophytosis, every one of us, we are facing a lot of problems like recurrence, relapse, either there is no response or partial response, or patients keep on getting it for long. So talking about this, now we are started studying the epidemiology. When you have started studying the epidemiology, hardly this epidemiology was studied before, but now they said there's almost, prevalence is almost 36 to 78%, because most of the patients comes to our clinic. I think about 6 to 7 patients comes per day. For example, in my clinic, but other clinic people must be getting more patients. So number of patients are increasing. So this is the patient, I remember I mainly work in HIV, but last 5 years I started taking interest in dermatophytosis. Reason because it's a big problem in our day-to-day management. This is the patient, he came to my clinic. Of course you can see in the cruris, tinea cruris, but what about the genital lesions? At least I was suspecting genital herpes. But this patient, we started, of course we got a KOH done. KOH is must in everybody's clinic. I do not know how many dermatologists, a very simple procedure. What you need is a simple microscope. And you have to train one of your receptionists or somebody how to scrape it, and you can read it. It's very simple but very useful. I am practicing the day I started my practice, that is in '79. I have a microscope and you must do KOH. See, we started this patient with itraconazole and everything disappeared. Of course, this patient developed edema of the feet. That time I was not also aware of this cardiac problem. Then we changed it to other drugs. But this is how. So mucous membrane is not known. And probably I would not have thought, but then we went to the literature, and according to literature, tinea of the gland penis is one of the paper from Japan, but tinea in the perineal area invading this, or perioral, there are many articles, tinea involves the mucous membrane, but rarely it is seen. This is another patient. This patient came to my clinic. You can see his CABG, he has got this cardiac bypass, he has got extensive tinea, he has got hypertension, he has got diabetes, he is on Lasix, he is on Citapine, he is on Digitalis, he is on warfarin. And this is the problem because now people are living more than 70, but they are living with the comorbidities. And because of that, they are on polypharmacy. So this is the patient comes to our clinic, is a big problem how to treat this patient. I think I would like to ask the audience, which drug you will start? Anybody, one of the person? Of course, if you go to our literature, drug of choice will be terbinafine. but this patient was on antipsychotic drug also. So we started this patient on fluconazole. The reason being, if you go for the what is called metabolism, if you look at this metabolism, the fluconazole metabolism is CYP2C19. It is not P40, that is called CYP3A4, where drug-drug interaction is very common with 3A4, not with the CYP2C19. So fluconazole, because many dermatologists are under impression or assumption they are from azole group, so drug-drug reaction must be same as the itraconazole, but it is not so. This fluconazole is very safe drugs, and if you see, even the psychiatrics drug they are using fluoxetine, paroxetine, it is the metabolism with the CYP2D6, where itraconazole cannot be used, terbinafine cannot be used, the drug of choice will be fluconazole. That's why we started this patient with fluconazole. Of course, the limitation with terbinafine, itraconazole is there, so we started with the fluconazole. So I feel fluconazole is very safe drugs if the patients are coming with the multiple comorbidity or they are on polypharmacy. Yeah, this is when talking about the fluconazole, many people are under impression that with the fluconazole there is chances of increased QT interval like itraconazole. But this is one of the study in Africa, they have given 1200 milligram of fluconazole for 1 year in 1000 patients, and they have studied about the QT interval. There is no change in the QT interval, so it is a very safe drug compared to itraconazole or terbinafine. So, and fluconazole can be given with rifampicin, can be given with warfarin. That patient was on warfarin with cyclosporine, hypoglycemic drugs, anti-diabetic drugs, because this is the drug which is hardly has been studied or how, because see, because in HIV we are dealing with the masses and the people who are not affording. That gave me an idea, because many patients of mine were not affording terbinafine, itraconazole. So about 4 years before, started working, can we give better drugs where the patient can have long-term compliance and the adherence, and that's why I started looking for the fluconazole, which is very affording drug. That's how we got involved, not because of anything else. But when we got involved, there are a lot of questions I think I'll address. So usually this is the patient, they ask your family friends, then they go to chemist, get the drug, nothing happens, they go to probably to quacks, then their family practitioner, and ultimately they come with us. So we have very large responsibility to see that they should get relief or they should get the proper advice. Second questions, about 5 years back, everybody used to talk in even the national meetings, resistance. Then I started working, is there really resistance or people are talking very easily or without much attention? So started working. So the first question, I'm conducting a lot of webinar on this antifungal for last 5 years. Almost I have conducted 97 webinar on antifungal. Then we conducted the poll. What is the percent of the patient when they come to your clinic? What is the percent of the patient they respond to treatment? So it is more than 75%. So when you start antifungal, anything, itraconazole, terbinafine, griseofulvin, and patients start responding, that means it's not resistance at all. It is clinical failure. This clinical failure word we are using since 92, 93, because in HIV, in the oral or esophageal candidiasis, we used to use fluconazole. Patients were not improving, but when their CD4 count is to rise, with the same fluconazole, patients were responding because their resistance or their immunity was less. So that is called clinical failure. That is not resistance. The meaning of resistance, any amount of concentration you increase, for example, MDR TB, instead of 450, if you make 1,000 of rifampicin, organisms are not going to respond. So that is called resistance. So most of us, this is the first research I did about 4.5 years before I started talking about there is hardly any resistance. There is resistance, but very rarely. In fact, in our clinical practice, 99% we are dealing with a clinical failure, so I thought I'll cover this. So that is a clinical failure. There are many reasons for clinical failure, but the most common cause is a lack of counseling. Unfortunately, we are dermatologists are all the time busy. We do not have time. In my clinic, any patient of dermatitis comes, he'll go in the separate room. There will be one doctor who is spending 20 minutes to 30 minutes for counseling. How important is the counseling, adherence and the compliance for 6 to 8 weeks. And that's how we get the results. Of course, yeah. So the reasons for failure, there are many reasons. But one of them is inadequate duration, because many patients were practicing now. All of us, I think most of us, we have realized it has to be more than 6 to 8 weeks. Interruption therapy, tinea or dermatophytosis has become the chronic infection. When you talk about any chronic infection, interruption therapy is not going to work. Like fluconazole giving once in a week, twice in a week, is not going to work. Like MDR TB, why is on the rise? Because of dot therapy, interruption therapy. Interruption therapy, any chronic infection is not going to work. So don't use interruption therapy. Of course, chronic infection, proper counseling is very important, including malignancy, HIV, or anything. So compliance and adherence is very important. So the counseling is very simple. Tell them minimum therapy will be 6 weeks to 3 months in few cases. Do not apply soap. All family members should be treated at the same time. No steroids at all. And wash your clothes in boiling water or hot water and iron it. Very simple. And we followed this. With this, we followed about 100 patients with itraconazole and ibuprofen. And we found 82% of the patients followed for 1 year. There was no recurrence, no relapse. Only 18%, out of 18, 16%, there was problem with the compliance. So we did repeated counseling and we could work on it. And 2%, they were on immunosuppressive drug like prednisolone and methotrexate because they were suffering from rheumatoid arthritis. I consulted rheumatologists. They said, sir, we cannot stop these drugs. And I'll tell you, this was the question I asked Aditya Gupta, who is well known internationally. He said, I have not come across such patient. I was surprised. So when the patients are on immunosuppressive drugs like a cyclosporine for a long time, I think antifungal drugs, they work for a short time. When you stop it, they get relapse. Yeah. And there is hardly any patient who did not respond, so there was no question of cultural sensitivity or resistance. These are the patients followed for 1 year, hardly any relapse in 84%, even including the extensive lesions. Yeah, so this is just simple counseling, nothing else. And this is about, we started 4.5 years back. Then I realized people are, I think they are easily talking about resistance more than that. So now talking about the chronicity. This is the patient who was suffering from 2 years in spite of a lot of antifungal treatment. But then I started looking for the literature, and according to Journal of American, that this is a chronic disease. We are dealing with the cellular immunity, not we are doing with the antibodies, because antibodies are not enough to eradicate tinea or dermatophytosis. So we are dealing with the hypersensitive phenomena or cellular immunity. Like a Montu test, there is a test called trichophytid test. Trichophytid test is positive, that means the patients are going to respond very well, but that test is not available in our country. So of course, any chronic infection, what is important? The compliance. And Dr. Gnaneshwar Rao was talking about a cyclosporine, many patients they can't afford. Same thing, if the medicine is expensive, the compliance will be very poor. So we have to prescribe which the patient can afford, not the patient cannot afford. Then the dose and duration, there are a lot of literature. Some of the patient will be 6 to 8 hours, 6 to 8 weeks is okay, but some of the patients we have to go 3 months, and very rarely 6 months, those patients who are immunosuppressive drugs. Even here it has given this IADVL that antifungals should be used for some patient in 3 months. So commonly in that is about the duration. Then whatever the commonly mentioned in the book, that is not enough, whether Indian book or the Western books. So they are going by their own experience. But what is now what is happening is, what is our clinical experience is more important in our country, because I am attending a European and American meeting. They said we do not come across such extensive lesions. We hardly see any recurrence and the relapse. That was their problem, is they are dealing with only terbinafine, nothing beyond that. But we are dealing with a lot of things. Yeah. So role of updosing. Many people, they say itraconazole, 400 milligram, 200 milligram BD. But if you see, there is hardly any role of updosing. Even itraconazole, by updosing, it doesn't have linear pharmacology. So increase the dose is not going to increase the concentration. So updosing is not required. In one of that, our clinical observation study which has been published, I showed that where we have used itraconazole 100 milligram BID, nothing 200 or 4. So last 5 years, itraconazole are not used more than 100 milligram BID. 200, 400 we never use it, and we get good treatment. So now coming to, we have got many systemic drugs like griseofulvin, terbinafine, itraconazole or fluconazole, posaconazole, voriconazole, so many drugs are there. So which drug we should use it, that question comes to our mind. Of course, most of the time is written.
Excuse me, sir. The talk time is 15 minutes, is already over, sir.
How many minutes are left?
2 minutes is over already.
Okay. I'll
exceeded the time.
Yeah, last, yeah. So, the drug of choice, according to me, fluconazole, the reason being, if you say the bioavailability is also 90% bioavailability, metabolism, there is a minimal metabolism, penetration, it penetrates each and every tissue of body, including stratum corneum. In fact, stratum corneum fluconazole is 40 times more concentration compared to terbinafine and itraconazole. And this drug, there is hardly any resistance, very convenient, and is very safe, because we use in HIV 400 milligram daily for 9 months to 1 year. We have used it in many patients, is very safe drugs. I think, and this is one of the study from Dr. Kabir Sardana, if terbinafine and itraconazole fails, fluconazole works. I think, thank you very much. Yeah, and we'll go for the, yeah.
Yes, sir, your panel discussion, sir.
Next slide. Yeah.
Next panel discussion.
Yeah. Pavan. Shall I start? Okay. Now we are starting the panel discussion. We are very experienced doctor, Dr. Rashmi Kansha, who is my colleague from Mumbai. Dr. Rajiv Sharma could not come because of his ill health. Bhumesh doesn't need any introduction. Dr. Deepa is also from the Hyderabad. And because Dr. Rajiv Sharma is not coming, we requested Dr. Ravi Vadrehu from Kakinada. So please join us. Yeah, Dr. Rashmikant Shah was a vice president of our IADVL. He has worked with me in HIV for many years, in leprosy, and now he is more in the clinical dermatology and in dermatophytosis. Bhumesh, everybody knows this, so I am not. But only things I can tell you about Bhumesh, whenever I got any pediatric dermatological problem, I contact Bhumesh, because I found he's very good in pediatric dermatology. Dr. Deepa, she is from Hyderabad. She is consultant at Skin and Hair Clinic. And she, of course, she has got interest in clinical and cosmetic dermatology. So we'll start with the first question. When you see there are so many combinations, everything is flooded with steroid. So I'll start with the Deepa, one of the youngest one. Deepa, all of us, we know that they come with, any patient comes, they come to our clinic, sir, ye malam lagate hai. What is that, the combination? So how you are going to handle these cases?
Good morning, everyone. So actually in our side of city, steroid abuse is very much because of RMP practice and many non-dermatologists giving all prescriptions. So the first thing I tell them to stop the cream. Nowadays even oral steroids are also being used very much. So I tell them to stop all the creams. I might put them on high dose of oral antifungals. I counsel them to use it for a longer period. I tell them that already your cell-mediated immunity has come down, your resistance has come down. So compared to normal doses, we have to give high doses of oral antifungals for higher period of time. And I might give them some bland emollients because skin barrier disruption happens when we use steroids. And then we tell them to use lots of emollients and mild soaps, stop scratching, and antihistaminics, and the normal antifungal therapy should be given, but longer period of time they should use. First, I counsel them that steroids are bad and they should stop it.
Okay, thank you, Deepa. I think, Rashmi, you want to say something?
As you rightly said, that, counseling is very important. And counseling has one particular thing, that is questioning. Questioning and counseling are very important. The moment you see a patient who comes with a history of recalcitrant or clinical failure, you must ask whether he has taken treatment from RMP doctor or a chemist, very important. And if he has gone to a dermatologist for other reason, and if he has been using steroids for other indications like atopic dermatitis or something else, that is very important. Questioning is equally important as counseling.
Thank you, Rashmikant. Now the message is very clear. All of us, we know the counseling is more important than anything else. Because the patient, when they go home, I remember one of my friends tell, he prescribed antifungal, the patient phone is after 3 days, डॉक्टर साहब आपका दवा काम नहीं करता है, मेरा जो पहला ट्यूब है वही लगाता है, I'm happy. So the counseling is very important. So we'll go for the next question. Next question is about, next question is, Ravi, this child comes to your clinic, or many children are now they are coming to your clinic. It comes with this type of lesions. How you are going to manage them? About Ravi, I did not introduce. Ravi is from Kakinada. We are associated with each other since 94. I go to Kakinada every year since 94 to manage our HIV patient, and he has got very large number of HIV patients. Probably he must be having largest number of a cohort in HIV we are following since 94 in his clinic, and he is a person I learn more from him. You just mention anything about the fungal, he does culture and PCR in his own hospital. Yeah, Ravi.
Yeah, thanks, Dr. Saple. I'm a newcomer here into this panel, just which and you have pulled me into this.
Yeah, but he is going to add on it. Yeah.
So this is typically this kind of patient. I would treat with 150 milligrams of fluconazole or itraconazole 100 milligrams. But more important nowadays, of course, barring this 1 year of COVID, People will be wearing the school uniform right from 7 o'clock till evening 6 or 7 o'clock till they get off the bus. So I will definitely tell about the undergarments which will have to be specifically cotton make. And the second thing is about not wearing jean pants at any time. So these are the few things. Otherwise, the standard topicals and the standard oral agents will work. Usually in children of this age, the response is excellent, and usually 6 weeks time, we'll be able to stop. And application of lot of talcum powder is what I advise in my practice every day.
Okay, thank you. Bhupesh?
Yeah, the duration is 6 weeks. The child almost is less than 20%. I will opt for the topical therapy. Morning I advise emollients, and night antifungal therapy along with anti-sting with lifestyle modification. The reason behind the children's the epidermal turnover almost is 2 to 3 times more than the adults. So that's why even though if you give extensive by following rule of 2, even more than 20% of body surface in involvement, short duration, the topical therapy is sufficient with the proper counseling and the lifestyle changes. And the second thing is whenever you see the tinea cruris in a child, it's rare. But if you see tinea cruris in a child, we have to look for the source of infection. Unless until you address the source of infection, unless until you treat the source of infection, the recurrences is inevitable.
Yeah, thank you, Bhumesh. I entirely agree with him. In children, as far as possible, treat with the local application. If the lesions are limited, I can tell you local application works very well. Unless until lesions are extensive, and as you say, look for the contact of the mother, father, or somebody in the family, and then start with the systemic. But drug of choice can be even griseofulvin can be given, terbinafine and fluconazole. But I treated this patient with fluconazole because I told you it's very cost effective, is very safe, and there are literature that fluconazole is one of the safest drug in children and even in a lactating mother. So forget about adult, even is one of the safe drugs in pediatric practice and lactating mother. Only thing, pregnancy you cannot use it. So that's how we are using, only are using in children, the creatine clearance is faster, creatine clearance is delayed. So the dose should be, if there is a neonates, dose should be every 72 hours. After 2 weeks, every 48 hours, not daily.
Dr. Saple, when you say that, there are 3-4 drugs which can be used, I think when you have a patient like this and father, mother both are affected, choose a drug which is common for all of them, and that could be fluconazole.
Yeah, what Dr. Rashmikant is saying, use the same drug, so easy to take, easy because the patients are not in confusion, so use the same drugs, that's why he is advising. Now about the itraconazole. Itraconazole is maximally used in our practice almost. That day I was conducting one webinar from Cipla. So 86, I took a poll, 86% of the people are prescribing itraconazole. But after the webinar, I just say, what is your opinion? And you will be surprised, 75% they said, sir, we'll start prescribing fluconazole, but that was after the poll. So about the itraconazole, now what is called is the subaconazole, suba-itraconazole. So, Deepa, what do you think about this? Super bioavailability.
Yes, sir. About super bioavailability itraconazole, I have not much experience, sir. But I feel it is not much different from normal itraconazole, sir. So I have not used it much. Maybe some more time, if I use it, I will understand it better.
Ravi?
Yeah, it's like what Dr. Deepa said now. I have not yet extensively used this. I'm little doubtful about this. As long as there are no contraindication for the standard dose of itraconazole, I am comfortable using in the present standard doses. But Certainly there's good logic behind using a lesser dose with more efficacious molecule. I think we need more trials and more extensive experience before we speak on this.
Dr. Saple, what I think, there is a difference between these two in the concentration problem. When you use 50 milligram of SP and 100 milligram of itraconazole warmer, the concentration would be almost same. But other contraindications, what you have mentioned, remains the same. So in that case, when there are complications, contraindications, fluconazole would be still better.
Bhumesh, you want to add or will? Yeah.
Can I add one point here?
Yes.
My request to the audience also, there are so many experienced people in the teaching institutes and outside with very busy practices. Now we are all discussing these things from the Western published literature. The pharmacokinetic and pharmacodynamic studies in Indian populations are very woefully lacking. Unless we all put our heads together and do what is 100 milligram standard itraconazole, 100 milligram powder form and pellet form, and 65 milligrams the subaconazole, how they are doing and what are the steady state levels in the serum. Unless now there are so many pharmacy colleges across the country, if we work in tandem with them, then our discussions will be more meaningful. This what we can put it in juxtaposition with the clinical improvement, then we'll decide whether it is delivering or not. Hardly takes 6 months to 1 year to do such a study.
Thank you, Ravi, for bringing out this point. This is a very important point, that concentration in stratum corneum. Concentration of stratum corneum of what is called super bioavailability, 50 milligram itraconazole. There is not a single study. In fact, this 50 milligram is studied in Australia, where they are studying only for systemic fungal infection in malignancy. This has not been studied for dermatophytosis at all. So there is no study. They say the concentration is high in plasma, serum plasma, in the serum, not in the stratum corneum. And I remember Dr. Kabir Sardana, who is working on this research, he says stratum corneum concentration is more important for any antifungal drugs or systemic drugs. In fact, my experience when it comes to topical, I'll say, so the super biology 50, 65, they do not have any single study of their concentration in the stratum corneum. So unless until you get experience, we do not know about these drugs, but there are no study about this. Then coming for the next questions, I'll ask Dr. Rashmikant Shah only, because he's mentioned nowadays people are coming with 3 or 4 family members are affected. So which systemic drug will you use it?
What I understood from this slide is like, there are so
many
people
in the family are affected.
And if you see the drug therapy, we do not use only oral therapy. We also use local therapy, which is sometimes more costlier than the oral therapy. And I would prefer in such cases which is more cost effective. I would use fluconazole. Of course, that may be biasness also, but I use it fluconazole along with any kind of a local application. Even miconazole and clotrimazole does work as effective as laliconazole, and the lotions would be still better.
Ravi would like to add something to the many family members come together.
No, only point one. I think depending on the body weight, age, and the parental generation person, any cardiac issues are there in case you want to consider itraconazole. Apart from these things, I fully agree with Rashmikant Shah. The other day, exactly last week, I was speaking in Raipur about this. When we prescribe a loliconazole cream, which is costing 350 rupees to 400 rupees. So an extensive tinea corporis patient is going to spend 400 rupees in 2-3 days time. So he is going to spend 3,000 rupees a month only on topical alone. We need to really consider this. and some kind of shampoos or some kind of soaps I would prefer, and an emollient cream along with a good acting oral agent.
Even in my practice, if it is extensive, I won't go for topical therapy because it is very, very costly. So what I will do, emollients, antihistaminics, and systemic antifungal therapy. If there is no side effects and no comorbidities, virgin case, we can go with the terbinafine. Or any comorbidities are there, the patient is not responding with all these conditions, we can choose the itraconazole.
Okay, thank you, Bhuvesh. I think last Saturday I was at Raipur CUTICON, and one of the dermatologists from Bhopal, he was using ketoconazole shampoo, ketoconazole lotion for the local application. And Dr. Sahuji from Nagpur, he was using salicylic acid peel. So these are the local things. The lesions are extensive. There are studies. And I was talking with Dr. Ravi in the morning. I said one of the patient comes to me for last 1 year with all, whether it's itraconazole, griseofulvin, terbinafine, fluconazole, used to respond partially. For 1 year, I got fed up. Then what I would have done, I said, आप salicylic acid apply करो, दूसरा कुछ मत लो, because I was talking Dr. Jaydev just now about psoriasis. So Dr. Jaydev also told me, any chronic disease, patients are not responding, ask them to stop all medicine. Correct, no, Dr. Jaydev? About psoriasis you told me, no? So I stopped everything, started salicylic acid. Patient came after 10 days smiling. He said, doctor, what miracle you have done it. And I was talking with Dr. Ravi. So Ravi, can you share your experience?
My patient was actually, since I'm not prepared, I didn't bring the photos. This patient, who is a laboratory technician in a veterinary lab, has been suffering from 2018. So 3 years have passed, and by this February he'll be entering his 4th year of disease of tinea corporis alone. So his pockets are exhausted. My own patience also is exhausting. So 3 months back I stopped everything. I just gave him 2% salicylic acid. 95% lesions have gone. Only 2 patches have remained on the abdomen. This is what I have seen with my own eyes in a patient. So my simple logic is, stratum corneum is the substrate for the fungus. Let us remove the substrate there for the fungus and see what it happens. So that's what really worked.
Another point I would bring is like something like a biofilm, what we call. This is one of the reasons for possibly recalcitrant or clinical failure. In that case, for a formation of biofilm, salicylic acid would definitely work. And that is how, this is one of the mechanisms that can work.
Okay, so talking about the topical therapy, Deepa, you want to share any your experience?
I don't have experience with salicylic acid, sir.
Okay.
I should try
no,
now.
any other topical. Okay, so talking about the topical therapy, I thought I'll share my experience. As Dr. Bhumesh said, in children, as far as you use topical, but use only, because I have done one study, only use systemic, no topical, patient will start responding. But the day you stop systemic antifungal, within 2 weeks you will get a recurrence. This is one of the study I will be sending for the public. So topical therapy is more important than the systemic therapy. Then the same other group, we are giving systemic plus topical, there was no recurrence. And this patient only on topical, we switch on topical plus systemic, there was very good response, no. So topical therapy, as Ravi said, the substrate is stratum corneum. So you have to treat the stratum corneum, you don't have to treat the internal organs. So that is very important about the topical therapy. About the monotherapy, Dr. Rashmi would like to combine them, because there are many dermatologists are writing fluconazole, griseofulvin, terbinafine together.
See, when most of us say that there is no resistance, if there is no resistance, why should you have to combine 2 drugs? Probably, there are reasons for a failure. As you said, one thing is counseling, what is required. There are dual therapy is a prescription of frustration rather than anything else. If you cannot counsel well, even 2 drugs if you are giving will fail. That is sure.
So combination therapy give first, the patient can't afford single drugs. When you are giving combination therapy, how you can afford many drugs? Number 2, toxicity of drug. Number 3, pill burden. And number 4, the compliance and the adherence. Everything is going to get hampered. And I'll tell you, last 5 years, I never used 2 drugs at all in my clinic. And the results in my clinic, no relapse, no recurrence, is almost 84%. So according to me, no need of using 2 drugs or 3 drugs.
And the candidates for monotherapy, children's.
Oh, it is acceptable?
Yeah, antihistaminic, monotherapy with the topical therapy.
And
pregnancy. Where in the first trimester we cannot give any, except B complex, we cannot give any. So emollients, antihistaminic to break that scratch cycle, and topicals.
Okay. Next question they asked, when you combine the topical and systemic, whether it should be from the same group or it can be other group. Rashmikant or Ravi, whatever you are.
As far as I am concerned, I use both of the same class, and there is a good synergy even with laliconazole, ketoconazole and abarconazole. There is hardly a difference of 1 or 2%, but if it is individual, if you count, I am a private practitioner. I count it as individuals. I don't have a large studies like 200, 300, 400 where 2% makes a difference. So I have a good synergy with the same class. And at the same time, I tell you, there is a good synergy of azole derivative and amrolfin local applications.
Yeah, thank you, Rashmikant. So if you go for the science or literature, whether used for the same group or other group, there is a synergy. You can use whatever. But I feel personally, where you are talking of the MIC required is high, better you use same group, so you are maintaining high MIC. That is my experience. So I thought, now when you are prescribing the topical, what is important is the vehicle and viscosity, because many times when you prescribe like laliconazole, look for the Pascal, that is 2.9 and 5.9. So any drugs, which company you are prescribing, that is immaterial. So look for the Pascal score, that is 2.9, that is called the good one, that has got better absorbability, sterility. So that should be the look for, when you prescribe, look for the viscosity. About the vehicles, what we require is a medium chain triglyceride, MCT. These are the 2 things you must look for when you are prescribing. There are a lot of advantages. We'll go for now the main patients coming with the recurrence, relapse. So Ravi, what is your message for them about any patient is coming with the relapse or recurrence?
So as is the experience of audience and the panelists here, there are several patients like this who are coming with recalcitrance for more than 1 year, 2 years like this. Really how to call it, whether clinical resistance or true fungal resistance, we are all breaking our heads. So my experience, as I am observing your observations, you are quite happy using fluconazole. I have my experience, I have seen patients failing on fluconazole, shifting to itraconazole, they have bettered. Patients failing on itraconazole, they have bettered with fluconazole. But terbinafine is not really consistently giving good results. This is my experience. So as I told, and Rashmikant Shah's observation, in rarely desperate cases out of frustration, in 3 patients I have given 2 agents. I know it doesn't stand the logic, but it is a prescription out of frustration. About 3 or maximum 4 patients I would have given. So that's the kind of frustration. So it's an ongoing story. So change the molecule and then see. This is what I think.
Thank you.
One of my observation, I would say, it is not a study rather, that using fluconazole, of course, as he said that, some patients respond well to itraconazole and some patients respond well to fluconazole. Both could be at par. Maybe I think fluconazole is better, And if you compare, as far as when we say resistance or something, relapses, up to 3 months, there could be, both could be same. But after, if you see 3 months, fluconazole results are much better.
Okay, Deepa, about recurrence or relapse, what is your experience? Or you allow patient to go to other dermatologists? They will be very happy.
Counseling is more important, sir. First, I tell them that whatever oral agents I'm giving, you have to finish the course. You have to complete the whatever 4 or 6 weeks course I'm giving. Along with that, I tell them to maintain the personal hygiene and all these things, loose cotton clothes and keeping the area dry, emollients in this season. And along with that, I give them my drug of choice in most of the cases is itraconazole, sir. So 200 mg OD I give. Along with that.
Yeah, I agree with Deepa, because any patient comes to you, changing of the drug is not important. Talking to them, counseling, adherence. Whenever any patient comes to my clinic, sometimes proudly I say, sometimes we also become proud, I say, I start the same drug, same company, but you have to take regularly and the patient improve. Because you have to develop that much confidence. Many patients, they come to my clinic, I said, यही दवा लीजिए, itraconazole, fluconazole, whatever is there, because you are responding, but they were not taking regularly. So what she said is absolutely right. You have to spend time with the patient and see that their adherence and the compliance, because most of the drugs are working, there is hardly any resistance I have seen.
Now sir, dermatophytosis, it has become a lifestyle disorder. So we have to make it in order, because rather than the recalcitrant, what is the cause for the recalcitrant, that we have to look for. It's only directly the patient will go to the medical shop and taking medication, combination of creams, because this has to be addressed. Especially the young age group, teenage groups, directly they'll go to the medical shop and take the medications. Yeah. So in my practice, generally I'll follow, if I see the recalcitrant, I'll follow the rule of M square. Always the medicine and mind will work. Because in the pre-adolescent, always you involve the caretaker or mother. Unless until you involve the caretaker or mother, the treatment is 50%. Whereas in adolescents, neither they are children, nor they are adults, they won't follow the instructions of anybody. Whether it's a father, mother, doctor, whoever it may be. You involve them. So unless until you involve the mind of the adolescent, the treatment is incomplete. The remaining medicine as a doctor, my role is with medicine is 50%. So unless you take care of the adolescents or the caretaker, the epidemic, it will continue.
I think this is a good message, not for the tinea, for everything, any chronic disease, unless until you involve the patient and you don't take a decision. Decision has to be in accordance with the patient. The patient should be ready to accept. That is the, yes.
I want to add one point. These points, what you have told about compliance and the same tablet, counseling are well taken. In my practice, where something like this appears and I realize that it is going to be recalcitrant, it is at that point I am resorting to culture. I have over the last 3 years, I have cultures of more than 1200 patients. When I analyze this data, about 10% of these organisms are non-dermatophyte molds, like fusarium, like Taleromyces, like other species. Okay, in these cases, when I know that this species is different from the routine dermatophytes, KOH also is usually negative there. So KOH is not positive, but culture is positive. And then itraconazole is working on those things. So I think it's time you train your neighborhood laboratory in a good Seborrheic-based culture where you are able to identify the organisms. At least I am finding out of these 1200 plus specimens, more than 10% are odd species. Microbiologists are not agreeing. My own microbiologist, who is an assistant professor in the medical college, quarreled with me on this, saying that this is a contaminant, I don't accept this. I proved to her with clinical photographs, KOH, response to therapy, and serial cultures. I proved that it is the same organism, which is other than the 3 genera that are usually causative. So this one has to keep in mind when we are talking about recalcitrant cases.
Thank you, Ravi, because they should be in the, yeah. Yes, sir.
Somebody to hand over a mic there, please.
Yeah, please. Yeah.
Hello. Yeah. I am Dr. Manmohan, sir. This is regarding the statement of salicylic acid used in fungal infections.
Sir, can you remove the mask and talk? Yeah.
Yeah. You said 2% salicylic acid. That is a keratoplastic. So keratoplastic will not help. Anything above 3 is keratolytic. So that has to be like our age-old Whitfield's ointment, what we regularly use, should be more effective. Or I want the opinion from the panel regarding, can we have a suggestion of having an antifungal with a salicylic acid combination? That is
I think what you say is absolutely right. It has to be 6% or more than 6%. Yeah.
More than 3% is keratolytic,
Yes, correct,
but keratoplastic is, in fact, it may aggravate.
That's why they say they're using 30% in peel, salicylic peel, they're using 30%. Yeah. What is the second question?
Second, sir, in the one of the moderators were saying we use talcum powder antifungal soaps, which our IVA guidelines say that they may cause unnecessary resistance because you are giving homeopathic doses. Those
Yes, sir. Talking about the powder, lotion, and the soap, it's very clear the concentration is so less, should not be used as a treatment. But this can be used as a prophylactic. There is one study from Manisha Singh from the Nepal. She has followed for 1 year those patients who are cured. 100 patients she has given this prophylaxis and 100 patients, and they found patients who are not given prophylaxis, their recurrence was 47% at the end of 1 year, and those who were given prophylaxis, it was only 13%. So this can be used as a prophylaxis, it should not be used as a treatment. I entirely agree with you.
Thank you, sir.
Yeah.
Sir, you have
Yeah, we'll
5
go.
minutes more,
Yeah.
sir.
Yes,
5
sir.
minutes.
5 minutes, okay. Yeah.
Sir, one more
Sorry,
question,
sorry.
sir.
Yeah.
One more question, sir.
Yeah.
Most of the TNS, most commonly we'll see in obese patients. In obese patients also, do you recommend itraconazole, 100 mg PD, or do you give according to the body weight?
See, according to the weight, you have to increase. That is above 75, you can raise the doses. But itraconazole, you can make it 200. But see that when you are using 200 BD should be used for 14 days. Then you can use once in a day. Because first 14, it has to be BID. It cannot be OD. Even it is 400 milligram because it doesn't work. So doses can be raised in certain cases, as you said. So we'll go for the next. This is the patient for the panelist. This patient has come with this is one of my study where because I told his FDC that there is no proof, there is not a single trial of fluconazole every day in the world. So we had to do the trial. So we have started trial about a year back. In the last week I completed a trial. So these are the cases. From these cases, this is one of the case. She has come with the extensive lesions, panelist. After 15 days, see, everything is clear. But after 1 month, everything has recurred. So I would like to start with Dr. Deepa. What is the cause in this patient? The causes are very simple. That's why I am showing these cases.
Maybe the dose is not enough, sir. She has not used it
Dose
properly.
was enough because she was
Compliance.
responding. She was responding.
Any family members infection must be there, which we have ignored.
Yeah, we have taken that history. There was no history of family members. Yeah.
Comorbidities, we have to see for
There was no
comorbidities.
comorbidity, yeah.
Okay, sir.
Rashmikant. So these are the various
the
reasons you have to look for.
Patient became all right, and she must have stopped it immediately. The moment she stopped, you have to use this drug 2 weeks at least after the total cure, clinical cure rather.
So,
and to probably again when they get a small lesion, they go to their original therapy of steroids. combination.
Yeah, but this patient had complete cure.
But book
So,
says,
yeah.
book says the 2 weeks beyond the clinical clearance is for the Navy cases. But any recalcitrant conditions, even after clinical clearance, 2 weeks is not sufficient. We need to give
Anyway,
another 2 weeks.
I'll come to the ground reality. This patient, because of COVID, she went to her native place, she did not take the medicine. Simple, yeah, she did not take the medicine, she came. You know, these are the very simple. After 8 weeks, we started the same medicine, everything got clear. So, these are the very simple things where the counseling is required. This is the another patient, she came with the extensive tinea. We started with the, after 8 weeks, see, everything disappeared. But this patient came with, डॉक्टर साहब अच्छे नहीं होते हैं, स्टिल खुजली चालू है, ये होता है वो, means they came with a complaint. So Ravi, what do you think about this patient?
Maybe irregular treatment only.
Pardon?
Maybe irregular treatment.
Yes, she has completed 2 months, doing
2
very
months
well.
and irregular.
Yeah, yes.
Maybe lifestyle, using the same clothes again and again, and it is reimplantation of the fungal spores onto the body. Typically, I advise 3 times change of the bed clothes, including the pillow cover, and undergarments to be changed. Undergarments have to be cotton.
Yes, correct. Bhumesh?
Yeah. The patient adherence is very important. When you see the recurrences, always you look for the adherence. And to avoid that, when the patient is symptomatic, you need to explain the importance of the continuous course with the dose and duration is very important. Because when the patient is asymptomatic, they won't follow the instructions of anybody. How beautiful you are, how handsome you are. But when the patient is symptomatic, you insist that this is the treatment you should follow to prevent the recurrences.
I think, Deepa, because of this time I am going ahead. See, this is the patient, any patient comes, they said, then we think of recurrence. You don't be in so much hurry. This patient look for, there are no signs of activity, there is no erythema, there is no papular rash. What is there? Only the dry skin. So this is the patient, usually they respond to emollient. We started moisturizer, everything disappeared. So everything patient is coming is not the recurrence. So I thought I'll share with this. Deepa, you want to add anything to this?
Other focus of infection like nails should be examined, sir.
Yeah,
Sometimes
so it's
there is a
so,
reservoir
yeah,
of
correct.
fungus in
But
the
I want to
nails.
tell you, this is not reinfection. This is just dry skin and itching, nothing else. So look for the sign of activity because everything is not recurrence or relapse. Yeah. So this is the next patient. This patient came. I think this is the last patient. Yeah. So we started treatment. See, at the end of 5 weeks, everything is clear. Then he came with the recurrent. After 10 weeks, he has come with the recurrence, but recurrence is the other side. So Dr. Ravi, what you say? This is
implantation from somewhere else. So scratching nails or as you observed in your talk, untreated or unattended onychomycosis can be a reason for these things. So the nidus may be there.
Could it be because of dogs or cats in the, or some source of infection in the home, which is not human?
Of course, we can look for the, but this patient has applied steroids. Yeah, because when they, it's very difficult to control patients. After 12 weeks, we started with the counseling, everything became all right. So these are the various cases. This is the last case. Sorry. This patient came, she was taking treatment for antifungal for 2 years. So how you are going to manage, Rashmikant?
Of course, what I see from here is like, infection which is probably steroid modified. So I would, first thing I would do is stop steroids immediately. And I abruptly stop, unlike many who says that, and then put her on either itraconazole or fluconazole.
Okay, thank you, Rashmikant. But this patient, the first question I asked, they said there is no itching. Where there is no itching and 2 years, so I said any patient come for the long period, always do biopsy. It turned out to be lupus erythematosus because now we are over-diagnosis. This is another patient. He came with a severe itching with a round like patches and for last 2 years. How you are going to manage this patient now, Deepa? Of course, as Ravi says, we got a KOH done, KOH was negative. Then sometimes we have to do a biopsy. Because I was thinking of atopic, that patient, because 2 years, we did a biopsy, and the biopsy you can see this mycelium. So rarely we have to do a biopsy. I think we'll close it.
So one point can...
Yeah.
This is regarding the reinfection part, what we are talking. So in my observation, once the treatment is done, the infection is coming back, and that too only on the buttock area, lower buttock area. So I just wanted to know the opinion of the panelist and moderator, sir, whether use of Western compounds, which we are doing nowadays a lot in public places and office places, so can we, that way it is possible to get an infection done? Because infection, most of the ladies, they get it on the lower back.
Using commode, we are using commode, so whether they are getting from the commode. So what is your opinion?
Yes, sir, it can be a possibility, but if a proper hygiene is maintained, I think that can be overcome.
What is the proper hygiene? She is working in a high-tech city, and then they have to use the stylets.
Yes, sir.
So there are some cotton-made rings available which can be put on the commode sheet, and they can use it and throw it off. Use and throw.
Disposable, he is suggesting disposable, but as you said, there is hardly any studies. Somebody has to study, but this is the hypothesis he has come out. Somebody has to study, but in the reality, we do not know. Thank you, sir. I think, and the last message I want to give.
One question.
Yeah.
Here. Suppose if it is a persistent recalcitrant dermatophytosis, can we give oriconazole?
Yeah, this is a very good question. Oriconazole, I working because I'm attached to the hospital. There about 100 oncologists are working, 100 oncologists, 200 diabetologists are working, and I'm the HIV clinician, so I see all immunocompromised patients. There, they are using oriconazole very rampantly. Oriconazole is for the systemic fungal infection, number one. Number two, oriconazole study has been done by, I forgot the name of the dermatologist for Indonesia. She is working now as a dermatologist plus mycology. The concentration in the serum is very high, but concentration in stratum corneum is very low. So oriconazole is not drug for the tinea or dermatophytosis at all. There are 2 trials where they have used the local and oriconazole, and both the trial, the lesions are limited. Yes.
And recently one paper reported from Bangladesh, around they given for treatment failure cases 500 cases, and in the paper they said it is working very well in treatment failure cases of dermatophytosis.
Yeah, but those are the paper, that's what I'm saying, there are limited number of patches, and when there are limited number of patches, I can tell you, just apply local, you don't require systemic. And this is such an expensive drug, we have to keep for the emergency, for systemic, and the concentration in stratum corneum is very low.
Dr. Saple,
yeah.
In the era of COVID, when variconazole is supposed to be associated with mucormycosis,
yes, correct.
Mucormycosis, we should not use such drugs
Yes,
which can cause a harm.
Correct.
Maybe it is social problem then.
And what about the cost? Of course, yeah, and there are hardly any study, anecdotal reports are there. Now, before closing, I would like to give one of the messages according to me for last 5 years. Fluconazole is for tinea infection. Fluconazole is a drug of choice for the masses, but use daily doses, because one of the disadvantages of fluconazole, it lasts in the stratum corneum 20 hours to 30 hours, in pediatric 20 hours, in adult 30 hours, so it has to be repeated every day. In Candida, the concentration required is very less, so use once in a week is enough. But in dermatophytosis, it has to be every day. It cannot be once in a week or twice in a week. And thank you very much, all our panelists and the chairman, co-chairman, thank you very much. And thanking everybody for the patient listening.
Thank you very much, sir. Thank you, the supply, sir, and the panelists.
I now request the moderator, sir, panelists, and the chairpersons to kindly assemble at the photo booth. The next session is Dr. B.G. Ranade oration. I now request our chairpersons, Dr. T.S.S. Lakshmi Madam, our former DME and the former HOD of Usmania Medical College, and Dr. V. Gauri Madam, former HOD of Usmania Medical College, to kindly start the session.
Check, check. Check, check, check. Check, 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 check.
కొంచెం గైడ్ చేయండి కొంచెం వినపడదండి నేను చెప్తున్నాను చెప్పిన ఒకసారి ఇక్కడ తక్కువ Good morning, everybody. Attention, please. I request Dr. Jaydev Batrukar, the Speaker of the oration, to come on to the podium. Dr. Jaydev Batrukar, please.
I congratulate Dr. Jaydev Batrukar for the B.G. Ranade award. I request Ramakrishna Satalkar sir to come onto the dais, who is running the Ranade Trust. We have other dermatology awards from the Ranade Trust. That is, one is in IMA, the other is his. Now I have the pleasure of introducing life sketch of Dr. B.G. Renade. Dr. Bhanu Govind Renade was born in 1903 in Pathan district, Satara, Maharashtra. After schooling in Pathan and MBBS graduation from Bombay University in the year 1929, he shifted to Hyderabad in 1931. Dr. B.G. Renade was appointed as an honorary consultant in Skin and VD Department of Usmania Hospital and Usmania Medical College since 1931. He was a founder member of Maharashtra Mandal and also Indian Medical Association. A trust was created to look after his belief in philanthropic activity. This trust has been donated generously to Andhra Mahila Sabha and also runs a free medical OPD in Maharashtra Mandal. Both husband and wife have donated generously during and after their lifetime. He died on 27 January 1976 in Hyderabad. In his memory, we have this B.G. Renade oration, which is this year awarded to Dr. Jaydev Betrukar from JSS Medical College, Mysore. Dr. Betrukar. There are two medals for him. We'll first, before the oration, we are handing him Dr. Jaydev Betrukar. Dr. Lakshmi, madam.
I had the pleasure of meeting and talking to Renade because I came to Hyderabad in 1972. So the last part of it, I had the pleasure of meeting him and talking. All of you are seeing his photograph. I've seen him in reality. That is the pleasure.
A well-run trust by not his family member, but anything. Dr. Ramakrishna Satalkar has to be thanked for his efforts because running trusts is not a small job or easy. Thank you. This part is only one.
That is more than sufficient. MD from BMC, Mysore, Bangalore.
Sorry for the delay. I will introduce Dr. Jaidev Betrurkar for the benefit of the juniors because we know him since long, who has been in JSS Medical College, Mysore. Jaidev Betrurkar, former professor and dermatology and SGD, JSS Medical College, Mysore, did his MD dermatology from BMC, Bangalore. He has been in teaching profession since then. Presently, he is president IADVL, as we are all aware, and served in various capacities in their Bangalore IADVL and National IADVL, and he has been a driving force for those associations, and he is an active member of their association and teaching faculty, and he is an examiner and prepper setter to many things. Has conducted many conferences, and it is a brief list of his achievements, but he has got many more. As we are delaying, he concluded at this stage. Now I request Dr. Jaidev Betrurkar to talk on the topic of yes.
Yeah, good morning to all of you. I'm very proud that I have two of my very respected Madam, Dr. Lakshmi and Dr. Gauri chairing my session. It's a very proud moment for me. I also would like to thank the organizing committee and also the Telangana IADVL for honoring me with this prestigious oration. Yeah, I think my topic today seems to be a little controversial. I'm sure I'll be touching some raw nerves when I speak about this. It's just an effort to say that or put a little bit of thinking into our mind whether we can do this or not. That is the only idea of talking about this particular topic. It doesn't come here.
That is there.
इसमें नहीं आएगा. ऊपर करने के लिए. So let's just see what integrated medicine is before I go to where we can use it as integrated dermatotherapy. Please don't mistake that this is what we are fighting against as mixopathy. I am definitely not talking about mixopathy at all, what we are, IMA and many of us are against. So it is just an integration of various medications or systems. Integrated medicine or integrative medicine is
basically defined as a combination of a broad spectrum where we combine, amalgamate all the Western medicines and also the alternative medicine or the complementary medicine and also traditional medicine, also called as ethnomedicine. And it was clearly defined by Rees as integrated medicine, or what is it's called as integrative medicine in US, as practicing medicine that selectively incorporates CAM, that is the complementary and alternative medicine, along with the orthodox medicine that we all follow. Yes, of course, the principle here is to treat the patient as a whole rather than a disease-specific, and use the appropriate therapeutic modalities for the benefit of the patient. Of course, the proponents of this particular integrative medicine think that it is, or believe that we are treating the person as a whole rather than the disease itself, and it brings about good patient and physician relationship. That is what the proponents of integrative medicine talk about. But of course, the problem here is, if I talk about this particular integrative medicine, many people think what I have written there. That is, patients do have approval of this. Patients do approve when we say about integration of various systems into caring of the patient, but there is definitely disapproval by the people who practice evidence-based medicine. That is, most of us who believe in evidence-based medicine. So this is a dilemma or the problem with integrative medicine. This is what was defined by Ryan et al. This is again in the Indian Journal of Dermatology. So it means that integrative medicine is being talked about even in Indian setup also. Now there are different types of medicine. We all know that. That is allopathy, the alternative medicine, and the traditional medicines that majority of our patients follow, but we often disagree with these patients. I don't want to talk much about the allopathy that we are following. The alternative medicines, here the users of this believe or perceive that this works very well. But of course, this does not stand the scientific method of proving the efficacy of this. And this is not a part of biomedicine because the evidence is very much lacking here. And of course, sometimes it contradicts our belief in what we think is the principles of biomedicine. So that is the biggest problem with alternative medicine. So we have all these things, that is the Ayush as the alternative medicine. Along with that, they have added naturopathy, the energy-based medicines like magnetotherapy, electrotherapy, and so on and so forth. Then we have the traditional medicine, which is nothing but the knowledge and the skills of a person who practices it, and also the cultural belief in those areas where it is practiced, like traditional Chinese medicine and also American folk medicine and so on and so forth. So these are all the traditional medicines, but where it is all the patient is being treated and physically and mentally, and the patient gets some relief. Again, this lacks any evidence, absolute evidence. There is absolutely no evidence for this, the efficacy or how it works. Now these are the various traditional medicines, that is the traditional Chinese medicine, home remedies, and various pujas the patients do. In fact, in Karnataka it is very prevalent from where I come. For wards, the only thing most of our patients do is to go to a place called Nanjangud nearby Mysore and offer a bag of horse gram to the Nandi there, and they think that it cures. So I always tell them when they come back to me, I tell what the God couldn't do, I am definitely cannot do this for you also. So that is the belief in them. So these are various things patients believe. Now this is another one, that is complementary medicine, which we use as an adjuvant to our conventional medicine, like diets, lifestyle changes, yoga, and all those things which are being advised by us already now. Many of us advise lifestyle changes to most of our patients of psoriasis or any other disease for that matter. Now, the question comes, do we need to integrate at all? Of course, many of you may not believe or many may not agree with me when I talk about this. So should we integrate or not? Because I'll just present this particular case of a 40-year-old male who had used so many medications, including native medications. We had treated him with very other drugs. Nothing was working, or whatever was working was very partial, but the patient was frustrated. He wanted guaranteed cure, which we could not give him. Of course, the disease was psoriasis. We had given him methotrexate and whatnot at that time. This was quite some time back. So he wanted guaranteed cure. He wanted to follow any other system we could suggest to him. And we didn't know what to do. We were in a dilemma. So we told him to choose whichever he wanted. He chose naturopathy. And believe it or not, along with the drugs that we were prescribing, that is methotrexate, and the naturopathy did help him to a certain extent. It's not that he was completely cured or completely relieved of the disease, but he was about 80 to 90% cure, and he was very happy with that. So he could go work and lead his life normally with that much of clearance. So it was a belief in him, and the drugs which we were giving also started working to a certain extent. Now, why we know that allopathy does fail. It is not that panacea for all the diseases that we have, both whether it is the systemic diseases or cutaneous disorders. We know that it does not work all the time, because many of the diseases we know that the cause is not known, or sometimes the patient may use inadequate dose or may not be compliant. Then there is always a peer pressure to use second opinion, and sometimes, and of course we know that there are non-responders. Some of our patients, percentage of our patients are non-responders, and as and when the patient comes or as and the patient changes the doctor, we also change the drugs. That is very common for us. We really don't want to follow the same drugs that the other doctor has given. That is our probably the ego issues or whatever. And most of our patients do have high expectation, and the cost of the treatment also is quite high in our patients. So this is a particular 2011 article which says why there is a need for integration, because we know that there is a good popular belief that the complementary and alternative medicine works, and there is a lot of interest among patients to use them. And globally, many governments are now considering combining the biomedicine with alternate medicine. And there is a scope for doing clinical research. Morning I was talking about this. There are no evidence, but yes, we can develop evidence because we have the technology and the manpower to do this. So we can do research, we can do clinical trials and prove that whether this works or does not work. And it may, in fact, benefit most of the cases which are very difficult to treat. And we know that some of our diseases are psychosomatic in nature, so they may also help there in that. And of course, this integration is possible only in the therapeutic level. We may not be able to integrate this in the pathophysiology or the pathology part of the diseases that we are dealing with. So a team also effort or a team approach could be of much help to most of our patients. And of course, yes, as and when we go on, we can probably develop a guideline for using these type of medications for the benefit of our patients. So this is International Journal of Dermatology where this was published. Now, but we also have a lot of hesitation. Of course, most of us have hesitation. Why we don't want to use Ayurvedic or other traditional medicine along with our drugs. Why is that? Because we believe that in allopathy there is a measured level of evidence, and it can be measured and proved or disproved very easily, whereas alternate medicine does not have a measurable evidence, though it has evidence, but it is not a very well measured evidence, and traditional medicine, of course, does not have evidence as of now. As of now, we don't have. Now, this is the evidence that the biomedicine has. There is a pyramid of it, which is as we go up, the level of evidence also becomes more stronger and stronger and stronger. So we always prove our drugs or disprove our efficacy of our drugs or our method of treatment by going up the pyramid. Whereas if you look at the Ayurveda, Ayurveda also has a sort of evidence. This is called silver evidence, the golden evidence, and the diamond evidence. I cannot read out the names of that, they are tongue twistings for me. And also that is for diagnosis, and they also have a level of evidence for therapy also. This is what is told in the books about Ayurveda, about the evidence about Ayurveda, but this is not been proved by randomized clinical trials or where they have used the drugs in a better way. But that is what, but now the evidence or the thinking among Ayurveda practitioners is that they need to have some evidence-based Ayurveda. So what previously they were thinking was whatever they are doing was the best possible. So they didn't want to bother much about developing evidence. So now they are into trying to develop evidence for the use of Ayurveda in various treatments, because they were not inquisitive about how their drugs work. So that was the biggest problem. And they always thought that their drugs are better than anybody else's drugs. So now, okay, oh, sorry, it is not changing here. Okay, sorry, I'm sorry for that. I thought this was changing here. Okay. So now they are thinking of having a evidence-based Ayurveda or evidence-based practice and trying to do some various research and also have a clinical experience. That's again in 2013 they started thinking about all these things. There is something called science-based and evidence-based Ayurveda also, where they are looking for the more efficient means to improve their care to the patient and prove that their disease or the drugs or the method of their treatment works. So this is called as science-based or evidence-based Ayurveda. So this is also they are looking at as to how to popularize Ayurveda in the regular practice. Now coming to this homeopathy, okay, I don't want to talk too much about this. Homeopathy, some people believe there is an evidence, some people believe that there is no evidence. This is what they say about the presence of evidence, again, for homeopathy, that because it is a sort of a approach to the wholesome approach to the patient, so they think that it works. And there were some systemic reviews where it also said that homeopathy works. But if you see the further one, it says that homeopathy does not work. Okay. It's a controversial subject and it is no better than, people think that it's no better than the placebos. So there is a clinical evidence is lacking here again. And again, the belief among homeopathy practitioners is not to develop evidence, but they say that we don't want to know how it works. We just want to know that it works. So just as long as it works, let it work. Why should you bother about how does it work? So that is what is the thinking among these people. But of course, the burden still lies on them to prove their drugs work, but somehow no effort has been done by the practitioners of homeopathy as to how it works. And this is in a lighter vein, that as you know that homeopathy doctors keep on diluting the drugs as they use anyway. But surprisingly, this is a WhatsApp group of Indian Dharma docs. Okay, this is nothing else. There was a poll. One of the Nobel laureate, Venkatram Ramakrishnan, he had put up a poll where he wanted to know whether people believe in homeopathy or not. Now, this is not done by Indian Dharma docs. This is about this was posted in Indian Dharma docs, IADVL. So here, if you see that around 65% or 66% of the people thought that homeopathy works and they have faith in homeopathy. Now, why I am talking about this is, there is a faith among people, and we need to play with on their faith in this and add to our drugs, so that we give a better result to these patients. I am not propagating homeopathy anyway in that matter. The others, of course, the yoga, Unani and Siddha, naturopathy, of course there is no evidence as of now, but in clinical experience we know that they do work, especially yoga in combination with certain, along with our drugs, does work in some of the patients. At least the patient feels better. Probably it is because of the lifestyle changes and also the regularity and the mental satisfaction that they get. Now, I am talking about integrated medicine, but does it really has any value is the question. Probably many of you are skeptical about what I am talking about, but look at it. In Japan, in 2012, they formed a group to say that look into the efficacy of integrating medicine, that is the biomedicine and also the traditional medicine and the alternate medicine. So they have a group which can, the concept of integrative medicine to improve or look into the efficacy of that. And same also is in US. They have a different office which is called the National Center for Complementary and Integrative Health. So there is a interest among other countries also to use or to integrate the medicine systems of medicine to give better cure or better result to these patients. It's not only in India that we are talking about, even in many of the other countries also are talking. Of course, even in China, there is an effort to do this integrated medicine. So, coming to dermatology, why should we integrate? Should we or should we not? There are so many diseases which I can enumerate here that we really do not know why they occur most of the time, and most of the time our treatments for which majority of these diseases are prolonged and not very satisfactory. So these are some of the diseases that we come across on our day-to-day practice, and we have sort to say 70 to 80% answers to these diseases, but not always the 100% result. Now, why should we look at integrating therapy of in dermatology practice? Because, as I said, we do not know the cause of the diseases. To majority of the cause of diseases, we do not know the cause, exact cause. There are theories, and we also know that most of these diseases are multifactorial, because lifestyle, autoimmune, the viral infections, and so many theories are there, but none of them proved beyond doubt. Then majority of our diseases are also psychosomatic in nature. So psych also plays a large role in the treatment or in the causation of diseases. And we all know that the treatment is pretty long. Say if you take psoriasis, it is quite long. And we offer only good to better results and not complete cure in majority of them. That is what I said, they can be controlled. And of course, the cost. As the investigations, as the newer drugs come, the cost of the treatment also goes on increasing, so also are the side effects of these drugs. So this is why we may have to consider looking at integrating with other systems. Now, integration doesn't mean that we follow the other systems or the other systems follow our treatment. It is only act as a complement to each other rather than one system being followed by others. So it may bring about better cure and may have a fasting lasting benefit to these patients. So that is what probably we should think about. And also we can bring in about newer modalities of treatment by combining these. And of course, we may be able to reduce the cost of the treatment and bring in more psychological satisfaction to the patient. And more importantly, we can do a lot of research. Okay. So that is where we are research work is very, very important for all of us. We know in IADVL also gives around 50 to 60 lakh rupees for research by members. So why not we talk about integrating our research with other medicines, other systems also. So we can do that, and we can develop an evidence for using these systems along with our treatment, not that we follow only their treatment or they follow our treatment. And we can develop patents also. This is one more thing that we can think of really. Why not take up research work on these? Now, if you see this particular topic or the slide, now they say that complementary and in alternative medicine dermatology encompasses the wide variety of methods and diagnosis and treatment or substitute conventional dermatological practice. This is also referred to as holistic dermatology. It draws from other knowledge from the other systems also for the benefit of the patients. And it can be used for diagnostic and therapeutic purpose, and it is integrative dermatology. If I tell you where this has been mentioned, probably you will be surprised to know where exactly is this particular statement has been made in using alternative medicine or complementary and alternative medicine in dermatology. Now, the practice of good CAM, though it lacks level of proof, is a good one for basics. It does combine the basic science and the clinical experience. In fact, many of our dermatological therapies were developed in a similar way, but then they were proved scientifically. Just take aloe vera for that matter. So we proved it after developing evidence, but it was being used by so many people much earlier than that. So this is holistic dermatology, includes all of them, that is combining the biomedicine with the other medicines like Ayurveda and all those things. And this is a chapter, there is a chapter in Fitzpatrick. Okay. That is where these things have been discussed. In 8th edition of Fitzpatrick, the general medicine or general medicine in dermatology and general medicine textbook by Fitzpatrick, 8th edition, this particular statement has been made. Now, unfortunately, the 9th edition does not have this chapter. I don't know for what reason that was removed, but this was there in 8th edition. Now, Dr. Narhari from Kasaragod has been doing a lot of work on integrated medicine, especially for vitiligo and also for filariasis. And they have developed a good evidence for the use of complementary medicine or alternate medicine along with the traditional biomedicine that we have been used. And they propagating that there is a way for us to develop evidence for integrated dermatology also, where we can use all of them. But there are challenges. Of course, there are too many challenges for us to do that. First of all, we are skeptic about all these things that should go, and then try and see whether we can do something about it. And there is a tremendous scope for us to develop integrated dermatology. Definitely there is, but we need to come out of that particular shell that we have and probably look at a larger way of doing that. Now that is what Dr. Narhari has been, telling us. Now, this is another one paper. Recently, I have come across that because we know that in developing countries, traditional medicine is a entrenched one. We all have experience, and sometimes we might have used traditional medicine also for ourselves. And in Europe, from 70s, there has been a big interest with complementary and alternative medicine. It has become a $1 billion business these days. And especially in US, it has become a $1 billion business now. But why this is being used? Because there are lots of adverse drug reactions to our medicines, there is increased cost, and there is more interest among the patients to go towards the nature and the natural remedies that we also see in our patients. So many of them use various drugs. Where did this come? These herbal remedies, including these are also being used for various skin conditions, and they are gaining greater popularity. And this is a paper again by Lotti and others recently in 2018. So that they have been propagating again integration of various systems into the management of dermatological disorders. What about in India? What has happened in India? Let us see what is the situation here in India. In 2017, the Ministry of Health and Family Welfare launched what we call the Bridge program to certificate a community health for Ayurveda practitioners, and this is absolutely against the belief of what integrated medicine is. So they wanted to develop a bridge course where the Ayurveda and the other system doctors start using traditional or the allopathic drugs. But that is exactly opposite to what really integrated medicine is. Integrated medicine is not training other doctors to use another system. It is only to integrate various systems of medicine in the management of one patient, and not training other system doctors to practice the other system. Now there are, as I said, there is a scope for us to have integrated medicine, to develop evidence and try and see whether we can help these patients. But there are many issues, because the biggest one is the Consumer Protection Act, and there are ambiguity whether we can use, or Ayush people can use allopathy drugs, or allopathy people can use Ayush drugs, and so we may be getting into problems, legal issues. There is one-upmanship among ourselves. The ego problems are always there. There is no comprehensive plan from the government authorities. They absolutely think the other way around. They have the wrong policies probably, and legal issues are still there. And we, allopathic practitioners, we have the strong regulatory agencies like MCI or the NMC and so forth, and even the state medical councils, which take stronger action, whereas the other associations or other agents, other systems do not have a very strong regulatory agencies, and other systems are out of our ambit. So these are some of the issues which we have. Concluding, I would like to say that integrated medicine is a possibility. We can do it if we wish to do it, and develop more scientific evidence for the efficacy or the non-efficacy of that. We can have more scientific interaction among ourselves. I had an opportunity to talk to Ayurveda medicine and tell them how can they develop evidence which stands the scrutiny of so many others. And we can also discuss on various scientific forums to see whether this is a possibility or not a possibility. So in the end, I would say that traditional knowledge systems like Ayurveda and modern science, evidence-based medicine should be integrated wherever possible for the benefit of the patient. Thank you very much. I'll rest my case in the abode of the President of India. Me being the President of IADVL, I would like to send this use of integrated medicine onto the abode of the President of India to take a better care of our patients, to help our patients. Thank you very much for patient hearing. I hope whatever I have little told is not against what you people believe. It is just an effort to put a thought. Thank you.
Check.
Thank you, Dr. Jaidev. Hello. It's working? Okay. Thank you, Dr. Jaidev. It's beyond post-graduation, beyond teaching and beyond all that. It's something what one has to understand is not changing the systems of medicine and one to the other, but to take advantage of something you have which helps the patient. That is what the introduction Dr. Jaidev wanted to give us. And each one of us may have an experience with other system of the medicine where patient got a better relief from simple aloe vera to other things. But we have to understand the draw lines. The problem here is we have allopathy medicine has a very strong walls, and other people want to come into this thinking that it is something. And the cost of medicine, now I don't think in any other system also the cost of medicine is less expensive. The Ayurveda or the so-called Kerala treatments, all these things are also expensive. The doctors are expensive, the treatments are expensive. That part of it is something we have to put. And the Western craze, there is no doubt about it. There also it is not the doctors, but it is the individuals go on searching those shelves, they choose their own, and so the vagaries and vanities are of individuals rather than any system. So, a thought we have to give how these things can be complementary or integrated in the true sense where Dr. Jaidev has given, but not, it is not any one system developing into other or other system people coming into this without knowing what they talk or what they are using, whether it is steroid, antibiotic, or any painkiller also in the same system for everything. So, but at the outset, I thank him for his coming over here and putting something into our brain, something totally different from dermatology or beyond dermatology. Thank you, sir. Thank you. I thank organizers for giving us this opportunity to sit here and be with you all. At the last but not the least, we want to thank and honor Dr. Ramakrishna Santalkar, who is running the Ranade Trust, and he was associated with Andhra Mahila Sabha as a surgeon, and we are happy to honor him. Thank you.
Now for the inaugural ceremony, I will take the pleasure to invite our President Sir Dr. DBN Murthy Sir and our Chief Guest Dr. Jaidev Betkurur Sir, our President National IADVL, and guests of honor Dr. G. Gajanan Malya, General Manager of South Central Railways, and our Honorable General Secretary Dr. Bhumesh Kumar Sir, Treasurer Dr. Janardhan Sir, and our President-elect Dr. N. Ramesh sir, immediate past President Dr. Vani Patale madam, scientific chairperson Dr. Netha sir, and Vice Presidents Dr. Geeta ma'am, Joint Secretaries Dr. Rajita Damishetty, kindly occupy the chairs for our inaugural ceremony. Jyoti Prajwala and the prayer song, please. I request Dr. Rajkirit sir to kindly occupy the chair. Dr. Rajkirit sir. Now we'll start the inaugural ceremony with the lighting of the lamp and the prayer song. I request the dignitaries. Now I request the TS CUTICON executive team to felicitate the chief guest, National IADVL President Dr. Jayadev Bedkurur sir.
Unveiling of our souvenir. I request our Honorable President, Dr. D.B.N. Murthy sir, to give a welcome address.
Respected dignitaries on the dais, Chief Guest Dr. Jayadev Bedkurur, President IADVL National Body, and the guest of honor is awaited. And I respect my teacher, Dr. T.S.S. Lakshmi Garu and Dr. Gauri Garu on the dais. And President-elect is also awaited. General Secretary, Telangana State IADVL Dr. Bhumesh Kumar Katakam, Treasurer Dr. B. Janardhan, Vice President Dr. Geeta, Joint Secretaries Dr. Rajita Damisetti, Scientific Chairperson Dr. G. Narasimha Rao Neta, and Co-Chairperson Scientific Committee Dr. Sudharani Madam, and all the delegates who assembled here. I invite you and welcome you all for this inauguration ceremony of Telangana State CUTICON 2021. It's a 7th annual conference conducted by Telangana State branch of IADVL. After a very long time, we are conducting a physical conference, and I am very happy to see you all gathering here. We have got more than 400 registered delegates and online more than 1,000 delegates attending
Now
and following
sir,
the conference.
Sir, 1 minute. Now I invite the guest of honor, Sri Gajanan Malia sir, please come on to the dais and occupy the chair. And Dr. Ramesh sir, President-elect, please come on to the dais.
Welcome Shri G. Gajanan Malya Garu, General Manager, South Central Railway, and President-elect Dr. N. Ramesh onto the dais, and you are welcome to attend this state IADVL conference. We have got a record number of scientific papers this time, and our scientific committee had a tough time scrutinizing them. I extend my Merry Christmas and New Year greetings to the delegates who are celebrating this festival. I thank all the executive body members for supporting TS-IADVL activities. Dr. Bhumesh, with his dynamic and dedicated activity, almost silenced the entire executive body. Dr. Bhumesh worked as a general secretary as a possessed man, left every other aspect of life behind and worked to maintain the TS-IADVL always in the news, a real, very vibrant association. Dr. Bhumesh spearheading all the events of Telangana State IADVL and was responsible for successfully completing 33 academic activities like CMEs, Dharmanas, workshops and conferences, etc. We have done more than 95 awareness activities as social responsibility and to give our contribution back to the society, like Chalo Gaon Ke Or, Chalo Gaon Ke Pathsala Ke Or, visiting orphanages, old age homes, and extended our services and contributed to their requirements also. Regarding anti-COVID activities, we have done more than 76 activities so far, like donating masks, sanitizers, oxygen supplying machines, etc., and educated the public regarding the prevention, detection, and treatment of COVID infection. We have already conducted free health camps at our own office at Nagol, and distributed necessary medicines also without any cost. We have done anti-leprosy activities on Leprosy Day, conducted Psoriasis Day, Vitiligo Day, HIV Day, etc. with great enthusiasm. Our motto is to avoid steroid abuse and conducted more than 15 ITATSA awareness activities in a regular manner. I think totally we have done more than 230 activities, that is almost on alternate day one activity. Really a great contribution single-handedly by Dr. Bhumesh. We participated in the Basics for a day-long physical CME conference in association with Dr. Anchala Parsarthi Institute, where more than 300 delegates attended. It was a great success. We are going to be a part of International Leprosy Conference, which will be conducted next year in collaboration with IAL Group. We have a very strong, capable team and ready to conduct Dharmacon in 2024. Even though we are the youngest branch in the country, we have already bagged the best upcoming branch 2 years back. We have started TS-IADVL journal successfully and enriching it periodically and running it successfully into the second year. We are going to start a Dharma Foundation trust with a generous contribution from Dr. Gauri Madam and Dr. Manmohan. We have our own office premises in Hyderabad in such a short time. It is a very achievable event for such a newborn Telangana State IADVL. We have instituted a Best Thesis Award in the name of Dr. Patnaik sir, whom we have lost this year. We have also remembered our most respected Dr. Aurangabadkar and named a scientific hall on his name in the pre-conference workshop. I would like to bring this information to all the members of TSIADVL that we have not received any financial grant or any detail of the financial documents from the previous executive body. We have managed expenditure of every event conducted by TSIADVL by our own efforts. We have got a grant from the Central IADVL with the help of our President, Dr. Jaydev Betkarur, for conducting the anti-COVID activities, for which we are thankful to him. Our TSIADVL is an extremely vibrant organization and our members are participating in SIG activities for which few were conveners and coordinators, etc. Every year, one of our members are being elected as members of the Central Executive Committee. So, our contribution to the National IADVL activity is always there. This year, in appreciation for his continuous dedicated, determined activity, Dr. Bhumesh, we are planning to honor Dr. Bhumesh Kumar Katakam in the valedictory function with a medal stating President's Appreciation Award for Distinguished Dynamic Dermatologist of the Year 2021 to Dr. Bhumesh. I thank the entire executive body who supported me during my tenure as president. I also thank the members of the Telangana State IADVL for giving me this opportunity to serve the association as president. Long live IADVL. Thank you very much.
I now request our General Secretary, Honorable General Secretary Dr. Bhumesh Kumar sir, to address the audience.
Respected dignitaries on the dais, today's chief guest, our beloved National President, Dr. Jaydev Betkarur, and guest of honor, Dr. Gajanan Malia, and our President, Dr. D.B.N. Murthy, the President-elect, Dr. Ramesh, and immediate past President, Dr. Vani Patale, and the Treasurer, Janardhan, and our EC, and all the dignitaries of the dais and the senior members. Very good afternoon, one and all, and welcome to this inaugural ceremony of 7th State Conference of IADVL Telangana State, which is going to be held for 3 days. Yesterday we have conducted a pre-conference workshop successfully. Almost more than 250 delegates have participated, and in the conference more than 450 delegates they have registered, and we thank the delegates, those who have come from outside, and for sharing their scientific knowledge. There is no words to say, so almost our President has told everything. So whatever we have done our level best by putting our body, mind and soul, and with your support. So without the support of the members of IADVL, it would not be possible. So we, the IADVL, is committed for the community friendly and the subject friendly and the members friendly. So with these three, and already our national president is theme of the community and members welfare in that. So the theme TS IADVL is a part and parcel which is continuously creating awareness for the misuse of topical steroids for a healthy skin and healthy body and healthy nation since the 2019 when it is a brainchild of Dr. P. Narasimha Rao sir. So we request all the members, especially the younger generation, please sensitize at least 10 members and let them sensitize to skin another 10 members, because once the అంటే ఆరోగ్యమైన చర్మమే ఆరోగ్యమైన దేహము ఆరోగ్యమైన దేహమే ఆరోగ్యమైన దేశం. సో మాయిస్ట్ ఈజ్ మస్ట్, అంటే చేనైనా చిలకైనా చర్మాంగమైన మర్మాంగమైన వితౌట్ మాయిస్ట్ దెర్ ఈజ్ నో లైఫ్, నో లివింగ్ కింగ్డమ్. సో we healthcare providers as a dermatologist, the skin is the first defense mechanism. Let us maintain the good skin health that has been initiated from the pediatric age group. So it is cumulative work, and we thank all the HODs of Telangana so for their tremendous contribution in the scientific knowledge and taking part in all academic activities and awareness activities from all over India, from all over Telangana. So with this I don't want to take much time, and thank you very much. Over to Dr. Kavit.
I now request our scientific chairperson Dr. Netha sir to kindly address.
Very good afternoon, respected our today's chief guest, National IADVL President Dr. Jayadev Bhatkar and TS IADVL President Dr. D. Benamurthy and our honorable guest Gajajana Malya and our President-elect Dr. N. Ramesh, Vice Presidents Dr. V. Geeta, Dr. Mohanlal, General Secretary Dr. K. Bhumesh Kumar, Treasurer Dr. B. Janardhan, Joint Secretary Dr. Rajita Damshetty and Dr. Rajkirit, my dear teachers, colleagues and my dear students, very good afternoon. Welcoming you all for CUTICON 2021. It's my pleasure to be here and welcoming you all faculty members and IADVL members who have come and made this event grand success. CUTICON 2021 is special in view of COVID-19 pandemic, and we are sharing our scientific knowledge with taking all COVID-19 precautions for a healthy skin, healthy body and healthy nation. The theme of this conference is management of challenges of dermatosis, present and future. In scientific sessions, we covered all the clinical dermatology, STDs and leprosy and cosmetology and dermatosurgery, including COVID-19 with the latest updates. They followed by panel discussions to discuss the practical tips for our younger generation. We designed important questions for audience for active participation to clarify their doubts about day-to-day clinical practice. As usual, take-home pearls of CUTICON 2021 will be shared to our beloved registered delegates later on. Award and free papers for postgraduates and special sessions for younger dermatologists are integrated in the scientific program. In the our tenure, we also organized during the COVID period Dermanar as an online education program. We all over India we conducted great response come from the different medical colleges all over India. We certainly promise you to deliver the best of our capability by putting our body, mind and soul. I hope everybody will enjoy this scientific feast. Thank you. Jai Hind, Jai Telangana.
I now request our chairpersons, the senior consultant dermatologists and former HODs of Usmania Medical College, Dr. TSS Lakshmi Madam, to say a few words. and even Gauri Madam too.
A very good afternoon to all of you. I want to thank the audience for giving me an opportunity and just to wish this, our association, long live, long live, long live IADVL, entire national, state level, whatever it is. And most important thing is, this year they have contributed all work and no play makes the David lazy it seems. That's why I'm so happy to note that even included some sports meets and all that, so nicely well arranged. I just want to congratulate and wish all the best to the existing people and then the coming people. All the best. Thank you for giving me an opportunity. Thank you once again. Thank you.
Gauri ma'am. I now request
I have an announcement here now. I request Dr. Satyanath, son of late Dr. R. Patnaik, will be giving us a check in the memory of his father for instituting a gold medal every year to the best dissertation from the postgraduate. He will hand over the check now, and I'll ask him to speak for a minute. Dr. Satyanath has given a check for 10 lakhs. This will be done a fixed deposit, and the money which is collected as an interest will be utilized for giving the gold medal and the cash award to the best dissertation by a postgraduate student in Telangana state. Yeah. Photo. You go. Let's go.
I now request our Chief Guest Dr. Jaydev Betkurur sir to unveil the TS CUTICON 2021 souvenir.
I request Dr. Putta Srinivas sir and Dr. A.G. Rao sir, please come on to the dais. Dr. Manmohan sir. And the presidents of from 15 to 21. All past presidents from 2015 to 2020. Reddy sir. If Dr. B.N. Reddy is there, please come onto the dais. He is the first president of IADVL Telangana state.
Now I request the guest of honor, Dr. Sri G. Gajanan Malya sir, to kindly unveil the TS IADVL Constitution. And now it's time to felicitate our chief guest, Dr. Jaydev Betkurur sir, President, National IADVL President sir. I request sir to address the audience, please.
Good afternoon to all of you. Respected guest of honor, Mr. Gajanan Malya, President Dr. IADVL Telangana, Dr. D.B.N. Murthy, Secretary Dr. Bhumesh, Scientific Committee Chair Dr. Narsimha Rao Reta, all the other EC members of the IADVL Telangana, and my friends Dr. Putta Srinivas and Manmohan and so many others, and all the friends of Telangana branch, and my dear IADVLites, ladies and gentlemen. First, let me wish you all a very Merry Christmas to all of you. May the blessings of His Holy bring us good health, joy and prosperity all over the years. And also I wish you all a very Happy New Year in advance. Now, just coming to IADVL Telangana has been doing an extremely very good job of their work in the last 2 years, though we were all having a severe problem of the pandemic. In spite of that, they have done a very good job. The Dharmanar, which was conducted by IADVL Telangana, has been an excellent, has been received by members all over India very well. And it was also very happy that most of the PGs loved the quiz and also the awards that were given to those people. And the community service that was rendered by TS IADVL was exemplary. It was very nice to see so many community service being conducted, and they were also part of the community service initiated by IADVL National by providing equipments to healthcare workers. They also did that quite well, and I appreciate and I thank the IADVL Telangana branch for being with us during this time. And I'm sure this work will continue in future also, and I would like to see whether IADVL Telangana can bring in some member benefit schemes for the benefit of social benefit of their members. If they can do that, then it will be another feather in their cap of IADVL Telangana. During the last 2 years, we as the IADVL EC have been incognito. We have been only on the virtual platform. But IADVL as such has been continuing and doing very well, very good job, both academically and also on the part of the member benefit and the community service. Academically, we have conducted lots and lots of webinars. Almost every year there is a webinar either through the IADVL Academy or through SIGs or even by the other committees. We have been conducting, and the response has been very good. Unfortunately, I think over a period of time, in the last few months, the itch to meet all of you has become more. And so we are having more physical programs rather than the virtual programs. And of course, it is a welcome change to all of us. The webinars, of course, there is something called webinar fatigue has set in recently now. IADVL has been fighting against quackery. We have something called ITAC. We have been receiving complaints by various members and trying to take action against those complainants, and that has helped to a certain extent in some areas, but unfortunately IADVL is not given any power as such to take any action against anybody. We are just a agency or an association that can complain to the other authorities who can do that, and it is the other authorities who can take action, like the State Medical Council or the Medical Council of India or whoever it is, or even the other councils against whom the complaint has been raised. Unfortunately, recently we got a letter from the DCI stating that they have justified the MDS people conducting all aesthetic procedures starting from hair transplant down to acne scar treatment also. So they have claimed under various clauses that they are capable and they are allowed to do. So it is probably another blow onto our area of expertise. So we need to be careful about that. So that's one more thing, the quackery system. But I feel the quackery can be, fought not by a single agency like ITAC or anybody. It has to be fought by all the members of IADVL. We should try and fight together against this menace, so that, and the one way of fighting is to reach the community and tell the community that we are the dermatologists and we are the ones who can take care of their skin problem. So once the community understands that, definitely there will be a better change for our practice and we will be able to do that. And I am also finding that that dermatology education is a very costly affair. It's not that simple. And also once you pass out, there is a problem of settling, and that itself is again a costly one. And what I see in social media, where I am a little bit active, I find that there is a lot of frustration among youngsters. That is because there is quackery and the practice not picking up, and the returns are not good to what they have put in. So there is a need, I feel that there is a need for the elders to hold their hands and try to counsel them regarding how they can grow in the practice. And also we have been doing that in IADVL, giving more opportunities to youngsters to grow in academically, and in that way they can also grow in their field of interest also. So that is how we need to improve or bring in some sort of help to our members. There is one more issue which I very dear to my heart is the member welfare. As you know, IADVL has got 3 member welfare schemes. One is the IADVL Benevolent Fund, which is given to at certain diseases like renal transplant and cardiac surgery, cancer therapies, and so forth. And also the accident benefit scheme, which is given to only those members who meet with an accident and have some problem or even leading to death. And there is something called DVL Welfare Trust, which is basically a mutual welfare trust. You give little money so that I get more money. That's how it works. The simple principle is that. So I look forward for all of you to be part of that. I'm very sure that I don't want any of you to be eligible for the benevolent fund or the accident benefit scheme. I want all of you to be healthy, hale and healthy, not to fall sick and ask for a benevolent fund. But I would definitely like you to join the DVL Welfare Trust so that you can help others who may be in need of some financial help. Because we also give what we call the professional indemnity also in that. So that facility can be used by you whenever you are in trouble. Now, with this little bit of advice to all of you, I congratulate Team IADVL TS or Telangana branch for having done an exemplary job during their tenure of this year. I hope the next team also will continue to do this, continue to keep up this tradition of the best work that is possible. And we will meet again, hopefully, as Gnaneshwar Rao and the organizing committee of Dermocon what should I call it, as 24, which was postponed from 21 to 24, will have a physical Dermocon, and I will be there as part of delegates to Dermocon 24. And I wish all the very success to the CUTICON TS, IADVL TS, and also all the best for the organizers of Dermocon 24, and also the organizers of ILC, that is the International Leprosy Congress, where again I will be present here as a part of the organizer. So wish you all the best. Have a very good scientific feast, and also I think Bhumesh Kumar has got lined up a very beautiful evening program. I don't want to miss that, and all of you, meet all of you there. Thank you very much, and all the best to you. Long live IADVL.
Thank you so much, sir. I now request the TS CUTICON 2021 Executive Body and the Chief Guest to honor our guest of honor, Sri G. Gajanan Malia, General Manager of South Central Railways. Sir, kindly deliver. I request our guest of honor to address the audience.
A very good afternoon to one and all. Wish you all a Merry Christmas. And it's great that on this auspicious day you are having this conference. Respected chief guest of today's conference, Dr. Jaydev Betkerur, President IADVL, Dr. Rashmi Sarkar, President-elect IADVL, Dr. PBN Murthy, Dr. Ramesh, Dr. Bhumesh, General Secretary, Dr. Darsimha Rao, Neta, Scientific Chairman, other dignitaries on the dais, all the doctors who are participating in this 7th conference of Indian Association of Dermatologists, Venerologists and Leprologists. I am really privileged to be amongst you in this August gathering of skin specialists from the state of Telangana. I am told that there are about 900 members, 650 of whom are qualified life members and 250 are under training. Healthcare industry is one of the most important sector for the progress of the society, and with the recent pandemic, the importance of healthcare has been reinforced in no uncertain terms. Further, with the steady rise in the economic status of the populace, combined with the advancement of medical technology, there has been a continuous improvement in the health consciousness among the public, especially with regard to skin and dermatology-related issues. I am told that previously there used to be only 10 postgraduate seats of dermatology in the combined state of Andhra Pradesh. But reflecting its importance and necessity, currently there are more than 50 postgraduate seats available in the state of Telangana alone. I am sure this number is likely to grow further to meet the needs of the society. Today, the top rankers in NEET PG entrance exam are showing interest, competing for dermatology PG seats, reflecting its growth prospects. It is a proud moment for South Central Railway that our Central Hospital, Nalagoda, is the only DNB by DVL center in South India, as well as the only accredited center for DNB dermatology across Indian Railways. And as a General Manager of South Central Railway, I am privileged to be the patron of this dermatology unit. I am glad that every year this hospital takes 4 DNB students, which is mutually beneficial for both the students as well as the railways. Our railway healthcare system, I would say, is Atmanirbhar. We do almost everything in-house, except for the tertiary care and some of the secondary care specialties. And I'm proud that during the COVID period, railways were totally self-reliant, and on South Central itself, we have treated more than 22,000 cases of COVID, and that too moderate and severe cases also. And the recovery rates were excellent. And we equipped our hospitals with the best of the machines, best of the medicines, and provided total care to the patients, which even some of the corporate hospitals were not providing. And we have saved a number of lives of railwaymen who were affected by this COVID. As you all know, railways never stopped working during the pandemic period, and all our frontline staff were exposed to the dangers of this pandemic. I am happy that today's conference is being attended by specialized doctors, which I am sure will aid further development of this crucial field in medical science. Dermatology science, like all other specialties, is a growing field, and a lot of other specialties like cosmetic dermatology, including lasers, fillers, pediatric dermatology, dermatopathology, dermatosurgery, among others, are also developing fields. I am confident that this conference, with the participation of eminent dermatologists, will play a vital role in imparting new knowledge to the aspiring postgraduates about the state-of-the-art methods in diagnosis and management of skin venereal diseases, including HIV, AIDS, and leprosy. I wish all the best to the participants and hope such conferences will continue to guide the development of dermatology field in the state. I also congratulate Dr. Ramesh, who is our dermatologist in Lalagoda Hospital, to become the president-elect today, and I think he'll be taking over along with a set of new office bearers. I also compliment the existing office bearers for doing a wonderful job, as has been highlighted by our chief guest. I wish dermatologists all the best in the times to come, and wish all success for this conference. Thank you.
Thank you so much, sir. I now request our Honorable General Secretary to propose vote of thanks.
So a big thanks to all of you and all the dignitaries on the dais, chief guest, guest of honor. So sorry for the delay for lunch. All the lunch has been started almost 20 minutes back. So by sharp 2 o'clock, we'll restart the scientific session. So we'll close this inaugural ceremony. Thank you very much. We'll rejoin at 2 o'clock sharp.
Kindly display the CV, please.
It is coming here, it's not coming there.
So,
So this one.
sir has got 34 years of practice. He has got many presentations and 8 publications. And his main areas of interest are on HIV medicine, filariasis, acne, etc. Over to Ravi Vadrevu, sir.
Thanks, madam. So it's post-lunch, wonderful conference, extraordinary inaugural with the South Central Railway General Manager visiting us, and the none other than National President Betkarur telling us about certain schemes and the developments that are made. And really, indeed, very happy to note that in the 7 years, Telangana State IADVL has reached great heights, especially in the last 1 year, with the able and dynamic leadership. So many programs I have never heard of. As a past president of AP IADVL for 2 occasions, I really understand what a great achievement it is. That much for the association. I thank the organizers, Scientific Committee Chairman Dr. Neta and the Scientific Committee President and Secretary Telangana IADVL, DBN and Bhumesh for this invitation. And in the next 15 minutes or so, we are going to address a very common issue, but a vexing issue to all of us. Autoimmune versus idiopathic urticaria, what do we need to know? So this what is introduced by me. The organizers have given me the word, do we need to know? But I thought, especially we should know that what. There's some problem with the slide movement, you must assist. So, in the introduction, we need to look at what is the nomenclature, what is acute versus chronic urticaria, and in the chronic urticaria, what is autoimmune and what constitutes the chronic spontaneous urticaria or chronic idiopathic urticaria, and what are the diagnostic tests and their limitations, and what are the differences a clinician finds, and what are the dilemmas he faces in day-to-day practice, and what are the treatment aspects, is there any real difference in treating all these conditions, and what are the future prospects what we are looking into. This is not moving. This is what happened to Dr. Betkarur also. There's some problem with this.
Yeah. It is connected.
So he is connecting?
Yeah.
Okay. So here, what's in a name? That which we call a rose by any other name would smell as sweet, is what Juliet said in this famous Romeo and Juliet, Act 2, Scene 2 by Shakespeare. Today, whether we call it a chronic urticaria, spontaneous urticaria, or autoimmune, or whatever it is, ultimately our treatment lines and the investigational lines are going to converge. An enormous amount of work has been done, as seen by all these papers over the decades, and more work has been done. More and more work has been done. What for? Are we making any real progress on this? And what is the current situation? This is what we shall see in the next 10 minutes. So urticaria is a condition characterized by the development of wheals or angioedema or both. When it comes to chronic urticaria, there are 2 caveats that are added. One is it has to be more than 6 weeks by duration. The second is the causes can be known or unknown causes. Then, okay, I'll try. Thanks very much. So, on 1st December 2016, all these wise men from about 42 countries, 48 delegates have gathered in Germany and have prepared the guidelines after enormous deliberations. And our own Kiran Godse, who is an authority on urticaria, was there representing IADVL and India at this meeting.
Here, just put it here and just here.
You have some golden touch. Yeah.
You
Yeah.
said yours, I'll do it.
This not listening to me, she has a golden touch. Yeah. So chronic urticaria subtypes. The left side, the definition what I gave. The right side are all called the inducible urticarias. I'm not going to read out all those things. So then, from the first report in 1962 about the supposed antibody thesis to leukocyte degranulation, till 1993, that is exactly midpoint, 3 decades after the first thought came to one doctor, then the second doctor showed that there is a high affinity IgE receptor, or less commonly IgE itself. There are antibodies in the body, which we call autoantibodies. So this was the foundation for what we call today autoimmune urticaria. So to make the matter more simple, though we are not into mathematics, urticaria minus physical urticaria plus urticarial vasculitis is equal to chronic spontaneous urticaria, in which chronic autoimmune urticaria will be 45% and rest remains idiopathic urticaria. So the same thing in a tabular form, in a flow chart. This is there in the journals. The reference is given there at the bottom of that. In 2019, this has been given. So if you remove the inducible urticarias, whether they are wheals only, you need to exclude urticarial vasculitis. If it is angioedema only, exclude any non-steroid anti-inflammatory drug induced, then you are left with chronic spontaneous urticaria. So what is the pathogenesis? Many agents are capable of activating the dermal mast cells, but most important are these 3 that are delineated in the line 2 there. Allergen-specific IgE reactions, anti-IgE and anti-Fc epsilon RA autoantibodies, and complement C5a. These are the trivial few one has to remember. But later on I'm going to tell you, these investigations are also being done only in the research laboratories and not in an ordinary laboratory. At the end of it, about 5 to 10% with chronic autoimmune urticaria have autoantibodies which specifically are against IgE itself. Then it is the same thing telling us the cascade and how the mast cell degranulates. Ultimately, histamine is released, and releasing all the effects of histamine clinically, what we see is urticaria. If you look at the pathogenesis, chronic spontaneous urticaria is a common and complex disorder. It's both common as well as a complex disorder that occurs in the absence of any identifiable provoking factor. It's becoming increasingly clear that autoimmunity is playing a role. So mast cell degranulation, only thing is associated molecular, pathogen-associated molecular patterns, stem cell factors, substance P, all these things. So this defines what is a non-immunological urticaria and what is an immunologically mediated urticaria. So clinically, if you see, these are the autoimmune, to the right half in the purple color are the autoimmune urticaria, pseudoallergic and infection related and idiopathic, whereas on the left side, 35% is physical urticarias or inducible urticarias. Diagnosis is well recognized that chronic idiopathic urticaria is an autoimmune reason, no question. It is in a majority of patients, this is happening, and autoantibodies have to be shown, and has been found to be associated with autoimmune thyroid disease and certain autoimmune diseases. Autologous serum skin test, about which we are going to see in the next slide, is a screening test, and it has got a sensitivity and specificity of 70 and 80% respectively. The current gold standard is basophil histamine release test. So this is what? Urticaria is a pool. In that idiopathic urticaria, at the core of it is autoimmune urticaria. So this is all what you all practice in the day-to-day practice. You see a patient coming with such horrendous lesions like this, give him relief in a day or two, relieve all the anxiety to the parents, then you are lucky. As quick as a fox, this is what steroids do in my practice. See, 21st, this patient came with that kind of angioedema just 3 days ago, and yesterday's photograph is this. Then, diagnostic pitfall. Sometimes an urticaria looks like a granulomatous disease, and landmines all the way. A case of Hansen's LL may be mistaken for a severe urticaria. And there's a patterns galore. Sometimes you think it is a various marginal erythema or some other erythema, but it's a case of simple chronic urticaria. Or acute exacerbations will make the patients crazy. Nowadays in the Google era, patients are running crazy with urticaria. Severe exacerbations. And a chronic idiopathic urticaria or autoimmune urticaria like this, without any end, a lady or a man can be sufferers, asking and demanding for therapy. Dermographism, sometimes as part of it can happen as different from an inducible urticaria. And again another case of dermograph. Hand experience is no excuse. Look at this. This is a pathology report from Delhi Derm Path Laboratory where I send my slides regularly, my pathology specimens regularly. And what's my diagnosis? Hansen's LL bar urticarial vasculitis. By that time I was already more than 20 years experienced. 3 of us have examined this patient. Still we could not decide. Then look at the bottom line. The diagnosis is urticarial vasculitis. Sometimes urticaria can masquerade. We cannot take our experience as an excuse. We need to be very, very watchful. And what is the line of control between autoimmune and CIU? What is the line of control? Chronic idiopathic urticaria is now replaced by chronic spontaneous urticaria. A big fraction of CSU is due to autoimmune factors. Other chronic urticaria that are left out are physical urticarias and urticarial vasculitis. Therefore, every case of spontaneous urticaria is not a case of autoimmune urticaria. Why is this important? Because it has got serious therapeutic implications. If we remember this, well, my talk is worth it. And what are the diagnostic tests and what are their limitations? Grattan has described autologous serum skin test. I'm not going to read out all this. This has been, all of you are masters of this and you have done it in your post-graduation and you know it very well. So only thing is, there is one serum sample, there are 2 controls, one with histamine and normal saline. You take the reading after half an hour, then read it. And specificity and sensitivity, as already I told, 70% and 80%. And what is the lab work we should be doing in a case of CSU? Differential blood count, ESR and CRP. What are the recommendations telling of those wise men in 2016? What routine diagnostic measures should be performed in chronic spontaneous urticaria? 90% consensus. We recommend limited investigations. Basic tests include differential blood count, CRP and ESR, period. Please remember, no great tests and workup is not required. All that is required is reassurance to the patient. Intensive and costly general screening programs for causes of urticaria are strongly advised against. Currently, those 2-3 tests are there in the research laboratories. You and I can't do them in an ordinary laboratory attached to us. And lab confirmation, immunoreactive but non-histamine releasing autoantibodies are also detectable in sera from some patients with autoimmune connective tissue diseases, which means these autoantibodies are not specific. So, they have got a poor specificity. The gold standard is basophil histamine release assay or basophil activation test. What is this test? This is the, in a nutshell, basophil activation test that is done in research laboratories is this. It assesses histamine release or upregulation, can help co-assess disease activity, and it can be used to gauge the impact of certain disease-modifying agents like cyclosporin A or omalizumab. So, functional autoantibodies that activate these things are present many times, but non-functional antibodies give a positive test to you. So, where are we? Are we any intelligent after getting this test done? There is still no simple reproducible clinical test, and most research is done in secondary or tertiary referral laboratories. We must remember these things. So, the watchword is patience, patience and patience, watchfulness, and using your instincts and clinical skills to treat a patient nicely without going in for fancy tests and fancy investigations. Of all these things that are given in the table, only thing is basophil activation test that is positive here. Otherwise, CIU and CIU, all other parameters are the same. Treatment, chronic autoimmune urticaria as in chronic idiopathic urticaria is with H1 antihistamines are the most important treatment. So that's what the first line says. Steroids may help in chronic autoimmune urticaria, especially in exacerbations. Where there is an exacerbation, you give a tapering schedule of steroids starting with a higher dose and ending with a lower dose. Alternative treatments with methotrexate, cyclosporin, dapsone and a host of other agents have been claimed to be helpful. Omalizumab is the definitive treatment where updosing of the standard H1 antihistaminics are not working even after updosing also. CSU is often reported to be associated with inflammatory disorders, infections, or or in some other instances. So H. pylori, bowel parasites. It is a common practice for us. The pediatrician in the neighborhood gives a deworming agent. Patient comes with one of those acute exacerbations. So always a word of caution. If you want to give deworming to this patient, always wait, let the acute exacerbation come down, then give a deworming. My practice is to start a broad spectrum antibiotic on day 1 along with the specific H1 anti-receptor antagonist in the hope that if there were to be that H. pylori or some other bacterial infection that is in nidus or acting as an antibody producing agent, then you are well nullifying the root cause of this pathogenetic mechanism. Then a lot has been said in all those articles what I have referred. A lot has been said against the first generation antihistaminics. May I ask you a simple question? How many of you are using first generation antihistaminics? Please be honest. 1, 2, 3. Most seniors are using. But this is less than 10% of the total audience here. Okay. Thank you very much, gentlemen, for that. See, first generation antihistaminics have still got a role. But those current recommendations speak against that, all for the reason of drowsiness. Hydroxyzine as an example if you take, because of the lipophilic nature of the hydroxyzine or first generation antihistaminics, they get into the brain, they block the histamine there. Histamine is what keeps us active all the time. That is compensated, therefore we get the drowsiness. Suppose this blood-brain barrier mechanism is different in a set of patients, what is the big deal in giving them H1 anti-receptor antagonist of first generation? We can always give. That has got a good place. So let us not be carried away by research carried on somewhere. Research has to be ultimately come to bedside or to the table. Otherwise, that research is meaningless. Then, these are the things, of course, I told. Second generation antihistaminics, of course, these are all the examples. We all know every day, not a day passes without prescribing all these agents. They should be considered as first-line for symptomatic cases because I have to speak from the literature, all evidence-based. This is what is evidence-based speech. So that's what we have to give. And where they are not effective in the given dose, you have to updose it even up to 4 times the dose mentioned. Then these questions are put to these wise people from 42 countries. Is cyclosporin A useful? The consensus is in 90% of cases where first generation have failed, second generation have failed, they have to use cyclosporin A. Leukotriene antagonists, hands down, no. So those of our colleagues who are using montelukast, all those randomized control trials are proving that montelukast has no role in control of chronic spontaneous urticaria or autoimmune urticaria. Corticosteroids, yes, already I told you, good dose of corticosteroids given in the right dose for the right duration have got a place, but certainly not for a prolonged use. They cannot substitute for the use of antihistaminics. So the recommendation is, yes, you can use. Is omalizumab useful as add-on treatment in patients unresponsive to high-dose H1 antihistamines? Yes, 90% omalizumab has been of use. So please go through this slide very carefully. Outside there are 30-40 pharma companies there with a stall and giving us the much needed inputs for organizing such a beautiful conference. But also there will be a hidden agenda of promoting their products. So certainly any company that is promoting these high molecule products, which are high-end products in thousands of rupees, will tell the beautiful side of it. Just please read this slide, then I'll go to the next slide. Look at this. CSU, look at those bold lines highlighted there. CSU is generally a self-limited disease. That suicidal tendencies, all those things, what companies are telling us, how many of your patients out of CSU have committed suicide? Hands up, please. Any suicides you know of because of chronic spontaneous urticaria? Not in my practice of 35 years. Thank you. No hands raised there. Omalizumab has not been shown to be disease modifying or curative. Relapse of symptoms occurs in almost half of the patients. This is from standard RCTs literature. I am quoting from a published article.
sir, low dose of steroid for some time, along with all these adjuvants.
Okay, back to you, Dr. Ravi. You have enlightened us on the subject. Tell me, out of a total of 100 patients who you treat with normal dose of antihistamines, how many need updosing? So how many will not respond?
So maybe about 5%.
How many out of those 5% will respond to the updosed 4 times?
So almost everybody responds. And those who are lost in the follow-up, I don't know, but almost everybody responds to that. But acute exacerbations, I give steroids, I rely. Only that.
Maybe you combine the steroids and updose, that's why all of them respond, or no?
No, steroids in routine chronic idiopathic urticaria, chronic spontaneous urticaria, I don't use at all. But if there is an acute exacerbation like some of those pictures what I showed, maybe 5 days, maybe 1 week, maximum 2 weeks, I'll give a tapering schedule. Otherwise, never in a chronic urticaria.
Okay, so the literature says that about 45% of the patients of chronic spontaneous urticaria respond to the normal dose of H1 second generation antihistamine, and about 60% will respond to the updosed. So there still are 40% left who will not respond. So what's happening now? This is not moving, that's moving, okay. So you believe that updosing works. Dr. V.K. Sharma, you believe that updosing works. So in how many percentage of patients, Dr. Dayal? As I said, literature says that about 20% will be added to it.
In my experience also, about 35% patients with normal dose, but after that I need to updose it, sir. Only then I am getting the response.
Dr. Ravi, you mentioned that, I know we have already discussed this algorithm. You mentioned leukotriene antagonists are totally useless. So are they totally useless?
I'm not using, except rarely where some other just dryness and itching is there or something like that. But urticaria per se, I'm not using montelukast.
Does anybody use leukotriene antagonists?
He said he's using.
Sir.
There is a set of urticaria patients who have associated allergic rhinitis and asthma also. Those are the cases where updosing also fails in controlling urticaria. I use montelukast. Where there is a background and the patient are known atopic rhinitis, that is allergic rhinitis and asthma is associated, that particular subset of the patients I do use.
So as sir said that, you want to add something, Dr. Dayal? Yeah.
Yes, sir. Even with NSAIDs reactions also, patient when they come, this helps, sir.
Okay. So as Dr. Ravi had mentioned in his talk, leukotriene has not, the leukotriene antagonists have been found to be totally useless in urticaria, but only if you have an associated respiratory allergy, because respiratory allergy responds to montelukast, they have been found to be useful. I am taking a short break here. So friends, I am introducing you to this Dialogues in Clinical Dermatology, which is happening in your city next week in the Marriott Convention Center. Dialogues in Clinical Dermatology is a SARC, Association of Aesthetic Dermatology initiative, which we do every year. And in this conference, there is an extensive workshop on various cosmetological procedures, and there's a day dedicated to core dermatology also. I welcome you all to join us, and we have kept a very special prize for you all and all the delegates attending in the CUTICON today. There's a booth outside of the DICD. Please go there and register for the conference. So, steroids, when and how? Dr. Dayal, please.
Yes. It is used in acute exacerbations of chronic spontaneous urticaria. A dose of 0.5 mg per kg body weight of prednisolone, even in a short course of around 7 days, sir.
Okay, so a short course. Everybody believes that only a short course should be given. So yes, what the recommendations also say that you should always give a short course, try to taper it off as soon as possible, then keep on antihistamines. If the patient needs it again, give it again, but do not give it for a long time. And if the patients need it beyond a certain period of time, then what do we do, Dr. Ravi?
Such instances are really rare. Maybe sometimes it extends to 3 or 4 weeks. By the time I'll be, otherwise cyclosporin occasionally I'll be giving.
Okay. Dr. Ravi, I'll go to Dr. V.K. Sharma and talk about a very important issue that you mentioned in your talk about sedating antihistamines. Are they totally out? You see, IACI or European guidelines say that you should never ever prescribe a sedating antihistamine or an H1, first generation antihistamine, like hydroxyzine, like chlorpheniramine. Sir, your views on that?
By and large, yes, but there is certainly certain situations where we have to use the...
Sir, please, what are those?
First is the urticaria with pregnancy. There definitely I would like to use sedating antihistamines. Then a small section of the patients are there. A small section of patients are there where second generation antihistamine, they are inducing diarrheas. I don't know whether you people have observed it or not. It may not be frank diarrhea, but they say there is increased frequency of visiting to the toilet. 3, 4, 5 times they have to go for the motion. Those are the cases where I withdraw the second generation, I put again this. And a very small segment of patients are there where you updose with the second generation. They say, sir, they will have a lot of difficulty in falling asleep. They are sort of excited. They say, we feel we are sleeping, but our brain is awake. Those are the cases where there is a troublesome symptom, then I add the first generation antihistamine.
Dr. Dayal, you want to add something?
Yes, sir. Doxepin is a tricyclic antidepressant drug. It also helps in relieving the anxiety, and it helps in sleep for the patients when the itching is depriving the sleep.
So these are very important points. Dr. V.K. Sharma has mentioned very interesting observation of some patients getting diarrhea with second generation antihistamines. Then you have no other option left but to give them first generation. Also, you said that they remain excessively awake. I don't know. Dr. Ravi, you have come across this observation?
Sometimes I am myself an example. One day I took one antihistaminic. That's the only ones I have taken. I could not drive anymore. I could not see my patients. I just came back, cancelled all my appointments on that. This happened 25 years ago. So some people who are really drowsy and cannot accept these tablets, we have to find other ways. And certainly, definitely I use a lot of first generation antihistaminics. Only if the patient complains, I first warn him that if there is drowsiness, tell him half the dose, then we'll see. Or if you are not able to bear, then we'll shift to second generation antihistaminic.
Dr. Geeta, I want your inputs because you have been surprisingly quiet. Yes, please.
What I do is, I'll just inquire the patient's occupation. If they are traveling next day and there is any important work, in those patients I prefer second generation. But in other patients, there is nothing wrong in trying first generation antihistamines.
I think a very important point that the history is important and your patient's occupation is important. If the patient's occupation is demanding and he needs to be alert, for example, a pilot, for example, a driver, so you can't, risk and give him first generation antihistamine because that can induce sleep. And a very important point that Dr. Dayal brought out was anxiety. Sometimes these patients are anxious, so if you have to allay that anxiety, maybe you have to give something like doxepin, which may give some sedation, but at the same time allay anxiety also. Okay, a short word about the first generation antihistamines. They are associated with impairment of the function because they are lipophilic and they cross the blood-brain barrier, they reach the brain, block the histamine receptors there, and histamine is important for keeping us awake, as Dr. Ravi had said. So they have their effects on the brain. So they reduce the ability of the children in learning, they reduce the outcome at schools, so they make them less alert at school, even if you give it at bedtime. And add to that these cholinergic, serotonergic, adrenergic and cardiac side effects. So there are problems associated with the first generation antihistamines. Also recently they have found that even if you give it at night time, it interferes, the first generation antihistamines interfere with the REM sleep. REM sleep is a very important, it's a very short span of sleep, part of the total sleep that we sleep in the night, which is very important to give us full, relief or full rest to the body. And if we do not get proper REM sleep, it's likely that we remain drowsy and less alert the next day. So it is important to consider these points when you are giving sedating antihistamines. That's why most of the recommendations have more or less said no to the non-sedating and to the sedating histamine. So now we have two second-line drugs that have been used. Dr. Geeta, you use omalizumab? Not yet. Anybody uses omalizumab? Yes, sir. Give your impression on comparing cyclosporin with omalizumab in your practice.
First comparison is, in both the cases you get relapse.
So please draw the mic.
In both the cases, you get relapse once you stop the drug. So that way, it's not much different. But there will be some times we don't want to use cyclosporin. And those are especially in ladies. Because cyclosporin, if I choose, I should be, and patient also should be mentally prepared to use it for nearly 6 months. And in the ladies, that is a big problem. Because they invariably start developing hypertrichosis. And though literature says it is reversible, but I haven't seen that it is reversible. So those are these points, especially when I handle lady patients, I think about it. And all my omalizumab I use only in lady patients.
Okay. So also patients who have a renal issue, who are hypertensives, who have lipid issues, there also cyclosporin is not very safe. Omalizumab is more or less safe in most of the patients, except that it can cause allergic problems. Long-term outcomes between, let me ask you about omalizumab, sir. You gave omalizumab for a period of 5 to 6. Initially they used to say just 6 injections, now, then they came up with 9 injections, then they said as and when required. So long-term outcomes with omalizumab.
I can't say that I have such a long cases, but wherever I have used, initially when it became available in India, somewhere I think 2014 or 15, I used to give only 150 mg. But there then I found that the moment I withdraw, after 6 injections, the patient was relapsing. Then the new recommendations came with 300 mg. With 300 mg also, yes, after patients after 6 injections, he becomes asymptomatic, but invariably shows a relapse. Maybe after a period of 6 months, 1 year. Recently a patient after 1 year he showed the relapse. So I don't think they are curative.
So what about Dr. Dayal about cyclosporin?
Just regarding omalizumab, it is licensed to treat urticaria, sir, actually, and it is also useful in continuous treatment, and it can be used when there is relapse also. It helps, and its safety and tolerability also is good.
Okay. Dr. Ravi, you have used cyclosporin extensively. Give us your thoughts on cyclosporin as far as disease modification is concerned. One is relief of symptoms. Any disease modification you have seen?
Reasonably okay, but having said that CSU is a self-limited disease at some point or not, how much to attribute it to cyclosporin, how much naturally it has regressed also I cannot say. Second is my biggest problem is hypertension with cyclosporin. So where I have discontinued cyclosporin is because of hypertension. That's one thing. But
okay.
May I be permitted to ask you one question?
Yes, sir, please.
What is I am asking the moderator, what is your experience with omalizumab?
It is not as good as it was hyped initially. I find cyclosporin to be equally, if not better, good to omalizumab in relief of symptoms. In fact, I find cyclosporin, because we have very extensive experience with cyclosporin now. We have used cyclosporin in hundreds of patients, omalizumab maybe 15 to 20 patients only. And then what happened with omalizumab was it came as a biosimilar after the initial drug that was available. I believe that initial drug was quite effective compared to the newer drug. I don't get very good results with the newer drug. So now I have more or less reverted back to cyclosporin. So that's my take on it. Okay, other second line drugs, Dr. Geeta, please. Your experience with these, methotrexate, with azathioprine, with MMF, dapsone, colchicine.
Sir, I gave methotrexate to some of my patients who didn't give any response to other drugs, and dapsone also. But the result is not that good. Again, they came back with a similar condition. Again, I have to start with the second generation antihistaminics and all.
So the problem is it will come back again and again and again, a very frustrating condition, and that's why urticaria is an important part of all conference debates and discussions. So let's discuss a difficult case. Now, I had this patient of 29 years of age. He was a male patient, 119. This is way back in around maybe 2013 when I'll not go further. So it is 2013 when this patient presented to me. He had recalcitrant urticaria, had been treated by multiple colleagues, and he was referred. He was not responding to oral histamines and was requiring steroids again and again for control. I did an ASST and I found it to be positive. So I'll not go into the details. This Dr. Ravi has already mentioned. So what should be the next step? Let us go stepwise how we need to treat a patient of difficult urticaria. So we have a patient who has not responded to 4 times the dose, who is needing steroids again and again, whose ASST is positive. Dr. Ravi, please. What do we do next?
So if he is normotensive,
I would he's a young boy.
I would start on cyclosporin for him.
Cyclosporin.
In addition to the second generation.
Antihistamines. Dr. Sharma, sir?
Yeah, that is the logical thing. But one thing you said 109 kgs or something like that. So whether the other parameters were worked up, lipid profile?
Yes, yes. He was a young boy, had no comorbidity, just that he was obese and, but he was tall also. So 119 I mentioned because we are going to look at the dose also. That's why, sir.
So logically it is the cyclosporin only.
So logically it is cyclosporin. Any difference of opinion? So logically it is cyclosporin. I was just asking, out of all these, everybody has said logically it is cyclosporin.
But if this patient can afford omalizumab, we can start that also.
If the patient can afford omalizumab, then start omalizumab. But
As per the guidelines.
As per the guidelines. So practically we have seen over these years, we have been following guidelines. We used to do that, but I have told you my experience. When the biosimilar came in, I found that cyclosporin was scoring. So as logic says, this patient was put on cyclosporin. We worked him up, did the investigation. Initially, you have to investigate for the renal functions. You have to look at the hypertension, lipid profile. All this has to be done. And the dose is 3 to 5 milligrams per kg body weight. So a 100 kg man would require around 500 milligrams of cyclosporin a day, which is a very high dose. So he was started on 300 milligrams, continued on 360 milligrams fexofenadine twice a day, and he was under good control. And he was free of steroids now, getting occasional lesions but did not require steroids. He was continued for 2 months on this dose. After 2 months, we tried to taper off the cyclosporin. We went to BD for 1 month, we went to OD in the 3rd month, and we found that the symptoms recurred. So he would require steroids again. He was more or less the same, although he was better than before, less steroid requirement. So what do we do next? Cyclosporin has failed, sir. So what do we do next, sir?
In this case, the patient is needing steroids. The other drug which is useful in steroid-dependent chronic spontaneous urticaria is methotrexate.
Okay. Any other ideas, Dr. Ravi?
As I told briefly in my talk, I would give one good course of antibiotic in the hope that there may be some hidden cause for this. Second is, I live in an endemic area for filariasis. I extensively use diethyl carbamazine with very good benefits. So these two I will be doing. Some other thing like what Dr. Vetkarur spoke this morning in the inaugural session.
Alternative.
In the lecture. In the oration he spoke about the alternative medicine and other things. I tell 2 things. One is charcoal tablets, which are not available readily off the market now. They are available by Himalaya company as Gasex tablets. So charcoal tablet, 1 in the morning, 1 in the evening I will give. And I ask him to take 1 spoon of honey in the morning, in the hope that if there is a hidden, some kind of stimulus is there, probably this might, and in a very inexpensive way, in a very simple way I will be doing this. Most of the times I am rewarded.
And which is the antibiotic of choice?
Norfloxacin.
Norfloxacin. And what is the idea of giving norfloxacin?
Oh, it controls urinary pathogens and gut pathogens both. That's the logic way.
Okay, so I think that these are very important inputs Dr. Ravi has given. One is if you are in an endemic area where filariasis is there he has used dicarbazine and that he has found to be useful. A course of antibiotic useful. Gas absorbing charcoal found useful. You want to make some addition, sir? Dr. V.K. Sharma?
Nothing. In some cases, I do give azathioprine.
Okay.
Because I took that idea that azathioprine is a very good steroid sparing agent. So those patients who have become dependent on steroids, then I introduce azathioprine so that the dose is reduced and finally stopped. I was successful in some cases like this.
Okay. So azathioprine is another drug. Dr. Dayal, yes.
So, regarding the antibiotics, as per the guidelines, they say that without evidence, which is better not to give any antibiotics.
Okay. Okay, so as he was ASS3 positive, he was given a serum therapy also. So we gave 8 shots of autologous serum and found that it did not work at all. So he was the same. So what do we do next? I think we have discussed this. There are possibilities of methotrexate, azathioprine, as sir has mentioned. So accordingly, this patient was put on methotrexate, 15 milligrams a day. But remember, methotrexate can produce an idiosyncratic bone marrow suppression. So you give a small dose and then do a hemogram after 1 week, and then if it is okay, then give the full dose. So he got partial relief with 15 milligrams a week. His dose was increased further to 22.5 milligrams a week. Still partial relief, only required Visolone from here on. So where do we go next? What are we left with, sir? Of course, this patient has not got omalizumab, and I think most of you would agree that he would go on omalizumab. So anything else that can be done, sir? You have given wonderful inputs on charcoal, on antibiotic, on filarial treatment. Anything else you do, sir? Dr. V.K. Sharma, anything else before we go to omalizumab?
Nothing, because invariably cyclosporine, finally I come to the conclusion that it has more aura than it really is. Okay. So invariably we fail with the cyclosporine in many diseases.
Drugs like dapsone, colchicine. Dr. Geeta, any inputs on dapsone? Where do you use dapsone?
Yes, sir. Such type of cases, I tried dapsone, sir, but no, I couldn't get good results.
You don't get results?
Yes.
Dr. Dayal?
Dapsone also is very good, also indicated in this recalcitrant chronic spontaneous urticaria. It helps.
Yeah, I think dapsone is more useful in patients of urticarial vasculitis. So when you get good results with dapsone, most probably there is a lingering vasculitic component to the urticaria that is there, because they are more of anti-inflammatories, like dapsone is an anti-inflammatory. So this patient was then put on omalizumab. At that time, omalizumab was not easily available, and we would not give it easily because patients were not ready to take it because it was expensive. So he was put on 300 milligrams subcutaneous monthly intervals. He got very good results. His antihistamines were continued at full dose. I gave him 6 cycles, and then I lost him to follow-up. So I don't know what happened to him until recently. This patient came to me several years later, and then he came for a different condition, not telling me at all about his urticaria. He said, I have this lesions, and it was seborrheic dermatitis. Suddenly I recognized him, and I asked him, what happened to that problem? We had been struggling with it. He said, I'm perfectly fine now. So probably omalizumab of that time, I don't know this time omalizumab whether it will help, that omalizumab had helped that patient. It modified his disease, and he is now controlled with occasional, tablet of fexofenadine. So before I go to summary, any other inputs, Dr. Geeta, anything else you want to? What about danazol? Some patients are given danazol. What is the role of danazol?
I didn't try danazol, sir, but as Dr. Dayal sir said, dapsone has given, like in my cases, like patients with recurrent episodes of urticaria, up to 6 months there was no urticaria noticed by the patient, but afterwards there was recurrence. So we can try, in some patients we can try dapsone. There is nothing wrong in trying dapsone, sir.
And what is the dose of dapsone that you try?
Sir, up to 100 and...
Not 100 twice a day. Do you get G6PD level done?
Yes, sir. All the parameters like routine investigations apart from G6PD.
Do we get G6PD done in leprosy patients when we start them on dapsone? I was a little curious to know this. Does everybody get G6PD done when we start dapsone?
No, sir. No, sir.
What is this? Why do we?
After the legal issues, we have started doing it in every case.
I think previously it was not a routine teaching that patients of leprosy, we would never do G6PD. But in these more elite patients of urticaria or vasculitis, etc., we first do G6PD and then give dapsone. I'm a little surprised on that. Yes, Dr. Ravi?
I was about to butt in about this. So dapsone, now there is a generational difference. My daughter has joined me in practice for the last 4 years. And whenever I am writing dapsone, she'll hold my hand. Daddy, is that required? Is that required? And as you said, G6PD, I never did it. But today, in today's world, yes, sir. In today's world, for this off-label use, we use it. and the patient ends up in some kind of DDS syndrome or something, then that will be enough headache for us. I think Dr. Srinivas wants to say something.
Yes, sir. Yes, sir.
Ganju, with your kind permission.
Yes, sir.
Thank you with all the panelists and your good self. See, regarding dapsone, I have 2-3 remarks to make. Number one, the adverse reactions of dapsone in those who are receiving for anti-leprosy treatment is very minimal, right? So in public health program also, nobody does G6PD. And adverse reactions like Stevens-Johnson syndrome or TEN or fixed eruption are very rare when you prescribe dapsone for the leprosy patients or Hansen's patients. The second point is when you prescribe dapsone for non-leprosy indications like acne vulgaris, chronic urticaria or any other condition where our textbook do mention that it is an indicator for dapsone. And in fact, most of the PGs know the stock question is in all the Viva OC and in the theory examinations is that what are the non-Hansen's indications of dapsone, other uses, also chloroquine. The problem is the adverse reaction with dapsone when you give for other indications is more frequently encountered and reported also. And so much so, we have seen a case of lichen planus, well established, the correct diagnosis by biopsy, given dapsone. Subsequently, patient had Stevens-Johnson syndrome, something untoward happened. The matter went up to State Consumer Forum, National Consumer Forum, Supreme Court. Almost for 16, 17 years, the doctor has to go so much of trauma, so much of disturbed life, personal life, the professional life, and it is not worth that we should face such things. That's my personal opinion, not as academician, as a fellow doctor and dermatologist. So also not only lichen planus, I have seen similar case of dapsone causing Stevens-Johnson syndrome, the patient dying, and loss of vision, again litigation, right? As in myself personally, I have prescribed acne, there was 20 years back rather, for a young girl with acne. After doing all the investigation, prescribed dapsone. After 4 weeks, acne was improving very well, but mother was saying that girl is becoming breathless these days, breathlessness. I said any history of asthma is there, nothing was there. Still, as a cause of precaution, advised hemogram. Hemoglobin has come down from 10 grams to 6 grams within 4 weeks span of time. That is causing hemolytic anemia. So immediately withdrew the drug, stopped the drug, wrote there explicitly stop the dapsone, gave alternative treatment. But something surprising was that girl wanted to have dapsone. Unfortunately, it was giving good response to her compared to earlier anti-treatment by our fellow colleagues in our Hyderabad. She was not happy, but okay, it is a subjective phenomena, satisfied subjective phenomena. But dapsone was working very well, but for the hemolytic anemia it has caused. So my word of caution to all the panelists and the audience here is, if you prescribe dapsone, prepare for 2-3 things. Number one, they'll search in the net, says that it is an anti-leprosy drug. Finish. Patient attendant will come and beg you, sir, we kuchiyade vaade mandulu meer maaku pimples korak istara leda simple urticaria istara ani vaanchipadistaru. They will bang the doctor, you have prescribed an anti-leprosy medicine for simple itching, simple acne. Even grandma can treat acne. That's what they complain, right? Second thing is, this dapsone, one of the senior dermatologists from Guntur, he prescribed for acne. A case was filed against him in the consumer court saying that this doctor has prescribed for simple acne anti-leprosy medicine. Luckily, the other guy was relying only on SIMS, the book of SIMS and its references. We supported him with all the references, it was struck down. But still, it's only sometimes, the sword of justice sometimes, which way it goes, we don't know. The balance of convenience, how a judge thinks, we can't predict. Particularly in Consumer Forum, we don't have much of experienced judicial people. In Consumer Forum, there are appointments which are non-judicial also, as members. So keeping that view, dapsone is definitely has got a scientific role to play in all these non-Hansen's conditions, I agree. But still, to save your skin, be little careful. Thank you very much, patient listening.
Thank you very much, sir. Thank you, sir. So, I think a very important message, you have to be careful. In fact, it's not only dapsone. You see, Tofacitinib came in recently, and it was started with so much halagulla, and most of the companies are now into tofacitinib. But as it is coming in, we know that it's a very difficult molecule to use. It's not so easy using tofacitinib. So friends, to conclude, the second generation antihistamines are the recommended first line therapy. If you don't get relief with a single dose, you quadruple the dose, and the current data is very convincing on quadrupling the dose and getting relief with that. Sedating antihistamines should be preferably avoided because of multiple reasons that we discussed. Steroids should be used in very short tapering courses if at all you need them, and if you need them repeatedly, then the patients should be put on a second line like cyclosporine or omalizumab. H2 blockers, leukotriene antagonists, dapsones, they have been found to be useful in certain situations. In highly drug-resistant cases, they have found that when you have reached a stage when even omalizumab is not working, what they have done is they have combined omalizumab with second-line drugs like azathioprine and methotrexate for a period of about 6 months, and then they taper off the cytotoxic, and they found that omalizumab started working. So this is another step that they have done. So again, reminding you of the chance of registering today at a very nominal price for your next week's hands-on workshops on cosmetic dermatology, dialogues in clinical dermatology. I thank my respected panelists for this wonderful interaction, and thank the organizers of the Telangana CUTICON for giving me this opportunity. Thank you very much, audience, for your kind attention.
Thank you very much, sir.
By the way, this is a green magpie. I am a birder also. I shot this just a month ago in Sattal. A green magpie, this is a birder's delight, a visual delight for birders also. We get it with difficulty. So I thought I would share it here. Thank you very much, sir. Thank you.
What's up, ANF? My name is... Did you think I was going to count down all the way to 1? Wouldn't be very exciting, would it? Amsterdam Music Festival.
Now I call upon Dr. Madhubabu sir, Professor and HOD, Kakatiya Medical College, Warangal, for the pediatric dermatology session. Sir, please.
Good afternoon all. First, let me thank the organizers for giving this opportunity for saying this today's afternoon session. And we have come to the end of the sessions of the today's scientific program. We are in the last session today. And that's the last session mainly is on the pediatric dermatology, a very highly interesting and challenging issues for the consultants and practitioners. We have one guest lecture and we have one panel discussion. First of all, we come with the guest lecture. The topic is mainly on the next generation moisturizers. What's the new in the moisturizers? The speaker is almost a very reputed personality of both at the state and national level, who has held with different positions at both the state and national IADVL sessions. He's a very young, dynamic, very challenging, highly energetic, highly committed person which I have ever seen in my life, to be a very youngster and very dynamic and very daring and dashing. And he's none other than the young hero of our session. It's none other than our organizing secretary, Dr. Bhumesh Kumar Katkam. So I invite Dr. Bhumesh Kumar Katkam proudly on the dais to deliver his lecture.
Full screen, yeah. Respected chairpersons, thank you very much for your kind words, sir. And at the outset, respected my teachers, Dr. A.G. Rao, sir. So because what he taught, I am sharing little bit of knowledge with all of you with today's topic. The pediatric dermatology. So the moisturizers are the backbone for the skin, for the maintenance of the skin, healthy skin. The next generation moisturizers, what is new? Yeah. So these are the three areas of this beautiful tricolor flag. Always I used to use this our beautiful national tricolor flag. Without this, my talk will not be ended. The skin moisturizing, what is the source and functions, what are the different causes of dry skin, and what are the different moisturizers, the conventional versus the barrier. What is the difference, how to use. The stratum corneum, the stratum granulosum, it has two important organelles in the granular cells, the keratohyalin granules and the woodland bodies. Full screen, yeah. Full screen. Full screen. Yeah. Yeah. The important organelles, one is the keratohyalin granules and the second one is woodland bodies. So these are the important for the bricks and mortar, the maintenance of the healthy skin. Like this. So both the bricks and mortar is necessary for the proper functioning of healthy skin. The stratum corneum, again it has three important structures, the cytoplasmic membrane, the keratin filagrins and corneodesmosomes, which is necessary for the healthy skin. And moisturizing, the skin moisturizing, the source and functions and hydration of normal skin due to water, it is hydration because of water or lipids. The source is the stratum corneum requires at least 10% of water content to remain soft and supple. The ideal content is between 10 and 40%. The dermis even contains 10 to 18% of the body's total water content. And the water migrates from dermis to epidermis, followed by evaporation from the sources of the stratum corneum called transepidermal water loss. Why effective hydration of the stratum corneum? Why we need to know the hydration of the skin? The effective barrier function of the skin. The barrier function is very, very important. So the intact skin will not penetrate any microorganisms, whether it is a COVID virus, whether it is HIV virus. So the healthy, effective the barrier function is very, very important to prevent the penetration of any microorganisms or allergens or irritants, and facilitate the desquamation of corneocytes. Oh, different है इधर आती है दोनों करना yeah this is already yeah the facilitates the desquamation of corneocytes and facilitates the healing of damaged stratum corneum. And the hydration of normal skin, the stratum corneum is the chief barrier to loss of water from the skin. So the mechanism of returning moisture is mainly natural moisturizing factor and intercellular lipids. So this is very, very important. So I won't go in detail there regarding the composition of natural moisturizing factor which is there in the stratum granulosum. The intercellular lipids, this is very important. So the three main types of lipids form the intercellular lipid layer of the stratum corneum: the ceramides, the cholesterol, free fatty acids. So that's why the moisturizers, when you use ceramide base or non-ceramide base, always is a matter of debate. But the proper hydration of the skin mainly depends on these three lipids, but in that 50% is from the ceramides. The source of intercellular lipids is outward bodies. The discharge their content at the border of the stratum granulosum and stratum corneum. That is cross-sectional of corneocyte. This is also very important slide. Within the intercellular there is a hydrophilic and hydrophobic structure that is necessary for the maintenance of the natural moisturizing factor. The sebum, the role of sebum in skin hydration is negligible, but the sebum secretion in children is negligible but they possess a smooth and healthy skin. In the elderly, the reduction in the sebum production is not inversely proportional to the increase in the skin dryness. So that's why the dryness mainly depends on the fat component which is necessary for the hydration of the skin. Dry skin, the features, pathophysiology, major causes, I won't go in detail. So as I said, the factor responsible for dry skin, is it water or oil? In fact, it is the lack of water, not the oil. So the oil is necessary, in the fats, the lipid content which is necessary for the hydration of the skin. The dry skin pathology, as we know, any defect in the intercellular or defect in the corneocytes, that gives rise to transepdermal water loss. At the same time, the entry of microorganisms, irritants or allergens and responsible for the inflammation on one side and the aggravation of the secondary infections on other side. These are the major causes: the topical irritants, the environmental factors, aging, cutaneous disease, iatrogenic. These environmental factors, mainly the wind and humidity, temperature, air travel, these are the different factors. I won't go in detail. And the treatment of dry skin, it is the skin moisturizers. So what are the skin moisturizers? The products designed to restore and maintain the optimum hydration of the stratum corneum. So as I said, moist is must for living kingdom. Tema lenide jeevitam ledu. So adi charmangam gaani, marmangam gaani, chenu gaani, chalaka gaani. So hydration of the skin is very, very important, because the quality and function of the moisturizers will influence the quality and function of the skin and thereby well-being of the treated individuals. Andukane arogyamaina charmame arogyamaina dehamu, arogyamaina dehame arogyamaina desham. So we healthcare providers should try to maintain the healthy skin that should be initiated from the pediatric age group, because if you neglect the skin, almost more than 80% of the skin will be damaged at the microcellular level by the age of 18 years. So it is a high time to sensitize by ourselves So to create awareness the importance of healthy skin from the pediatric age group. And what are the different moisturizers? I won't go the first generation, second generation, or the emollients, humectants, all those things. So broadly they are the conventional and non-conventional, or barrier repair moisturizers, non-barrier repair moisturizers. So the non-barrier repair moisturizers, they will responsible for hydration of the skin, whereas the barrier repair moisturizers, they repair at the granular level and maintain the natural moisturizing factors and responsible for the prolonged duration of hydration of the skin. That is another important factor related to the barrier repair creams. And the first generation, this only the non-barrier repair. The advantage is there is a low cost and perform basic occlusive function. But the against are there can some are irritate the sensitive skin, drying of skin for alkaline products, the no skin barrier. For example, if you see the half-life of sunscreens is just 2 to 3 hours, whereas the half-life of moisturizers generally double the sunscreens, almost 4 to 6 hours. Whereas the barrier repair creams, so some studies, as per studies says, the retaining capacity almost it has been extended beyond 24 hours. So once in application is more than enough in the barrier repair creams. But that too mainly the compromised skin. In the normal skin you can choose non-barrier or barrier creams. But the cost is a matter with related to the barrier creams. So the approach is to use the barrier creams. Advantage is once in application. Generally the non-barrier creams generally I will follow rule of 3. The 3 times in application, and especially in atopic dermatitis, within 3 minutes of bathing for 3 minutes. Within 3 minutes of bathing, application of moisturizer 3 times in a day. That will maintain the hydration of the skin almost 24 hours. So the third generation, what do you say, the barrier repair? So only drawback is the cost. The same thing is, the creams, the moisturizers which contain the pentavietin, the advantage of adding of pentavietin is responsible for barrier repair. So the moisturizers which contain pentavietin and maintain the hydration of the skin, subsequently decreases the transepdermal water loss over a prolonged period, as well as prevents the entry of microorganisms or allergens or irritants. So these are some studies showed the response of this pentavietin containing moisturizers, the efficacy. And they have done the 4 weeks or 7 to 2 hours after the application. So almost it has the hydration of the skin was maintained almost 7 to 2 hours, the study says. But our requirement is if you apply once in a day, almost that is more than enough. Only problem is the concern is cost. So according to the disease, if for example if it is severe atopic dermatitis, almost the skin has been compromised. Not only the skin has been compromised, the innate function of the skin which has been compromised, especially the defensins which is responsible for the recurrent bacterial, fungal, viral infections, and subsequently the microorganisms themselves, they are responsible for initiation of atopic dermatitis, themselves they are responsible for the flares of atopic dermatitis, themselves they are responsible for the chronicity of atopic dermatitis, and themselves they are responsible for the cutaneous and as well as extracutaneous complications of atopic dermatitis. So the keeping atopic dermatitis in mild form, it's very, very important to prevent the cutaneous and as well as extracutaneous complications. So if you won't maintain the atopic dermatitis in mild form by the age of 5 years, if it is mild, the 50% there is a spontaneous resolution. But if it is converted from mild to moderate to severe, almost 70% they will become the chronic in atopic dermatitis even in adult form. So now no more atopic dermatitis is no more, it is a disease of pediatric age group. Now we are seeing in adults also. So atopy is nothing but the IgE hypersensitivity. But that IgE hypersensitivity is not sufficient to produce the clinical manifestations unless until the environmental triggers come in contact with the sensitized IgE and responsible for activation of the immune system, what you say, the pro-inflammatory mediators, and produces the signs and symptoms of inflammation, then subsequently atopy will be converted into dermatitis, what you say, atopic dermatitis. So keeping the atopic dermatitis in mild form and decreasing the inflammation, and subsequently it decreases the cutaneous as well as extracutaneous complications. The basic step for the keeping the atopic dermatitis, the moisturizers and moisturizers and moisturizers, and prevent the secondary infections by eliminating the triggering factors. What you say, just like Charminar, the infections, allergens, irritants, and the stress. These are the 4 factors responsible for conversion of atopy into atopic dermatitis.
Umesh, you are left with 2 minutes.
Yeah, almost it's over, sir. So to summarize with this pentavitin, so it maintains the hydration of the skin, decreases transepidermal water loss, subsequently prevents infection. So the moist is, as I said, must for survival, healthy skin and genital health. These are the different studies and benefits. If you add the moisturizers, niacinamide, that acts as a anti-inflammatory, antioxidant effect. The shea butter also is an increased hydration of the skin. Olive oil. So the usage, the ideal moisturizers yet is always patient friendly. So finally, so the patient friendly moisturizer is the ideal moisturizer. It should not cause any irritation. This I won't go in detail. So finally, so emollients are the cornerstone of young and dry skin conditions. So to choose conventional to the barrier repair, they are according to the disease. In normal conditions, you can give anything. So if you use effective moisturizers, that decreases almost 75% of the usage of topical steroids. The moisturizers are used to too small quantities, it won't help at all. So healthcare providers' role should be emphasized continuity of skin care and the patient satisfaction. So always we are continuously sensitizing. Please spread this message. So this is a special the discount for the delegates, the CUTICON delegates. Please utilize this opportunity. Again, the leprosy. There is special discount. Only 5,000 for the Telugu people for online registration. 4,000 for the PGs. Thank you. Thank you very much for your kind attention.
Thank you, Bhumesh, for your vivid and very lucid presentation of various moisturizers and the newer insights in a very lively and very jovial manner. Thank you very much. So now we move on to the next is the panel discussion. The topic is management challenges of various pediatric dermatoses. And we have a moderator with 4 panelists. The moderator, I call upon Dr. Kota Sai Krishna to act as a moderator for this panel discussion. Sai Krishna is a consultant dermatologist of the Yashoda Hospital, Secunderabad, a very reputed and renowned dermatologist. He is an ex-associate professor, Department of SPS Medical College, Head of Secunderabad Hospital. Honorary, served as Honorary General Secretary IADVL Telangana State in the year 2018 and a life member of various associations, and is highly academic in nature and has contributed a lot for the academic activities for the association. I invite Dr. Sai Krishna Kotla for his panel discussion.
I request the panelists, Dr. Chandravati Madam, Dr. Madhusudan Sir, Dr. Bhumesh, and Dr. Sirisha to please occupy the dais.
A little bit high.
Yes. It's fine, sir. Thank you, sir. Thank you, Madhubabu sir, for
If you want, you can use the mic.
kind introduction, sir. I think the panelists.
Thank you, Sai Krishna. So just overnight, because Dr. Rajiv Sharma, he could not attend because of his ill health. So that's why immediately almost night 12 o'clock I called him. So, Bhaiya, ye kar do. Without any hesitation, he said, okay, thank you very much. So please carry on.
Thank you, and it is nice to have a panel. You have a very famous panel here. Dr. Madhusudan is a practitioner, and he is a gold medalist in dermatology. Chandravati madam requires no introduction. Dr. Bhumesh and Dr. Sirisha. So without delay, I will like to go into the session. Sorry, because this was short intimation, so please kindly bear with me if any mistakes are there. Thank you. So, Acha. Yeah. Yes.
Hope I'm audible now. So this is a 3 months old baby boy presented with pigmented macules over the face, trunk, extremities. According to the mother, child was rubbing the lesions frequently, followed by redness. The child was diagnosed earlier to have a neonatal acne. I think it is not here. Yeah. So these are the lesions, and I think the diagnosis for our panelists is easy. They are slightly pigmented, leathery skin colored, slightly raised macules distributed all over the body, and there is this. We can see this small scratch on the back. You can appreciate this thing, and I would like to ask the panelist, Dr. Madhu, what would be your diagnosis? And
sir, by the way, clinical picture and the history, it is more going towards a cutaneous mastocytosis, because we are seeing the erythematous powder. Diarrhea sign is becoming positive, so more likely urticaria pigmentosa or early stage of diffuse cutaneous mastocytosis should be considered.
So, madam, can we differentiate clinically urticaria pigmentosa from diffuse cutaneous mastocytosis?
See, urticaria pigmentosa, there will be normal skin will be there. There are islands of normal skin, and there are few lesions are there, but we can't say because it's a small child.
Yes.
It can become
very difficult to say, but
yeah.
Only thing is sometimes textbook description, sometimes face, palms and soles are spared in your urticaria pigmentosa. Yeah. So, Dr. Sirisha, so how would you like to go about this case, and how would you like to investigate?
Sir, first I would like to do some basic investigation, CBP with peripheral smear, LFT. Would also like to check for organomegaly, and then skin biopsy for confirmation of the diagnosis with special stains for mast cells. And based on the symptomatology, if there are any involvement suggestive of systemic symptoms, and further management, and serum tryptase levels.
Yes, thank you. So, Dr. Bhumesh, when do you suspect a child to have, okay, so when do you suspect child to have systemic mastocytosis along with this cutaneous mastocytosis? Any clues? Anybody can?
Basically symptomatology, sir, but in children most of them are benign, and systemic involvement is very rare, and especially urticaria pigmentosa, which is quite common, resolves by puberty most of the times, but if the lesions persist beyond puberty, maybe we can evaluate. And symptoms, systemic symptoms suggestive, we have to evaluate with bone marrow.
Yeah, child is having other GI symptoms, and any other in the blood also. If there are any, so you have to go for a bone marrow biopsy and all those things.
Yes.
Otherwise, most 90% of cases in children, they are benign.
Yes, madam. Unlike adults, yes.
Unlike adults, when you see the mastocytosis, mostly it is a cutaneous. So give assurance and just follow. That's more.
Yes. So, but in adults, the only difference is even if you see cutaneous manifestations, the bone marrow biopsy is compulsory. In children, it is not required. So we look at the tryptase level. Until unless it is very too much high, we do not follow bone marrow biopsy and all. And of course, symptomatology, as you are saying, we are going to investigate for the symptomatology. So in this case, we did a basic workup, and the ultrasound was normal. There was no organomegaly seen, and then the tryptase levels were 8.5 in the initial instant. And then after how many days would you like to check tryptase level again?
Every 6 months.
6 to 8 months you can repeat, and then you can see that it has decreased tryptase level, and then so the histopathology, you can see the atypical cells, nuclear ATPI is there, and dermis, which proliferation of oval and spindle cells. And then you have this toluidine blow stain, cyanophilic granules are seen. So, and IHC, of course, is important. Sometimes it helps, especially KIT is there. Then systemic manifestation is more. So this is the IHC report. Okay. Then comes the response. The child responded well. So how would you like to manage the case, Dr. Mazula?
First and most is counseling, sir, because we need to counsel the parents that it is going to be long term. Avoidance of trigger factors, especially hot showers, rubbing of the skin, wearing harsh clothes, and avoidance of syrups, especially which provocates cough syrups, and NSAIDs and preservative drugs. These are the things which will worsen the things, so that we need to counsel them and make sure that the patient doesn't rub the skin, and we need to counsel parents regarding it. And coming to the management, I feel cyproheptadine works better than other. It scores up better than. My experience with urticaria pigmentosa, cyproheptadine is the best drug.
Child is 3 months old, so sometimes antihistamines management is topical steroids. Tacrolimus, does it work?
Topical, I don't think it requires much.
Single mastocytoma.
What is it? Cyproheptadine works well, and then topical emollients will be enough.
And then coming to the next case, this is a 11 years old boy with a history of fever, about 10 days to 15 days, not very clear. They had visited several doctors. So he was treated with antipyretics, then later developed the blisters on the lips, you can see. And then if we examine his palate also, there are a lot of ulceration seen. So he was having no arthropathy, and the erythematous rash was seen on the palms and soles. And he was treated with systemic steroids and topical steroids, but the lesion started aggravating. That is when he was brought to our clinic. And then you can see these lesions on the palms. Some of them are blistering, central blisters are seen. And you can see on the palms, soles also, the similar lesions. So, Dr. Madhusudan, what do you think?
Sir, erythema multiforme worsening with HSV1 infection, because the target lesions are seen, crusting of lips are seen. So, it's erythema multiforme with primary HSV infections.
Madam, any other diagnosis you feel should be considered?
Even I suspect the same thing.
Yes.
Most probably, but of course the other things are vasculitis and Stevens-Johnson's, all those things they should keep in mind.
Mostly the extension spectrum of erythema multiforme, major, Stevens-Johnson's and all these things. So how can you pinpoint here, Dr. Sirisha? How do you think we should conclude erythema multiforme in this particular case more?
No, there must, yeah, go ahead.
We look for the classic morphology of the lesions, the target appearance on the palms and soles. And also the oral lesions, I would like to do a ZANC just to rule out HSV infection, if there are any active
Already
vesicles.
hemorrhagic crusting is there, difficult to do Zank. Yeah. So, any other investigation you would like to do?
We can always go for serology, HSV serology, for the triggering factor.
How do you like to manage? Then next, sir? Next, how do you like to manage?
I would also like to ask for prior drug history, sir, if to find out if drugs are the triggering factors, because erythema multiforme.
Any other connective tissue disorder also you would like
even
to
as a part of connective tissue disorders.
Yeah. So these are the things. Basically, routine hemogram, and these things will definitely help. And then this is the clinical picture, what we can see. The lips, hemorrhagic crusting on the lips. So here it is difficult. What exactly is the herpetic lesions would have been there in the patient? Exactly, or really herpes is there or not, we cannot see. We can see the hemorrhagic crusting, oral ulceration and palmar lesions. We are expecting that it is a herpes simplex triggered erythema multiforme. But several other viruses or other infections also, because he had fever, so we do not know. So such
if she's
cases.
a female, you should also keep in mind of systemic lupus erythematosus also.
Yes, madam. So we did this blood pictures and ANA titers were negative. Then this was after we have started acyclovir to the patient. So he responded very well to acyclovir, but still again the dilemma, because initially he was given steroids, and we know that erythema multiforme is self-limiting. So you don't know if our acyclovir really helped or he improved over time. So this is after his healing of the lesions. Anything?
Yeah, one point related to, if you see erythema multiforme, the mostly whether it is a disease or a drug or idiopathic. So if it is disease, we have to rule out herpes. So in those conditions, if you give acyclovir, that will prevent this progression of the disease. Whereas if you think of a drug, if it is a disease, virus is a culprit, if you give steroids, so there is exacerbation of the disease.
Yeah. So that was probably the prior doctor who has seen the patient had a dilemma. That is why they started him on steroid, thinking that it could be a drug.
Steroids were given, no?
First
in this
steroid
case.
was given.
No
So still it was worsening.
So that means the virus is the
So
cause.
that is the dilemma. So to start with acyclovir first or steroid first, both together, sometimes it is because the time when they present to us is important.
In children, always we should go with the antivirals first. Yes. In adults, yeah, definitely we should think of drugs. But in children, my opinion is always we should think more in terms of infective.
Because sometimes erythema multiforme can also present with look for lymphadenopathy in the initial stages. You can see that other mucosal involvement, and then we can decide. Yes, there are certain other things. Then moving to the next case, a boy from Uganda presented with hyperkeratotic thickening of the palms and soles since very young age, maybe few years of age. Then history of consanguinity is present. He had 8 siblings. Out of 8 siblings, younger brother and elder sister have similar changes. There was loose malformed teeth. Changes are there. This is the hyperkeratotic lesions in his palms and soles. And then you can see the dental changes. That part is his younger brother, and then that is his sister. So, Dr. Sirisha, you would like to comment on this?
Yes, sir. We should look for syndromic PPKs. Obviously, he has palmoplantar keratoderma and associated gingivitis, periodontitis more of.
Yeah.
So we have to rule out Papillon-Lefevre syndrome and its allelic disorder.
Yes. There is no mental retardation in this patient of ours.
Would like to check for lesions over elbows and knuckles, knees, and
everything
any
is fine.
hyperkeratotic
Other
plaques.
areas are fine, and these are the only lesions he is having, and his sibling pictures are sent from there. So
only periodontitis with PPK.
Which
probably.
of the PPKs do you consider in these cases?
Sorry, sir.
Which type of PPKs do you consider in this case? One is papillon you have
Yeah.
told. Then next.
Nails are normal, sir.
Yeah, nails are normal.
If nails.
Dorsal picture you can see. The nails you can see in this picture. So again, Howell events and other things are there. Yeah, agree with this. What
3L
basically
syndrome.
here is other conditions do not involve the teeth. Here teeth is specially involved. So papillon lefevre syndrome, that is what we are considering here. So how would you like to go about with this case?
It's a genetic disorder, so probably genetic counseling is the first thing, sir.
Yeah,
Nothing
genetic
much can be done.
counseling.
Can
But he is having
advise.
difficulty because his palms and soles are very difficult. to know
Keratolytics for the PPK, symptomatic treatment, and of course dental referral to orthodontist is important.
Madam, you would like to?
Oral acetretin you can do.
Oral acetretin can be started. So what are the advantages and disadvantages of oral acetretin? When to start, when you see the patient, and how long to continue?
How long to continue is a difficult point because it is a genetic disease. But as long once the thickness of the palms and soles goes off, patient is comfortable, I think you can reduce it.
Yes.
Maybe seasonal, sir. In winters and all, when there is exacerbation, we can give a course and then give a break and then repeat.
We need to give oral acetretin, sir. It is drug of choice. Once it comes down, we should maintain with the topical salicylic acid and topical retinite, sir. Most of the 70% people will be happy with a modification of footwear with the topical salicylic acid with the topical retinite, sir. Especially tazaratin or high dose of retinol.
Okay. So that's what they say. You can start acetretin early. Even there is a risk of early epiphyseal fusion also, closure also. But still they try to start early and then they ask us to continue because there is a improvement of dental anomalies also with the acetretin, not only the skin part. So they ask you to continue till the successor teeth come and they are maintained. So till that time you can continue. If you find the case very early in the stage of onset. So this is how we manage, and then sometimes it might require CT scan of the brain because there is intracranial calcifications and all. Then of course a genetic study in this case is on the way. Probably we will get the reports by January.
Two more children.
Yes, madam. Elder sister and younger brother. In the same
So
family.
I think we should counsel the parents also for further pregnancies and all those things.
Eight children already. So I don't think there's scope for further, but we are getting the genetic analysis done for their family. So that is what. So this is after acetretin we have given to the patient, and then there is an improvement in the patient. He is feeling better, right? Yeah, a 4-year-old girl presented with generalized extremely itchy rash, erythrodermic in nature with flexural predominance. The patient was irritable and had boils over the left foot and left hand, which had started a week back. And then you can see that eczematous dermatitis, lichenification affecting the face, trunk and the extremities. You can see the excoriations, and of course there is lichenification and thickening of the skin, and that is the boil over the left hand, and the eczematous skin with the boils are not very inflammatory. That is a cold that is devoid of signs of inflammation. And then there is a deep set eyes, and then there is perioral rash, and then there is a extending rash is extending into the hairline also. It is not being demarcated. No facial dysmorphia as such, but except for some widely set eye, if you can say, in this particular patient. So what would you be your first diagnosis, and what are the differentials you would consider in this case? Because the child is suffering from very long, and the child has been treated with multiple courses of cyclosporin and other immunomodulators. Yes. Madhu, sir.
Sir, one is patient chronic atopic dermatitis where lichenification and recurrence are there, and secondary infections. And in that, you are seeing a deep-seated abscess. So, atopic dermatitis with secondary infections, predisposing. If it is recurrent, we need to think screen for especially job syndrome. One is the thing, and any other immunodeficiencies should be ruled out. One more Omen syndrome also can occur, but most common is the job syndrome is the one which we need to screen.
Atopic mimics can be screened. So when do you suspect a patient, and what are the other immunomodulatory deficiencies you consider in these cases? Like you said,
yes, one is this one, sir.
Yes.
Second one is getting abscesses. Third one is recurrent nose, sinus and lung infections. We commonly see the external artery infections. But if it is a autosomal recessive jobs, we'll see most of the viral rather than bacterial. It is completely different picture what we will see autosomal dominant. And one more thing is, if the patients are more recurring for infections, if we need to see for the any platelet abnormalities also, one more thing, the Viscott-Aldrich syndrome, where is the platelet coagulation abnormalities with infections. So these things which need to be think and which need to be followed.
100%. Yes. So here you can see further fissuring of the lesions. So what are the laboratory investigations, basic investigations you would start, Dr. Sirish? Madam. Basic investigations like
all the basic investigations we look for, sir, because there boils also we look for secondary infection, the WBC counts, ESR, CRP and all. And in addition, we look for IgE levels because that is a criteria for diagnosing job syndrome.
Yeah, all the immunoglobulins.
Immunoglobulins and
Yes.
specifically
Madam,
IgE.
anything specific you want? Chandravati, madam.
Pardon?
Anything you would like to add into this?
No, Viscott-Aldrich syndrome is
Yes.
one thing that I think we should look for, that IgA and all that we should
Yes.
look. And one more also should keep in mind, I was actually Netherton syndrome is one more also
Yes.
comes like this. So you should check the hair also.
Yes.
Any hair shaft deformities is there.
Yes.
Many other conditions also can come as a differential
Nonbullous
diagnosis for this,
ichthyosiform
not only atopic
erythroderma.
dermatitis, because
Yes.
you should take it as erythroderma and different types of etiological cause you should look into.
Yes, madam. Non-bullous ichthyosiform erythroderma.
Yeah, of course, immunodeficiency, because child is getting frequent boils and bacterial infections, that those T cell immunodeficiencies or immunoglobulin deficiencies, all these things we have to look into.
Yes.
And of course, at the end of it, a skin biopsy also, and ichthyotic disorders also you should rule out.
Yes, ma'am. Skin biopsy was done in this case, madam, and then as rightly pointed out, we did all the things, and then the immunoglobulin IgE came as 5,299, and eosinophil count was very high, and ESR was high compared, and other immunoglobulins came within normal range. So we made a diagnosis of IgE, hyper IgE syndrome. So then followed by our genetic study, and then it came as DOC8 positive. So it was autosomal recessive, and this is one case. Okay. So management would be
Management symptomatic, taking
management.
care of the infections.
Infections.
And prevention also is one more important thing, because they are prone for the infections, bacterial infections.
Sometimes,
And of course, skin care. Skin care is also equally important, because the
Long-term
barrier,
bone
skin
marrow
barrier function is very important.
Yes. Bone marrow transplantation may be required.
Yes, that is the last, yes, definitely.
Coming to more common case, madam, what we see in our practice, a young boy, 8 years old, with patchy hair loss, crusting, impetiginization on the scalp for 1 month duration. He has itching and was treated outside with desonide lotion with no response. Then he was started with terminafine 125 milligrams with topical ketoconazole with no response. Then they tried for 15 days. Presented with this condition, how would you like to manage? Madam.
Yeah, looks like a Kirian. First, investigate some plucking of the hair and all those things, look for those things, and then start an oral oral antifungals. My favorite is grisofulvin only, even now.
Yes, madam. Excellent.
Yeah, 20 milligrams per kg body weight I usually give.
Yes.
So, and then topical shampoos, ketoconazole shampoos. At least for 3 months is required. And suppose it is painful and boggy, a short course of steroids, oral steroids also is good.
Yes.
So that we can prevent psychiatric type of alopecias.
Alopecia. Yes. So what is the take on terbinafine versus griseofulvin? Like you told, griseofulvin scores over terbinafine?
I have the experience of this. I usually, once patient is not responding, yes, terbinafine is the drug of choice.
Yes.
But oral syrups are not available.
Yes.
Are they available?
No.
Yeah, that is the disadvantage.
And, they can be mixed with milk and
But theoretically, they say for trichophyton species, terbinafine works better than microsporum
yes.
species, but clinically we can't differentiate. So
clinically,
griseofulvin
we have to
is
wait
a
for 1
FDA
month
approved choice.
for that fungal cultures to come.
But till now, many guidelines have changed, but tinea capitis still grisofulvin is the drug of choice.
Gold standard. Yes.
Gold standard. First, we should go with grisofulvin only.
Yes. Bhumesh.
Yeah, in a child, when you see a patchy alopecia with signs of inflammation, the back history is very important because even initially there is a patchy alopecia, application of irritants, and that is associated with the signs of inflammation. So any patchy alopecia, whether it is infective or autoimmune, so that is very important. Even recently we have seen, initially there is a patchy alopecia, they applied some irritants, and we presented with just like we thought of tinea capitis, but the patient was not responded. Then we did the dermoscopy. So that has given a clue to rule out from whether it is infective to autoimmune conditions. That is one. Once if you label confirm, because even if you do KOH, only 40 to 50% or maximum 60% will be positive. But therapeutic response, we have a 3 in our armamentarium. You can go with the fluconazole, we can go with the griseofulvin, we can go with the terbinafine, we can go with the itraconazole. But the point is the griseofulvin, it is the standard drug. The response was excellent, especially in the hairy areas. We have a micronized and ultra micronized also. To get response minimum, it will take 6 to 8 weeks.
Yes.
But only the patient adherence is a problem.
Yes.
So that has to be explained. If the
That
money
has
is
to
a
be-
burden, you go with the griseofulvin. Otherwise, even you can go with the terbinafine
tell the
or
patient, yes.
itraconazole.
Yes.
Sir, one very good point Bhumesh sir has told. Dermoscopy definitely useful in this condition.
Yes.
You will see the black dot hairs with the broken hair. You'll get a clue. I will say in tinea capitis, dermoscopy is going to improve your diagnosis before going for investigation. So do dermoscopy in a tinea capitis case.
Yes.
I have a doubt. In Kirian, what are the dermoscopic findings? Because it is inflammatory
Very
and
difficult.
boggy swelling.
Inflammatory, boggy swelling and crusting is also there. I don't think in this particular case, dermoscopy, until unless you clean it and all, it will be masked because it's
Yeah, that
already
is
delayed
what.
case.
Dermoscopy
But,
in a
what they are
Kirian, it will
talking
be
about
difficult.
is general tinea, regular
Yes,
tinea
yes.
capitis,
Yes,
gray
agree.
pattern or broken hair. Then here is a cervical node also this child is having. So this was managed with, as you told, griseofulvin, and then you can see the improvement within few days. The child started responding. Yeah. Then this is a foul smelling. This slide, this one particular slide is from older. I think this is Arun Iranda sir case, not my case. Foul smelling, sore rash on the face. Treatment with the oral antibiotics, amoxicillin, cephalexin were ineffective in these cases. In this case, you can see the crusting later. You can see all monomorphic crusted 4 mm papules and vesicles coalescing into crusted plaques over the cheeks and fingers. Yeah. So another similar case with similar. Both the children have past history of atopic dermatitis. So the earlier child father had a history of cold sore on his lips. So the child had fever and all these things. So what is the diagnosis, madam? You can go ahead.
Eczema herpeticum?
Yes, madam. So it's eczema herpeticum, and then how do you differentiate this case, madam? This is eczema coxsackicum. So any differentiating points?
Eczema, coxsackium, they're more painful. Herpeticum, they're more
Inflammation is
itchy.
there. If there are pustules also there in this case. Crusting is there.
Rapid progressing necrosis will be there in herpeticum, sir. Coxsackium, you will see more of a bulle. Rather than the rapid progressing necrosis, you will not see in a coxsackium, sir, eczema coxsackium. And second thing, disseminated lesions will be seen in coxsackium, more like a hand-foot mouth disease, which a disseminated spread will be seen in eczema coxsackium.
How would you like to manage the cases? In both the cases, standard regime.
But acyclovir should be given, sir. Acyclovir standardized dose definitely works in both cases, sir.
Yes.
In coxsackium, it is a debate, but from my point of view, from my little experience, I am saying it works.
Yes.
Acyclovir, if it is a pediatric, acyclovir, even in adults, acyclovir works, sir.
Madam.
Yeah, acyclovir, because coxsackie, nothing is there, so I think if
First,
you give.
follow up the patient, check for his systemic symptoms, check the CVP, his general condition.
Yes.
If he is, because the seizures are also known to happen, then systemic infections, meningitis, other things are also common in these children. So, taking good fluid care, oral lesions are there or not, we have to check, and then yes. And then probably start with the medication, then topical these things. Yes, Dr. Madhu.
Sir, one point I want to tell, sir. During my PG days, we have done a Zank smear, started an oral acyclovir before Zank has come. The patient has finally ended with myocarditis. If we have not started oral acyclovir in early age, maybe we would have lost the patient.
First thing is immediately start.
Yes.
That is the first dictum. When you see, start. And that too, IV is preferable or oral is preferable.
Yeah, if you see this, if I see this case immediately, I'll admit the baby.
Yes.
First, you admission is very important. Then the second point, rule out atopy, because herpes infections, of course, in adults, a benign condition.
Children had history of atopy.
History of atopy is there, that has to be ruled out, that has to be addressed. Admit. And at this condition, then look for the constitutional symptoms. If constitutional symptoms are severe, there is no point in giving oral acyclovir. Give IV acyclovir, 10 mg per kg, 3 times in a day at least, give for 3 to 5 days, then you will see the constitutional symptoms will subside.
Yes.
And then switch over to oral acyclovir 20 mg per kg, 3 times in a day, another 7 to 10 days.
Excellent.
And you address for the supportive care.
100%. Thank you.
IV acyclovir only, sir. Oral acyclovir you should not wait. You should give IV acyclovir only. Yes. There is no second.
Yes. Again, one of the common conditions we see in our clinical practice, in neonates with diffuse erythema, yellow crusting erythema, periorbital area, perioral area, oral mucosa not involved, Nikolsky sign positive, then there is tender erythema, child is crying. So another case with similar findings, perioral and periocular involvement is there. Dr. Sirisha, would you like to comment on these cases?
Yes, sir. A classical case of staphylococcal scalded skin syndrome with oral mucosa is not involved, tender skin, perioral rash and desquamation.
Yeah, so how would you like to investigate these cases? How do you start treatment?
You should admit the baby first.
Yes.
And give supportive treatment, and antibiotics, IV antibiotics targeting mainly staphylococcus has to be started, sir. Blood cultures can be sent because from the skin lesions we might not get anything because it's toxin mediated.
So where are the sites you look for?
But perinasal areas, perianal areas, we still can take swabs.
Post-auricular, periaral, and here in the genital area also. And then sometimes it can be the mother or somebody, or elder brother or elder sister who is having any bullous impetigo can trigger this in this neonates or infants, and sometimes children. So sometimes you see not a full-fledged staphylococcal scalded syndrome. Sometimes you get this diffuse blisters, and then they may not progress. Maybe early treatment would have arrested. So like this. These are all the different cases of staphylococcal scalded skin syndrome. Yeah. Then this is again one thing we see in a clinical practice, extensive folliculitis in children, non-diabetic, but so how would you like to proceed with these cases?
More like a periportitis staphylogen, sir. Need to give amoxicillin clavulanic acid or cloxacillin. That will work better, sir.
Yeah, so there are different types, starting from small follicular lesions to parenchylosis to...
One point before slide, the staphylococcal scarlet skin syndrome, generally if you see in the pediatric age group, so immediately you admit the patient. So don't wait for the investigations.
100%.
Empirically therapy that should cover the staph aureus. The either third generation cephalosporin IV should be given, then send for the throat swab for the penicillin or resistance. If it is resistant, switch over to vancomycin, 20 mg per kg.
You prefer cephalosporin, or would you like to go for clindamycin or vancomycin?
No. Initially you give third generation cephalosporin. They send for throat culture. If throat culture is negative, you can continue. And if it is positive for methicillin resistance, then you switch over to vancomycin, the 20 mg per kg 3 times in a day. The 20 mg is the start dose, then followed by 10 mg, the almost 2 to 3 times a day for 3 to 4 days. Then switch over to oral. That's the second point. And there is no point in giving the topical antibiotics because it's a toxin mediated, there is no point. And fourth point, because the source of infection we have to look for, as Shirisha said, perinasal, the ear, because from the nose there is incubation to reach the skin 7 days. Again to cleavage of desmoglein, it will take another 7 days. 14 days the incubation period would be there. So immediately admit, treat and look for the carriers, the source of infection.
So one thing is, you wanted to say something.
Sir, one thing, one contradictory to what Bhumi sir tells, sir. Most pediatricians prefer cephalosporins, but I still feel staph penicillins are the drug of the choice. If you use dicloxacillin or amoxicillin with clavulanic acid or a vancomycin, the response will be fast. But many pediatricians, because of diarrheal side effects, they are in a little comprehensive and they don't use much. But
it's definitely not nosocomial, it is definitely community acquired. So as you told, penicillin 5 penicillin groups can be very effective.
Penicillin group, actually they are the drug of choice. What you said, one point, because the chance of diarrhea. And second point is bitter. So acceptance from the child is very, very poor.
Very.
So these are the two reasons. Otherwise, the penicillin group of drugs are excellent.
Excellent, yes. And then third generation you prefer, or earlier generation?
One thing, that is also, I want to tell, as if you go by cephalosporins, as you go down the generation, gram-negative coverage will be more. First and second generation will be more gram-positive, third and fourth will be more gram-negative. So we should choose more of a second generation.
So why not go for clindamycin or linezolid? As of
You
now,
can
we are
use
starting.
linezolid, vancomycin also.
Sai Krishna, last 1 minute.
Yes, this also discussed, I think. So patient presenting with, again, do you suspect again immunodeficiencies and all these things? Source or these things to be investigated in these cases, and then cultures. Here we can, skin culture, pus culture can be helpful in these cases, not in staphylococcal scalded skin syndrome. Yeah. So thank you for your patient.
I am extremely thankful to Dr. Sagish and all the panelists, Dr. Madhu, Dr. Chandravati Madam and Sirisha and Dr. Bhumesh for a wonderful panel discussion on the very interesting and very tough case of periodic dermatosis. Over.
Yes, yes, sir. That's what.
That's what I told, sir. First, a cloxacillin and dicloxacillin and amoxicillin clavulanic acid should be chosen as a first track. That only first option we have given, sir.
Cloxacillin is the best choice of drug, injectable one. Yes. It gives best results in case of triplets, right?
Thank you, Srinivasa, for your inputs.
And active enteropathica, you have to consider in those cases as a DD for triplets.
Yes.
With the permission.
Sir, please. Sir.
One thing I read, is you said during EMF with recurrent herpes, you are not supposed to give steroids.
Yes.
But Thomas Abbeef writes that EMS is only a kind of autoimmune reaction to the herpes. So you can give steroids during the acute stage. Acyclovir only is useful to prevent the further attacks, not the present attack. So how our moderators take about this point is one.
Yes, sir.
Second is, when we see these neonates or small kids in the pediatric wards with SSS, is there any bedside test which can differentiate that from some other TEN or something? Because this is not mentioned in our standard textbook, only Schambach's liver writes that 3-4 points, I think for the sake of pages.
Yeah, this frozen sections.
Frozen section.
Frozen
Yeah.
sections,
What are
they
the features in both? Because that will differentiate TN from SSS. So
Yes.
that is very important for
Very
the
important.
treatment. For the benefit of
100%.
juniors, I
Frozen
think
sections is one thing,
any
sir.
one of you can take this.
Yes, sir. And as you rightly mentioned, sir, it is a
Totally
EMF
different.
is
There
a-
you give steroids,
EM
here we don't give
Eczema
steroids.
multiforme is a hypersensitive reaction to herpes. It is not a herpes
Okay.
direct.
In children, you have to differentiate
Can I tell her that point?
Yeah, 1 minute. Before you come as the panelists, please. You have to tell particularly young postgraduates the need to differentiate between T and SSS, particularly in children. Because the outcome, the treatment, everything differs totally, including the prognosis also.
100%.
So bedside diagnosis and confirm is a critical factor in starting of the treatment. That's very important.
See, if I remember right, long back I read, where if you take the frozen section, you see necrotic keratinocytes with inflammatory infiltrate in
Zero
the
inflammation
TN.
in TN.
TNSJ, yes. In Staphylococcus, it's
Inflammation is there.
Yeah, it's a cuboidal cells you see.
No, this is regarding the same EMF
TN first.
background of herpes. Until unless we have a proof that there is evidence of acantholytic cells or the multinucleate giant cells, there is no evidence, we can safely start this systemic steroids.
This patient was already started on steroid. It worsened.
No,
So-
what I am going on that there has to be steroids are not the drug of
stage
choice.
at which the patient presents
No, that's
clinic.
true. No, no. What discussion was going on was the antiviral. I was telling antivirals is the first drug of choice. Until unless you have the proof, you cannot give the antivirals.
Yes, sir. Sir, what Manmohan sir has told, recurrent episodes, acyclovir is taken.
Yes.
But even in primary episode, when you are seeing the necrotic lesions, if you are suspecting a oral herpes, definitely you need to give acyclovir.
Yeah, that's
What
true.
is-
No, until unless there is evidence.
Yes.
It could be. But in other cases where the EMF is there,
I see.
in such cases first drug of choice.
All EMF is not a herpes induced, no sir.
Exactly.
That's why drug induced EMF is there. Here it is a classical case, sir.
Yeah.
That's why I told in children infections are the first commonest reason. It is not in the adults.
Exactly. And
Yes.
other thing is, not only the herpes, the mycoplasma pneumonia.
Yes, even mycoplasma pneumonia also can cause, sir. Yes. Like pityriasis rosea, we have multiple etiology. EMF has also has a multiple etiology factor, sir.
Even in EMF, you have lighter variety, we have EMF major, minor, including necrotic lesions are seen.
Yes.
So-
EMF major more like it presents like overlapping with SJS and TN, sir.
So
Yes.
we would like to know whether we can give corticosteroids there or not.
If you are suspecting herpetic infection, better withhold. If it is not, early first week you should give that. If you, sir,
Two
how you do
important
know?
things, sir. One thing is, sir, EM presents usually after 10 to 14 days. It is not that it presents on the first day,
Yes.
first episode.
Yes.
So when it starts, by the time usually the herpes would have subsided. So when the inflammatory lesions are more and then it becomes important for us to start steroids. But if you are suddenly sometimes the onset of the fever and everything happens in a very short time, then that means we are beyond the incubation period of the virus, that is 14 days. During that time, it is important that we start acyclovir first, rather than taking the chance with the steroid, because once you are sure if it is not
No,
a
once
drug-
if it is almost going into SJ type, we may be forced to start steroids.
Yes, sometimes-
So what I asked Dr. Sirisha is, she said something about serology. Is that will help you in this acute stage? I'm talking about serology, herpes simplex, HSV1, 2, IgG, IgM. Will they help you in deciding whether it is the EMF or it is the herpes which is causing this?
In the acute stage, maybe we can look for IgM antibodies, sir. Recurrent cases also, recurrent herpes simplex, maybe we can do a serology.
What I think is probably this higher levels of IgM indicates it's a recent infection, so it is better to withhold steroids there. Otherwise, erythema multiforme major, you can comfortably give steroids because that is how we have to manage. Herpes, forget, nothing will happen. Even varicella, we give so much of steroid for Ramsay Hunt. So they are not that dangerous to cause problems. But only thing is, these two things we have to decide whether it is herpes is still active with the IgG, IgM levels, or it is only a reaction that is causing this with the titers of HSV1 and 2 IgG, IgM. Thank you.
Once again, thank you, Dr. Sagrish and all the panelists for a wonderful session. And we are also thankful for the senior professors, Dr. Manmohan, Dr. Srinivas sir, and Dr. A.G. Rao sir for their valuable inputs. And we have come to the end of the session today. And we are highly thankful for all the delegates who have participated since the morning till evening, staying back till up to 4 o'clock with a good attendance, almost 80 to 90% attendance. And today we have a closing session. And tomorrow the morning session starts by 7:50 with the award papers on the Hall A and simultaneously on the Hall B also. And now it's time for us to go for the annual general body meeting. It's for the AGM. And I request only the delegates who are life members to stay back in this hall for the AGM, and the rest of the people and rest of delegates who are not life members can leave the hall, and also the former people also can leave the hall. Only life members please retain back for the AGM. It's going to start within a couple of minutes.
Sir, please join us for the momentum presentation. Thank you. Moderator, sir, and panelists.
सौजन्य भी नहीं है जी, लीडर लोग बात कर लेते हैं, पूरे चले गए ना जी, तो फिर देखो और एक हाँ देर सर हाँ राइट नहीं आप कोई भी पूछे तो
I request all the life members of IADVL Telangana, so please join for the annual general body meeting which is going to be held soon in 1 or 2 minutes.
I request all the AGMs, all the delegates, this is the time for the AGM to start. I request all the life members who are in the canteen, who are refreshing themselves, please kindly come back to the hall and join for AGM. I once again request all the life members to come for the AGM who are in the refreshments. It's about to start. Please come soon. Thank you. Please join for the AGM. Venkat? పేరు పిలవమంటారా చెప్పండి. అది కాదు సార్, ఇది ఇలాగ ఇచ్చారుకోండి, కొంచెం డబ్బులు గిబ్లిస్తే ఈ పని కూడా చేస్తాం పార్ట్ టైం. ఓకే పట్టుకుంటాం. రేపు మార్నింగ్ వస్తాను, వచ్చేస్తాను. ఒగ్గు లేదు కదా, ఇలా వెల్కమ్ బ్యాక్. పొద్దున వచ్చాను, లాస్ట్లో ప్రశ్న టేక్ రెస్ట్. ఇవ్వండి. ఇవ్వండి సార్, మీరు ఏం చెప్తారో చేస్తాం. ఏమని నీ పని నా పని అనుకుంటే బ్లూ ఉందా గ్రీన్ ఉందా?
ఆయన రెడ్ ఎప్పుడైనా
బ్లూ. Last and final announcement for the delegate, for the life members. Please come very fast and please hurry up. Sir. ఇంత బాగా అరుపు మొత్తం వినిపిస్తుంది.
Good evening, everyone. Good evening, everyone. We will start AGBM 2021 of TS IADVL now on 25th December 21. First of all
the delegates are requested to kindly join the AGM.
I request you
It's
all,
going to start. All the life members, please come out to the hall.
I request you all to stand up for a minute for in the
So, good evening to everyone. In the AGBM, so that will be started with arbitrary. So this time, the arbitraries of in this year, Dr. Lavanya, she was expired on 1st January 2021, and our legend, Dr. R. Patnaik, he was expired on March 24th, 2021. And Dr. Abhishek Raju expired on 19/5/2021. Dr. Emmanuel, our friend, he expired in June 2021. And Dr. C. Shakuntala, she was expired on 14/7/2021. We request all the members, please stand. Thank you. We have proposals, it was sent, and some ratifications, and regarding the ratification of Professor R. Patnaik Gold Medal Dissertation Award, it was decided in the previous meeting. So Dr. Patnaik's son Sachinath already has donated 10 lakhs rupees for this dissertation award on the name of Dr. Patnaik. Is it? Thank you. Yeah, sir.
I think we should all thank Dr. Patnaik's family members who have taken this step. I just wanted the general body to take a thing. They have just written 1 year of dissertation. After passing that 1 year, they will be busy, either establishing their clinics or they may be doing seniormanship. That is too short a period for somebody to compete in this dissertation group. So can we increase it like national? B.B. Satyanarayan Award is given for the same, I think. On the guidelines of that, can we increase the time so that we can accommodate some more good papers.
Yeah, we take the opinion of, yeah.
No, our association is doing, no, they are only sponsors. You can frame your own.
No, the house feels that we should accommodate. Ganeshwar.
No. Yes, what?
Actually, this purpose is because of his Sachinath's son, he wanted to encourage the younger generation. So that's why his suggestion, we have taken his suggestion just for 1 year. So the house is open for the discussion.
No, the question is, no, when as per the constitution, when we have there is given. No, in the constitution, when somebody donates money for a specific purpose, and the specific period has to be mentioned. Specific period. Specific period has to be mentioned.
This is forever. They have given you 10 lakhs. From that, you can always every year. No.
This is forever. It's on the name of Professor
Okay.
Patnaik Award.
No, that's fine. No, the thing is, the House should pass a resolution thanking the family of Professor Patnaik. There should be we should pass a resolution thanking and in gratitude for the donating the 10 lakhs amount. That we should do.
Second, sir, I have one more proposal. As they give the money, I'm told that check is not taken or something. Okay. Even you can take Dr. Ranades, I think myself, Dr. B.N. Reddy, we have taken directly into our account the 10 lakhs, make a separate FD and put it separately so that we will know it is for that.
The morning what he
Yeah,
has
small,
given the check, we suggested that make it a FD, and what is...
They cannot make it FD. You have to make it
Yeah,
FD.
we can make, yeah.
That is important.
Yeah, we
because
will make it a FD.
Any signatories who are there today, tomorrow they will be somebody else. So trust members cannot come always. So it is the unit which has to make the bond. Then second, my personal suggestion and request is, can we name every time our conference hall as Dr. Patnaik's hall, hall 1. That is we should give them something, recognition for having donated so much. Can we make it, if there are some multiple halls or something like that? I propose whether we can have it every time, Dr. R. Because I don't think anybody is here who have not taken his help and knowledge. So can we make it like in the Bangalore and all, they made it forever, like what is that, Siddhappa's hall and those kind of things are. That I think you can ask the general body if they agree.
Initially, we will plan it for 3 years, and in case if you think it is correct, we can continue it further also.
Yeah, I think, can I have a word, please? That Bhumesh, small correction, that Patnaik's son, not Satyanath's son. You told Satyanath's son, right? The medal is by Satyanath in memory of his father, not Satyanath's son, right? Okay, that's okay, you don't worry about it. Second thing is, whenever they sponsor a gold medal or any other program, the donation has to be given to IADVL, make a fixed deposit in the specific purpose, that Patnaik's oration, number one. Number two, the interest, what happened? The interest is very low these days. Are you going to grant going to hand over a medal? Gold medal istara, gold plated istara, ఏమి ఇస్తారు దానికి వచ్చే బ్యాంక్ ఇంట్రెస్ట్ తోటి ద అమౌంట్ ఆఫ్ బ్యాంక్ ఇంట్రెస్ట్ యూ గెట్ నౌ డేస్ లెస్ దెన్ 6% ఫర్ 10 lakhs is 60,000, not more than that. So just nowadays once the value goes up, gold value rates go up and all these things becomes a financial matter. So I request, please think that the body, the amount, make a fixed deposit, the interest accrued should be utilized. But are you going to grant a gold medal or gold plated medal or only memento? Please think about that.
If we are giving a golden medal, we will give a cash award. In case if we are giving a gold medal, it will never exceed the interest of the fixed deposit. Nothing will be taken from the IADVL fund.
Yeah, that
This
you
is
are
certain.
very precise for that. See, whatever amount is generated as a part of interest, maybe less or more,
That's all.
should be
Within this money
utilized for the
only.
purpose of that particular
Yes.
giving in award. Maybe a cash or maybe a gold-plated one.
Yes, within
right?
that.
And more than that,
Agree.
sir, what period you are going to fix that? Because the interest changes. If you
20
keep it-
years, the 3 years life.
That's what, you make it clear, it should be as long as
20 years,
possible.
maximum
So
interest
that you will
rate
get
we can
maximum
put it.
interest out of it.
Sure.
Sir, previously also I was in other general body meetings, I was requesting you. Actually, in IMA also, family benefit scheme or our Dharmacon IADVL national body also, they have kept the funds in mutual fund. It is called hybrid mutual fund where there will be risk will be less, but we'll get more than 10% interest.
We can't risk.
There's no risk, sir.
No.
Average will be 10% average, definitely will get it, sir.
Mutual funds are subject to risk.
No, this is all discussed in the meetings. They said, our constitution says you
Sir,
cannot
we will
keep
go
it-
with the proposals, then any matter is there that will be discussed later, please. Later. And even what Dr. Putta sir said regarding the amount, what we have taken the suggestions from the Dr. Patnaik sir's son, Sachinath, he suggested that 5,000 rupees for that award and the gold coated, what we are giving gold medal, that is he suggested. If everybody accepts, so we can continue the same thing as per his suggestion. Yeah.
Yeah.
And
regarding the
and
mutual
second,
fund.
second, sir, one minute. First one is not cleared.
And is the 3 years for now we are keeping a 3 years every year CUTICON for his name. After that we can rethink.
No, like IMA, we have only Kirloskar Hall. It is always named after him. That's all for the services what he has done for the.
I am ready. I am the first fellow to support.
See, no, correct. Tomorrow many people may come, but first come should be given some, importance. Tomorrow if they come, you don't name the hall, but you give them some other thing. If tomorrow evro vastarani ee roju
No, for a fixed period you can do. For a fixed period, maybe 5 years, you can do. So that, yeah. Now one more thing regarding the putting money in the mutual
if
fund.
they want 5
the
years.
Constitution doesn't.
Constitution doesn't say.
No. Our Constitution doesn't accept.
Sir, Dayal Singh ji, please remember that all your IMA every is registered under society. अरे सुनो ना, मेरे बात करने दीजिए साहब, मुझे बात करने दीजिए आप. You allow me to talk first, right? All IMA or IADVL or any ASI or any Surgeons Conference Association is also Registered Societies Act 1892, number 1, listen to me. And as per that, subsequent amendments after the independence of India, you have to put in the nationalized banks only. All the corpus, listen to me, आप बात कर सकते हैं आप. We allow me to talk. You can't stop my throat. You have to put in the corpus fund has to be in the nationalized banks. That's all. Right. Now you can talk.
Sir, this is regarding the Dayal Singh proposal. Although our constitution says don't put in any other thing other than the nationalized banks. But you said national IADVL? Yes, I have shown the proof also. So national IADVL done it, please give a thought for it. Because not whole amount, at least 10%, so that, of course, we are not here to make money by business, but you just see it should be circulated.
That's the aim. And the central government also putting our pension funds in the mutual funds, sir. They are different. You have to first understand what are the mutual funds.
Dayal Singh.
Mutual funds.
No.
Without knowing it, if you just have that phobia,
No,
you will be at loss, sir.
No, sir, if it is there in the conference, in the constitution, how national IADVL people are doing that?
No, maybe they have a lot of money. No, they have a lot of money.
Even we have a lot of money.
No, we don't have a lot of money. We have enough.
We have in crores. What else you want?
No, excuse me, hello.
Can't
See,
put the money
I
at
want to
stake.
tell you something. Listen, let us put the donors' money into the fixed deposit and use these things. In case if we want to put our money, IADVL money, we will put in mutual funds.
No, that's
taking
what,
the
sir. We are
consent
not
of the
asking
general
donors.
body.
We are not asking donors. Donors, we have no right to ask for that. We are asking for the general TS IADVL money.
Then we'll think. First of all, the entire amount has not come into one single account. After we know what we have, we will definitely decide whether to put in mutual fund or not, taking the consent of the general body. Because we don't know what we have.
I know, sir, by heart what is the money, where it is lying. Last time I think we all calculated it.
Manmohan, I agree with you, you know it, but it is not under single head.
No, I think, sir, that you have to streamline.
And the president or the treasurer or the secretary is not the present custodian of that entire fund. We are not custodians of the entire fund till today, I am telling you. So, let it come into IADVL account in single account, then the present body at that time will be the custodians, and then the general body will decide what to do with the money, then we will do it. Isn't it?
So then you make it a rule, unless the old body
doesn't have even a single fixed deposit to manipulate. He doesn't have anything on his, in his...
he is a treasurer without any treasure, I know that. He's my colleague.
We are not
no
complaining. Listen
I know
to me.
that.
We are not complaining, but we are stating a fact.
But when we started
So,
first
if it
also there
comes
was
in-
zero.
Manmohan,
Madhubabu gave me 11,000 to start an
Manmohan,
account.
If it comes into one single account, then there will not be much confusion.
That's what I'm saying, Baba. It is already there in one account. Only two extra Ganeshwars and Netas or something,
that-
Bhumeshes,
let us
that
even
has to be
finish
put
that.
into this. The rest is all in the same account.
I agree with you. Even that also should be included in this. Then I think it will be a single account. Till it is completely amalgamated with this account, we will not take it for granted that we have a only single account.
Sir, this is the fourth year we are discussing to make it single account.
It will
I
be
made
another
it.
2 years.
I took Dr.
Unless-
Vani also,
Manmohan,
also to SBI.
Unless and until people take a stand of amalgamating all the funds into single account, this will run like this for another
This is taken
decade.
3 years back in the same hall, sir, 2 years
I
back.
agree with you. I don't deny.
Then why it is not implemented?
It is pleaded, not implemented. Pleaded, but it
Why?
is not happening.
Where is the problem?
I don't know. People are not supporting.
You as
what
a
to do.
president have a right to issue notice and find out what is there.
We have declared everything, but it is not coming in action. I don't know
No,
the
because there
reasons.
should be some problem somewhere in these 4 years.
Problem, all throughout it will be there. Unless
No, why should be there? See, when I gave very clearly the audited accounts on the day.
Manmohan, everyone is not like Manmohan.
No. Everybody should be.
Should be is a different
No,
state.
because
that
this is not
euphoric
my
state.
money or his money or his money. It's a public members'
That
money.
is the euphoric state.
They have every right to ask.
You have. Who denied?
As a member, I can ask.
Why not? But
And
I don't
what
have
is
an
happening
answer for
where-
you. Sorry, I don't have an answer for you.
No, that's what I'm saying, sir. You please make it this
I am-
time a final single account.
I have,
You take the opinion of the
Manmohan,
general body.
I have given so many requests, I cannot see.
Now you take, sir, take it, general body, maximum number of people agreeing for single account. Make it tomorrow itself, Monday. You ask.
Yeah, I am ready for single account. I am
You
for
are
single
not
account.
you, sir. You have to
May
take
I-
the general bodies.
May I put in a word, please? From the day we took over, I've been asking...
No, I am not able to, let us be clear. Either you
mask.
speak with a little mask out because we are
Yeah,
not
okay. Is that audible now?
Yeah.
Okay. So I've been asking, see, we wanted to close the accounts last year when the other team said they had closed the accounts. Nothing was given to us in terms of what's happening. The account was supposed to be closed. After that, we were operating the account and our expenses, we have everything. Now, when they gave the income tax, as you all know, it was not submitted. Accounts, chartered accountants, audited accounts weren't submitted in the last general body meeting. And during installation, they then said they paid 18 lakhs and then gave the FD check for 18 lakhs to put in our account. As in the confusing bit with IADVL is the association year is different from the financial year. So everything becomes a little confusing. At the end of that time, then they gave, when we asked, because we have to pay GST, no GST was paid throughout that year. They kept filing 0 GSTs, and when we had to pay, we couldn't go back and pay. That was so much effort. I had to do so much work to gather information and then pay GST through a different portal. We managed that. Now, when it's coming to income tax, our auditor says there are 4 accounts under one PAN number.
And we need all the details. They cannot give only on my account. They can't file returns. I've been asking for 3 months now. Not a statement has come from the previous account. Their account is still there, right? They didn't close the account. No. So if they give the statements and then they had submitted, I can been putting in the group, they have said 30 lakhs of GST returns are payable. And then some more payables. There are no details of why they are payables.
Shall I, madam, on this thing I'll talk. Basically, we are not employing a CA who is regular doing for our session. That
yes, I agree.
We have to employ a CA who permanently works for us. But where is CA? And her CA says, not necessary. Bhumesh CA says GST is not there.
No, my CA didn't say not necessary. They are very particular that they need all the information. They are not going to file without that.
See, when I did first one, I proposed GST, I have paid, IT I have paid and given the things.
Yes, but Dr. Bhumesh apparently, no, this is what I have to say.
So Bhumesh, you have to take it.
He has
but
said
as
that
of now, income tax rules say that any conference sponsored in India attracts GST. Outside India, it won't. This is the latest from income tax I am telling you. So why break our heads? There are CS who can work for us for 5,000, 10,000 rupees yearly.
We are paying the CA. It's not like they're doing free service.
So
but we should
let them take
for
care of all
continuity,
this.
we should have one CA. I propose that we have the chartered accountant, Dr. Manmohan and Dr. Sai Krishna here, because they know the issues. They have been doing a good job. And I think we should appoint them so that this issue is not there. And maybe, I'm hoping, they will also sort out this mess which these people have made, not allowing me to correct it at all. I've wasted so much of my time and effort.
No, it's okay, madam, whatever has happened.
No, we cannot say that. Every time what they say, whenever I say that, whatever happens. So I am not able to see if I can't pay IT. My account.
No, you are told your thing.
My accountant says you cannot close the account and transfer if you are not cleared the accounts. So how will I do that?
That's what we make it very compulsory to produce submit the audited accounts of the TS-IADVL as well of the conference. Conference they can take maybe December, January, but TS-IADVL they can be done immediately on this general body.
Yeah, let me talk. Yeah, regarding, we have two things. One is IT, income tax dues, another one is the GST dues. And regarding income tax dues, it was discussed in the Manas Sarovar general body meeting. There was a due of 10 lakhs. So it was decided unanimously that whatever the due it is there, that has to be paid from on behalf of IADVL. That is clear. So, but somebody said, why can't we try for any exemption? Then we went to IT office almost number of times. So we got almost 2 lakhs exemption for that, but showing this our awareness activities, health camps in our IADVL office. This is for the social awareness activities. And remaining 8 lakhs which is there in the IT office, they have to respond. So unless until they respond, before that, but there is no need to hurry to pay. Once we may get exemption. What CS says more than 99% because we got 2 lakhs exemption. Another 8 lakhs also we are going to get. But if they say you have to pay, then whatever it is there, it has decided previously that we can pay. And regarding the GST part, even the audited account was paid by the Your Time and Venkatakrishna Sam and Rajesh Singh. All they have paid and FD was made. So let us say this time, whatever the people, those who have done for the association, once if they paid and FD made, let us not pork unnecessarily. Whatever they have done their level best. So why we should continuously disturbing the people? Working for the associations, they have done their level best. So some people may have done this much.
No,
please, madam, when I am speaking, I didn't ask you. Please let me speak.
Okay.
Once if I finish, you can speak.
Sure.
Otherwise, if you want me not to
speak, I'm sorry for interrupting. You can go on. What happened?
That's what I am saying. I am trying to, whatever has happened, forget about it.
No, what I am saying is, 18 lakhs paid income tax, you close it and then audited account, if it doesn't show how they paid that amount, where they paid from, And then there is something called charitable trust. They said we are a charitable trust and they got some exemption on income tax. So there should be clarity.
No, regarding 2019, even Neta can tell, in the installation ceremony, he has given the audited account, not in the AGBM. He told that this is a tentative account. And in the AGBM,
at no point account is submitted.
Please, madam.
మీరు నవదం చెప్తుంటే ఎట్లా ఊరుకోవాలండి? అకౌంట్ ఎక్కడ సబ్మిట్ చేశారండి? Anybody has seen?
Neta garu మీరు మాట్లాడండి. Neta sir, as a president you can speak.
Have you submitted the accounts, Dr. Neta? Where? No accounts were submitted.
Account, only thing is 8 lakhs we are trying for the waiving off from the IT department.
During that time, what we as a secretary,
we submitted. We never later చేయనే చేయలేదు మీరు ఎక్కడ కూడాను.
As a secretary, I asked for all the audited account. Venkata Krishna has sent, you have sent, and previously the Rajiv Singh and Neta have sent. They have done their level best and they made it.
Why are you not sending me the account?
What is your problem, madam? I couldn't understand till now. మేము చేసి అంతా చేసినాము, డిపాజిట్ చేసినాము, ఎగ్జామ్షన్ కోసం ట్రై చేస్తున్నాము. 2 lakhs వచ్చింది, ఇంకా 8 lakhs కూడా వచ్చే అవకాశం ఉంది.
Even the balance sheet already they have submitted. With that showing that balance sheet, the remaining next year body they can do the auditing.
See,
we have the AGBM video.
కొంచెం కూల్ ఆలోచించండి. See, when somebody is talking, we got to understand. In the same hall, we had a general body meeting when I was the president. Yourself and Bhumesh, you said you have purchased that thing. అది వచ్చింది ఇంత ఇచ్చింది మేము జేబులోకి వెళ్ళేసాం. That is not the audited accounts. After that, that's what I am saying. There is no audited account for that conference. And then
this was last AGBM.
No, Neta, I think probably no, because that time it is orally told, and they said okay, buying part is okay, we agree. But what happened to the income generation and then expenditure? Conference chesindi meeru
18 lakhs, sir. 18 during 2019, what they have submitted to the we asked for all the audited account. Even the Venkata Krishna he has submitted, and your people and Rajiv Singh Neta also they submitted, and with the FD.
Even Dr. Ganeshwar has also submitted.
Yeah, they are the A.G. Rao and Sai Krishna also they submitted, and they made some FD, and Rajiv Singh and Neta also they made FD, and Venkata Krishna also made FD.
Question is not of the FD.
After auditing, after audited account, they made FD and handed over in the installation ceremony. And
the audited accounts are
then
not available.
The balance sheet of 2019 body already they have sent to the 20 body.
They have not given audited accounts, please. We can see
Without,
the video. We can see the video of the conference.
Let me clear.
Let me
Sir, let me clear. Without
finish,
audited account, 18 lakhs FD ఎట్లా చేస్తారండి?
మీరు సబ్మిట్ చేయలేదండి.
18 lakhs
ఇప్పుడు who knows you got 50 lakhs or only 20 lakhs or only 1 lakh, we don't know.
అది కాదు సార్.
18
ఆడిటర్ కి ఇచ్చి ఆడిట్ చేసిన తర్వాత ఇంత అమౌంట్ మిగిలితే 18 lakhs FD చేసి ఇచ్చిన తర్వాత ఆడిట్ చేయకుండా 18 lakhs ఎట్లా చేస్తారండి?
మనం కూడా చేసుకోవచ్చు లెక్క.
ఆడిటర్ సంతకం చేసి ఆడిట్ సబ్మిట్ చేసి ఉన్న తర్వాత లేదు అంటే ఎట్లా?
మీరు అట్లా
ఇన్స్టలేషన్ సెరమనీ that Neta submitted
generated in the stalls, how much is the expenditure, what is the residual,
that balance sheet was given, sir. Manmohan sir
నేను ఆడిట్ సైన్ చేసిన పత్రమే నేను హ్యాండ్ ఓవర్ చేసిన, డిపాజిట్ చేసిన అమౌంట్ కూడా
బ్యాలెన్స్ షీట్
పేపర్స్ కూడా ఇచ్చేసిన, హ్యాండ్ ఓవర్ చేసిన స్టేజ్ మీదనే. మళ్ళీ
okay, you do one thing. When I gave it to Dr. Neta, నేను మీకు హ్యాండ్ ఓవర్ చేసినప్పుడు have I not given you bonds, fixed deposit bonds? Please, I have given you, I also gave you 2 lakhs rupees as a seed money for your new this thing. మరి అట్లనే why don't you follow? అదే మీరు ఒకటి, ఎవ్రీబడి క్యాన్ డూ ద సేమ్ వే. అందరు అట్లే చేస్తే బాగుంటుంది కదా. మేడం, యూ గాట్ ద ఆడిటెడ్ అకౌంట్?
ముందున్న వాళ్ళు కంబైన్డ్ ఆంధ్రప్రదేశ్ ఉన్నప్పుడు ఇప్పటికి కూడా సబ్మిట్ చేయని వాళ్ళు ఉన్నారు, వాళ్ళ గురించి మాట్లాడలేరు.
లేదు, అప్పుడు అంత వేరు. ఇప్పుడు మన కాదు, ఇప్పుడు ఎవరు
సార్? మన్మోహన్ సార్. This is the balance sheet of just now. Even I asked for the CA. Neta, it was submitted the balance sheet of the 2019 after auditing, and the FD was made. The balance sheet, once if it is there, with the showing the balance sheet, next body they can send for the auditing.
No, ఒకటి మీరు వినండి, నేను ఎప్పుడైతే ప్రెజెంట్ చేశాను గ్రాండ్ కాకతీయలో వినండి, you let me talk. Your treasurer Neta was there, Venkatam was president. He said, I will circulate this audited account. I said, circulate what? Putta Srinivas said, you send it by email to every member. We have a right to know.
This all audited account. Audited account అందరికి ఇంతకుముందు అందరి పంపించేసినాం, అందులో గ్రూప్లో అన్ని గ్రూప్లలో పెట్టాము. Even 17, 18, 16 all audited accounts were sent in the group.
Neta garu okka nisham, please. For the information, I am the last president of the AP IADVL combined 2013 November. After that, Madhubabu was secretary, Padmaja was treasurer. We have handed over including fixed deposit to IC Reddy and his team in Kurnool 2014 November. We have all the acknowledgements also. Unte chustanu ippude istanu meeku nenu. So don't bring 2015-14 now into picture. You talk of TSIADVL. Why you bring AP and all that now? That is already concluded, well concluded. Neta garu, please. Okay, చెప్తాను మీకు ఇంకోటి. ఒక్క నిమిషం, I'm not content. ఒక్క నిమిషం వినండి ప్లీజ్. మీరు ఎవరి నుంచి మాట్లాడుతున్న నాకు సంబంధం లేదు. ఒక్క నిమిషం ప్లీజ్. జనరల్గా మాట్లాడేటప్పుడు జనరల్గా మీ స్టేట్మెంట్ ఇవ్వడం వల్ల ఏమవుతుందంటే అందరూ హర్ట్ అవుతారు, అలా చేయకండి. ఒక్క నిమిషం, ఐ టెల్ యూ ప్లీజ్. మధు, కొంచెం బ్యాగ్ తీసుకో. ఒక్క నిమిషం, ఒకటే నిమిషం. సి
Sir, before Telangana, what you said previous last year also you said, sir, Putta sir.
మీరు అన్న కాబట్టి చెప్తున్నాను, లేవో చెప్తున్నాను. థ్యాంక్ యూ
సార్. పుట్టా సార్ 1 minute.
ఇప్పుడు ఎలిగేషన్ ఏంటంటే లాస్ట్ ఇయర్ రిజల్ట్స్ ఆడిటెడ్ రిజల్ట్స్ మేడంకు సబ్మిట్ చేయలేదు అని అంటుంది మేడం. అదొకటే, ప్రీవియస్ ఇయర్స్ కాదు కదా మేడం, అంతే కదా?
నేను అన్నాను, they were not submitted during the AGBM. Even afterwards, they only gave us an FD. Accounts were not submitted. When we wanted to give GST and all, when I asked, his CS sent us some documents. Lot of inaccuracies అవి ఉంటే మా వాళ్ళు క్లారిఫికేషన్ అడిగారు. తెలియాలి కదా మరి, ఎన్నో ఉన్నాయి పేయబుల్స్ అని. 30 lakhs GST పేయబుల్ ఉంది, 20 lakhs సంథింగ్ ఆఫ్ సమ్ అదర్ పేయబుల్. సో దే వాంటెడ్ టు నో పేయబుల్స్ ఎందుకు, దేని మీద పే చేస్తున్నామంటే జవాబు లేదు. ఎన్ని ఈమెయిల్, ఎన్ని వాట్సాప్ మెసేజెస్, ఎన్ని కాన్వర్సేషన్స్.
That GST part we will discuss later because 30 lakhs now only 30 lakhs GST means itla worth of 2 crores transaction ఉండాలి. సో దట్ ఈస్ మేబీ అమాల్గమేషన్ ఆఫ్ వాట్ ఎక్కడ డిఫెక్ట్ ఉందో తెలియదు. ఈవెన్ మొన్న సీఏని అడిగితే కూడా ఇంత అట్లా మీకు అసలు 5 సంవత్సరాల వితిన్ 5 years 30 lakhs చేసి ఎట్లా వస్తుంది సార్, ఎక్కడో డిఫెక్ట్ ఉంది, దాన్ని వెరిఫికేషన్ చేద్దామని చెప్పాడు. ఒకటి మేడం ప్లీజ్, ఒకటి ఏంటంటే ఇప్పుడు 2019 they have done audited and balance sheet was submitted. How balance sheet will submit without audited account? How the balance sheet is going to submitted? ఎట్లా సబ్మిట్ చేస్తారండి?
కాదు మేడం, 1 year 30 lakhs ఎట్లా వస్తుంది? GST టోటల్ అమౌంట్ 30 lakhs ఉంటుంది మనకు.
ఎన్నిసార్లు అకౌంట్స్ పెట్టానండి ఎగ్జిక్యూటివ్ బాడీలో డిస్కషన్ కొరకు. సో దే వర్ ఆస్కింగ్ ఎక్కడ నుంచి 30 lakhs పేయబుల్ ఉంటుంది అని అడుగుతుంటే జవాబు లేదు. పేయబుల్స్ అని ఇంత పెద్ద.
We request all non-members, those who are pharma group non-members, please go out.
ఆ 30 lakhs తర్వాత సాయికృష్ణ గారి ధర్మజోన్ వాళ్ళు 15 lakhs అని చెప్పి క్లారిఫికేషన్ మేమే ఇచ్చాము. తర్వాత మేము ఓన్లీ డిలేడ్ జిఎస్టీ పేమెంట్స్ కి 1.4 lakhs కి 20,000 we have to pay extra because there was delay because of non return.
మేడం మీరు ఇంతవరకు మీరు సబ్మిట్ చేయండి, మాది మీ జిఎస్టీ విషయంలో క్లారిఫై చేసిన తర్వాత మీరు సబ్మిట్
చూడండి. మాకంత క్లారిఫికేషన్
చేయండి ఫస్ట్. మీరు ఉన్న మీ అకౌంట్ మీరు సబ్మిట్ చేయండి ఫస్ట్.
మా ఆడిటర్ తో అవ్వదు అన్లెస్ యు గివ్ us details.
మీరు ఎప్పటితో మీకు కాదు, మీరు మీతో పని చేత కాదు, ఇది సబ్మిట్ చేత కాదు.
మర్యాద లేదా అండి మీకు? మాట్లాడే పద్ధతి లేదా?
మీకు మర్యాద లేదు, మీకు మర్యాద లేదు.
మీకు చేత కాదన్నాక ఎవరు మీరు?
మీరెవరు మాట్లాడుతున్నారు?
ఏం మాట్లాడుతున్నారు?
సబ్మిట్ చేసిన తర్వాత సబ్మిట్ చేయాలంటారు.
నేను అన్నాను ఎందుకు ఊరుకోవాలండి?
స్టేజ్ మీద సబ్మిట్ చేసినామని ఎందుకు మాట్లాడుతున్నారు?
స్టేజ్ మీద సబ్మిట్ ఎప్పుడు చేశారు?
మీరు ఉంటే కదా 5 నిమిషాలు కూడా స్టేజ్ మీద లేకుండా వెళ్ళి పారిపోతున్నాం.
ఎందుకు ఉన్నాను?
జనరల్ బాడీ మీటింగ్ మీ సంగతి కదా అందరికీ తెలుసు, ఇక్కడ ఉన్న వాళ్ళందరికీ ఊంటే లేచిపోయి స్టేజ్ నుంచి లేచిపోవడం, హ్యాండ్ ఓవర్ చేసినప్పుడు టేక్ ఓవర్ చేసినప్పుడు కూడా 5 నిమిషాలు లేవు మాట్లాడుతున్నారండి. సబ్మిట్ చేయండి, 1 year అయిపోయింది, సబ్మిట్ చేయండి. మీరు
పర్సనాలిటీస్ గురించి మాట్లాడకండి.
పర్సనల్ ఏం లేదు, నాకు ఎవరు
పర్సనల్ గానే మాట్లాడుతున్నారు.
పర్సనల్ ఎవరు లేదు,
పర్సనల్ గానే మాట్లాడుతున్నారు.
Hello, please cool down. People who do not belong to TS IADVL, please empty the room. And another thing now,
I request all the members.
Hello, Manmohan, 1 minute. We cannot raise voices and we are not fighting. We are all members of a dignified society and an elite group. Please pay respect to each and every individual, and we are all for TS IADVL, not for any personal benefit. So please give respect, take respect, and don't be abusive and don't raise your voice.
Sir, ఒక్క నిమిషం.
Thank you, Dr. Murthy.
Madam,
please.
ఇది ఇండియన్ అసోసియేషన్ ఫర్ ద స్టడీ ఆఫ్ సెక్సువల్లీ ట్రాన్స్మిటెడ్ డిసీజ్ అండ్ ఎయిడ్స్ ఇస్ a balance sheet. It's not our IADVL balance. This is not the thing. It's wrong. This ఏదో ఎవరిదో అసోసియేషన్ పెట్టుకొని మీరు ఇది చూడండి, రౌండ్ ఇచ్చింది. ఇది చూడు, టేక్ దిస్. చూడండి సార్, చూడండి వెంకటరమణది, అది ఐఏఎస్ ఇండియన్ ఎస్టీడీ, అది మన సంబంధం లేదు. ఇది అది వదిలిపెట్టండి. ఇది ఇట్స్ నాట్ రిలేటెడ్ టు ఐఏడిఎల్. అది ఎక్కడ అకౌంట్ తీసుకొచ్చి పెడుతున్నారండి. చూడండి, అది ఓకే, అది చూడండి ఒకసారి.
ఇది కాదు సార్, ఇది వీళ్ళు పంపించండి,
అరుణ ఇచ్చింది,
ఇట్లా సబ్మిట్ చేయాలని
అది
డాక్టర్
మన సంబంధం లేదు.
ఇది కాదు, అది
రైట్. ఇది చూద్దాం. ఐఎంఎస్ ఐఏడిఎల్ తెలంగాణ స్టేట్ 38 లక్షలు 38 lakhs టోటల్. పర్టికులర్ రిసిప్ట్స్ అండ్ పేమెంట్స్ అకౌంట్ ఫర్ ద ఇయర్ ఎండ్ 31 March 21.
ఇది మా అకౌంట్స్ ఇప్పుడు. అంటే వీఆర్ నాట్ ఏబుల్ టు డూ ఆడిటెడ్ అకౌంట్స్. దే హ్యావ్ గివెన్ ఓన్లీ హెడింగ్ ఉంచండి, పేయబుల్స్ అండ్ ఇది. సో హౌ మచ్ అమౌంట్ వి గాట్ అండ్ హౌ మచ్ వి పేడ్ అవుట్ అండ్ బ్యాలెన్స్ షీట్. అది బేసికలీ బ్యాలెన్స్ షీట్.
మీకు అమౌంట్ ఏముంది మేడం? మీరు కాన్ఫరెన్స్ చేయలేదు, మీకు ఏమేమంట్ ఉంది? అమౌంట్ ఏం లేదు కదా, ఖర్చులు లేదు, ఇన్కమ్ లేదు కదా. అంతకుముందు అమౌంట్ ఎక్కడుందో చూడాలి నాకు.
ఎందుకండి 9 lakhs ఏవో ఉన్నాయి, ఏమి లేదంటే మరి అట్లా తీసుకోవడం.
No, let us sort it out for today once for all. We are going to do this.
So I have one query on audited accounts. Please చెప్పండి ఎట్లా చేయాలో. We have one auditor, we have to do it.
So that we are going to fix. One auditor, we have an office also. There he will sit, do our work. Everything has to be maintained in a file. What I have given, what Venkat Krishna given before me, Venkatramana given, is nowhere. You have any copies of that?
Yeah, Manmohan sir, the single audit account కూడా పాయింట్ ఉంది. ఆల్మోస్ట్ 15 నుంచి 18, 19 ఇప్పుడు కూడా 3 సంవత్సరాల నుంచి అతను చేస్తున్నాడు. సో let us endorse the person to do because he has well versed that person.
ఒక నిమిషం చెప్తా Umesh, don't think otherwise and mind otherwise. Your man said income tax, you are not. Same man told you.
No, income
when
tax.
When I said it is.
No, that is not auditor. IAP people, IAP what they said, Indian Academy Pediatric, the member, the friends what they said, our mana association GST వర్తించని వాళ్ళు చెప్పారు, ఆడిటర్ చెప్పలే.
ఆడిటర్ మీకు ఇన్కమ్ ట్యాక్స్ కూడా వద్దని చెప్పాడు.
ఇన్కమ్ ఎగ్జామ్షన్ కొరకు ట్రై చేస్తున్నాం.
That's what you told me on phone when I told
10
you.
lakhs లో 2 lakhs ఎగ్జామ్షన్ వచ్చింది, ఇంకొక 8 lakhs కూడా ఎగ్జామ్షన్
తర్వాత you taken over, you got a reminder from income tax to pay the dues or something like that.
Dues now 2 lakhs exemption we got it.
Dues అడిగినప్పుడు నేను చెప్పాను we have to pay that. Whoever is the
8 lakhs, it is under IT sir. If we may get exemption, we may get. If we won't get,
no IT dues exemption
వస్తాయి
for retrospective activities.
ఇప్పుడు రాకపోతే మనం ఎలా కట్టాలని it was decided in the Manasarovar. It already it was decided. మనం కొన్ని రోజులు ఒకవేళ వచ్చింది అనుకో మనకి 8 lakhs.
నేను మీకు ఇంకో హింట్ కూడా ఇచ్చిన. మా ఆడిటరు వాడు ఈఎన్టీ వాళ్ళకి తెచ్చినాడు ఎగ్జామ్షన్.
వాట్ ఈస్
లిటిల్ మనీ.
దెన్ వాట్ ఈస్ ద హరీ టు పే సర్ 8 lakhs? ఇప్పుడు ఆల్రెడీ 2 లక్షలు
వచ్చింది కదా. ద లాస్ట్ మీటింగ్
2 లక్షలు మనకి ఎగ్జామ్షన్ వచ్చింది కదా, ఇంకొక 8 lakhs అది ఇప్పుడు లెట్ ద ఐటీ రెస్పాండ్. Let the IT respond by the
whatever auditor you appoint him regularly. మనం ఆయన రమ్మను మీటింగ్ రావచ్చు, ఆడిటర్స్ కెన్ కమ్.
పిలిపిద్దాం సార్, పిలిపిద్దాం. సేమ్
every general body meeting the auditor should be invited and in
లాస్ట్ టైం ఇన్వైట్ చేస్తే పుట్టా సార్ అన్నాడు దిస్ ఇస్ IADVL మీటింగ్ ప్లీజ్ గో అవుట్ గెట్ అవుట్ అని అంటే వెళ్ళిపోయాడు అన్నాడు సార్. ఆడిటర్ అప్పుడు పిలిపిస్తే మీరు
Auditor can come and sit in the general body meeting.
యాక్చువల్ ఆయన వచ్చి ఎక్స్ప్లెయిన్ చేస్తా అన్నాడు. ఎక్స్ప్లెయిన్ చేస్తా అంటే నో ఇట్ ఈస్ IADVL మీటింగ్, ద ఆడిటర్ ఈస్ నాట్ అలౌడ్ అని ఇమిడియట్ గా పంపించేసి.
Because we doctors are not well versed, we cannot answer all those things and we don't remember also the accounts. Always better to take the help of the auditor, and every general body meeting before unaudited should be actually presented by the treasurer. I don't know today how you are going to.
Sir, ఒకటి my humble sincere request, whatever the people previous since 2015 whatever they have done their level best, and what the auditing they have done, and whatever the FD is made and it was fixed in the on the name of IADVL Telangana State till 2019. So let us not pour that. And after auditing 2019 body, audited balance sheet was submitted and it was given to the 20 body, and the 18 lakhs of FD was made. So with the showing that balance sheet, we can do auditing for 20 and followed by subsequently 21. And only two things has discussed. One is the IT penalty. So that 2 lakhs got exempted, and another 8 lakhs which is there. Almost I have gone 100 of times to the IT office. What they are saying, it is that also I will see. It is under the review. That also I will show. The IT, it is under the. They are not. Once if it is responded, if you pay, then we can pay. If they get exempted, we may get exempted. Let them respond. That is one. Okay, sir. That is IT. And GST part, whatever it is there, any exemption next time also, if you get any exemption, let it be. Otherwise, that will be paid by the IADVL, whatever it may be. Let us not pour, you have done this, you have done that. Whatever they have done, they were level based. Let us not disturb the previous body, please.
No, we are not encouraging, discouraging or anything, but we are telling, instead of keeping it postponing, the interest attracts, it goes from 2 lakhs to 10 lakhs now, it may increase also. Unnecessary, we have to pay the penalty. Income tax and
GST 38 lakhs ante okati sir, 38 lakhs ante the transaction మనకి ఎంత జరగాలి సార్? ఆల్మోస్ట్ మోర్ దాన్ 2 crores జరగాలి. ఏ క్యూటికాన్ కాన్ఫరెన్స్ కు ఒక 50 లక్షలు దాటింది సార్. అంటే ఎక్కడికి వెళ్ళి వచ్చి నేను IT ఆఫీస్కి వెళ్ళాను, ఇంత మాకు ఎక్కడికి వెళ్ళి వచ్చిందండి. దిస్ ఈజ్ నాట్ ఏ బిజినెస్ ఓరియంటెడ్, దిస్ ఈజ్ అ కాన్ఫరెన్స్ ఓన్లీ వన్స్ ఇన్ ఎ ఇయర్ విల్ డూ. 38 లక్షలు అంటే ఆ జిఎస్టీకి మనకు ఒక 2 కోట్ల పైన ట్రాన్సాక్షన్ జరగాలి సార్. అది ఎక్కడ డిఫెక్ట్ అవుతుందని అది డిటెక్ట్ చేసుకోవాలి మనం.
అది మనం అడుక్కుంటే క్వశ్చన్ ఆన్సర్ రాదు.
అది డిటెక్ట్ చేయకుండా
ఒకటి
సార్. ఇప్పుడు సో ఈవెన్ దిస్ ఆల్సో ఐ విల్ సార్ మన్మోహన్ సార్, సో this also I will take the responsibility.
Let us not waste. Malli it will become the same general body where we all go home.
This GST part also.
Let us as the seniors.
Otherwise, if it is not there, we will pay. If we won't get exemption, obviously we have to pay on behalf of association.
10 lakhs, 15 lakhs bond saving bonds, you give it off. What is there? It's all the government.
ఇద్దాం సార్, నేను అనట్లేదు. ఇద్దాం. ఇప్పుడు ఒక 2 లక్షల ఎగ్జెంప్షన్ వచ్చింది, ఇంకొక 8 లక్షల. Let them respond. If they respond, we may get వచ్చేస్తుంది కదా. ఇప్పుడు where is the hurry to pay?
May I say something, please?
Where is the hurry to pay 8 lakhs?
Already I have just pointed out that 1.4 lakhs మీద 20,000 penalty pay చేయాల్సి వచ్చింది, excess because of late payment of GST. ఐటీ కూడా అట్లాగే ఉంటుంది. మీరు 10 lakhs ఎప్పుడో డ్యూస్ ఉంటే దానిపైన ఇంట్రెస్ట్ అడగరా వాళ్ళు?
అది ఎగ్జామ్షన్ వచ్చేస్తే మొత్తం వచ్చేస్తుంది మేడం. అది ఇప్పుడు 2 లక్షలు వచ్చింది కదా.
పే చేసాక ట్రై చేయండి ఎగ్జామ్షన్.
ఒకటి సార్, ఇప్పుడు నేను
జిఎస్టీ అంటే
whatever the saving I am thinking. ఒకటే నిమిషం
we are not aware of all the rules properly. A proper qualified man CA will tell us what to do. Take the opinion. My inviting, don't go back and then keep fighting for that. All the president secretaries of the last 4 years we will meet. Okay, we'll call the CA.
In the office only, in the Nagol office we'll sit, all should come in the
wherever
office,
we'll sit. And
we'll
all these
discuss,
president secretaries, whatever they have given, they will tell. On the open it will be there.
Okay, so if you want
to,
give it to already Manasarovar la it was decided backlogs unte pay mana behalf of IADVL కలదాం అనుకున్నాం. Only we are trying for exemption. అది వదిలేద్దాము అంటే వదిలేసేసి
ఇప్పుడు వదిలేయండి. First let it be clarified. What are all the things are there to be paid.
ఇంకొకటి సార్, 38 లక్షలు జిఎస్టీ అనేది ఎక్కడి నుంచి డిఫెక్ట్ వచ్చిందని సెర్చ్ చేయాలి సార్. అది మన 2 కోట్ల అసలు తెలంగాణ వచ్చిన తర్వాత 2 కోట్ల ట్రాన్సాక్షన్.
Please give me 2 minutes. See, GST will go from the income tax office wherever the income is more than 20 lakhs, it goes automatically from the GST office. That's the rule, right? And this has come into effect from 2017 onwards. Any transaction in a PAN card more than 20 lakhs in a financial year will go automatically GST notice. Please note this. Second thing, my suggestion is, call from 2015 to 21, all presidents, secretaries, treasurers, 1 week time, fix all the agenda in a closed chamber, discuss for 3-4 days and close the matter once for all. That's my suggestion, Baba. Otherwise, it go every occasion, please, let me complete, Mohanlal. Every time, this is becoming a debating fact, like, as if we are fighting among ourselves. That's unhealthy things. I request DBN Murthy, please, you invite specific dates, all the last 6 years, president, secretary with come their accounts, bank accounts, everything, let them with all the details, appoint a CA, and you can do that. Staffing movement is one thing. You told that I mean asked to go out. No, but let me clarify that. See, you can invite an auditor or expert or engineer, you are constructing a building, you can invite him as a cooperative member to brief the members. But they can't be part of discussion. That's what I told. Okay, thank you.
సార్ ఇప్పుడు మీ మీటింగ్ అంటే ఆల్మోస్ట్ 19 వరకు అంతా క్లియర్ అయిపోయింది, ఆడిటింగ్ అయిపోయింది. ఓన్లీ రెండే విషయాలు, ఒకటి ఐటీ పెనాల్టీ ఉంది, 2 జిఎస్టీ పెనాల్టీ ఉంది. ఐటీ పెనాల్టీ ఆల్రెడీ మానస సరోవర్లా ఒకవేళ ఎగ్జామ్షన్ కాకపోతే కట్టేద్దామని ఏజీఎంఎల్ వచ్చేసేసింది. ఇప్పుడు జిఎస్టీ 38 lakhs అని ఉన్నది, అది ఎక్కడి నుంచి వచ్చింది సెర్చ్ చేసుకోవాలా. ఒకవేళ అది కూడా ఏమైనా తెలియకపోతే అది కూడా ఆయన బిఎఫ్ ఐఏడిఎల్ కట్టేసేయాలి. రెండే ఇష్యూస్, ఇంకా ఇష్యూసే లేవు. దాని గురించి అసలు అనవసరంగా దాని గురించి మళ్ళీ నానబెట్టుడు, దాన్ని ప్రొలాంగ్ చేసుడు అనేది మళ్ళీ సేమ్ అదే జరుగుతుంటుంది.
So regarding GST, what you are telling, if there is a controversy or there is, you think it is arbitrary, we can file a case in the tribunal, then the facts will come out. That is one. And regarding Dr. Sino sir's comment that it should be closed door meeting, even after closed door meeting also, the facts should come to the members, it should be transparent.
నో ఇప్పుడు జిఎస్టీ ఎంత వచ్చింది, ఎక్కడ వచ్చింది కాదు, ఇప్పుడు వచ్చింది ఏమైనా ఎక్కడికి వెళ్ళి వచ్చింది కనుక్కుంటాము. వాళ్ళు కనుక్కోపోతే కట్టాల్సి వస్తే తెలంగాణ ఐఏడీవీఎల్ తెలంగాణ తర్వాత కట్టేస్తాం, అంతే కదా.
జేబులోకి వెళ్ళి కట్టేది కాదు.
రెండే విషయాలు. ఇప్పుడు ఒకటి ఐటీ ఆల్రెడీ సార్, రెండే ఐటీ మానస సరోవర్లో 10 లక్షలు డ్యూ ఉంటే ఎగ్జామ్షన్ ట్రై చేద్దాము, లేకపోతే కట్టేద్దాం అన్న అయిపోయింది. ఇప్పుడు ఇక్కడ కూడా జిఎస్టీ ఇంత పెనాల్టీ ఉంది, ఒకవేళ ఎగ్జామ్షన్ ట్రై చేస్తే చేయాలి, లేకపోతే ఆన్ బిహాఫ్ ఆఫ్ ఐఏడీఎల్ కట్టేయాలి. రెండే విషయాలు కదా సరిగా.
See, let me tell you, 2006 onwards we have a Dharma Foundation. We have the best CA in the city who does this auditing. They said you cannot get exemption. Chief Income Tax Commissioner is known to me. Somebody is getting from back doors, you can take it. That also I am telling you. You tell some CAs will go and get it for you. So you decide among yourself, leave alone that part. If now coming secretary Mohanlal will do a marvelous job of paying the income tax and other things. So మీరు ఫైనల్గా ఏ డబ్బు ఎక్కడ ఉందో అన్నీ తీసుకొని రండి, వచ్చేసి ఒక దగ్గర పెట్టి.
ఇప్పుడు ఏముంది, ఐటీ 8 lakhs, 80 lakhs డ్యూ ఉంది. ఐటీ 2 లక్షలు ఎగ్జామ్షన్ మొంగ 2 లక్షలు, ఇంకా 8 లక్షలు ఆల్రెడీ ఇట్ ఈస్ డ్యూ ఉంది. అది అండర్ ద ఐటీ రెస్పాన్స్ కావాలి.
South Zone was done here. Where is it saved amount? ఏ బ్యాంక్ లో ఉంది? No, I know. అట్లా మనం పెట్టుకొని కూర్చుంటే కాదు అది.
మరి ఇప్పుడు అది 8 లక్షలు జిఎస్టీ కట్టేస్తే అయిపోతుంది.
I have seen that. You have done a wonderful job of getting an altered account. But only thing is, it should be handed over to the present body. Otherwise, what is the use?
Already handed over.
To whom did you hand over? తీసుకున్నారా మేడం మీరు? So that has come. So in your account, did you include our TS IADVL accounts?
No, we have not included.
You have to know, because you are elected as a president. You are supposed to give conference accounts and TS IADVL accounts separately. Did you give them the fixed deposits of 70 lakhs? Did you get that? You have taken that. What is your problem, madam?
సార్ మన్మోహన్ సార్ ఎఫ్డీస్ అందరు ఫిక్స్ అయి ఉన్నాయి, ప్రతిసారి ట్రాన్స్ఫర్ అవుతున్నాయి, అది ప్రాబ్లం లేదు. అన్ని ఎఫ్డీ ఇక్కడ నుంచి ఇక్కడ ఓపెన్ ఉంది. ఇప్పుడు నెక్స్ట్ వెళ్ళిపోతుంది, అది ఎఫ్డీస్ ప్రాబ్లం లేదు. ఇప్పుడు ఓన్లీ రెండే విషయాలు, 19 వరకు అందరు ఆడిట్ చేసిండ్రు, ఎఫ్డీ చేసిండ్రు, అయిపోయింది. ఇప్పుడు రెండే విషయాలు, ఒకటి 8 lakhs డ్యూ ఐటీ ఉంది, జిఎస్టీ ఉంది, దాన్ని కట్టేద్దామంటే కట్టేద్దాము, అయిపోయాయి, లొల్లే పోయింది, ఇంకా ఇష్యూ ఏముందా?
భూమేష్
పే చేసేద్దాం, అయిపోయాయి, పే చేసేద్దాం. కాదు సార్, ఇప్పుడు అందరు పే చేసిండ్రు, పే చేయంగా ఇంత డ్యూ ఉంది, ఆ డ్యూ ఎవరైనా కానీ FD చేసి ఇచ్చేసిండ్రు, మిగతా డ్యూ వచ్చింది, అది ఏడికేళ్ళు వచ్చిందని వెరిఫై చేసే చేద్దాము, లేదు అంటే ఆన్ బిహాఫ్ ఆఫ్ ఐడీలు కట్టేద్దాము. రెండే విషయాలు ఏముందా
భూమేష్? అది కాదు, 2019 కదా మీది ఆడిటెడ్ రిజల్ట్స్ ఇచ్చారా మేడం?
ఇగో బ్యాలెన్స్ షీట్ ఆల్రెడీ బ్యాలెన్స్ షీట్ హ్యాండెడ్ ఓవర్ టు వాణి మేడం అండ్ ద CA ఆల్సో. బ్యాలెన్స్ షీట్ లేకుండా ఆడిటింగ్ అవుతుందా?
అది ఇచ్చేసింది కదా,
18 lakhs అన్న FD చేసి ఇచ్చేసిండు, వాళ్ళకి ఇచ్చేసిండు. మళ్ళీ వాళ్ళు ఇప్పుడు 21కి ఇచ్చేసిండ్రు, వాళ్ళ దగ్గర లేవు. ఇప్పుడు నా దగ్గర ఉన్నాయి. ఇగో సార్ అరుణ మేడం ఇచ్చేసింది, ఇగో నా బ్యాగులే ఉన్నాయి, ఆల్ FDs నా దగ్గర ఉన్నాయి.
కాదు మేడం, మీ ఇయర్కు మీకు ఎంత ఆడిటెడ్, మీ ఆడిటర్తో చేయించవచ్చు కదా మీరు.
మన్మోహన్ సార్, ఇగో FDs ప్రాబ్లం లేవు, అన్ని FDs ఇదే బ్యాగులో 16 నుంచి 17కు 17 ఎన్ని ఇట్లనే ట్రాన్స్ఫర్, ఇప్పుడు కూడా ఇదే బ్యాగ్ నెక్స్ట్ మోన్లో ట్రాన్స్ఫర్ అయిపోతుంది. ప్రాబ్లం కాదు.
బ్యాంక్ ఆఫ్ బరోడా ఎక్కడ సమ్ అదర్ బ్యాంక్, కెనరా బ్యాంక్ లో పెట్టిండు ఆయన. మన మెయిన్ అకౌంట్ ఉన్నది SBIలో. సో యూ ప్లీజ్ ట్రాన్స్ఫర్ ఇట్ ఇమీడియట్లీ.
అది కాదండి,
డిసైడెడ్ లాస్ట్ టైం.
They have done their thing and they have also given me the 2021 statements of their bank.
Yes.
2019 వాళ్ళది అప్పుడు అకౌంటెడ్ స్టేట్మెంట్స్ తర్వాత జనవరిలో ఎప్పుడో మార్చిలో అడిగినప్పుడు ఇచ్చారు. There are lot of clarifications required. There is no clarity on many things they have said, including what I mentioned. So a clarity is
ఇప్పుడు అంతా ఫర్గెట్ అబౌట్.
సార్ ఒకటే
you have to
on behalf of
get
Neta
clarity
Rajesh Singh
on the accounts.
2019 వాళ్ళు ఆడిటింగ్ చేసి బ్యాలెన్స్ షీట్ ఇచ్చేసి 18 lakhs FD చేసింది సార్. వాళ్ళ గురించి ఇంకా దాని గురించి ఇంకా పోర్ట్ చేయదు సార్ దయచేసి. 18 వాళ్ళు చేసి చేయదు సార్, 17 వాళ్ళు చేసిన వాళ్ళు వదిలేయండి సార్. ఇప్పుడు సార్ 20 వాళ్ళు ఆ బ్యాలెన్స్ షీట్ పెట్టుకొని ఆడిట్ చేసేసేయండి, అయిపోయింది. ఇంకా పక్కల గురించి ఎందుకండి?
సరే, మీ డిక్లరేషన్ ప్రకారం విల్ టేక్ దట్
18 lakhs అంత చేసి 18 lakhs ఇచ్చేసి.
సో దట్ ఈస్ ద సేవింగ్స్ ఆఫ్ దేర్ కాన్ఫరెన్స్ 18 lakhs.
మీరు అన్నట్లు మనకు అంత నాలెడ్జ్ ఉండదు. ఆ లెక్క ప్రకారం చేసేసి ఆడిట్ చేసి 18 లక్షలు FD చేసి ఇచ్చేసారు, అది అయిపోయింది. దాని వదిలేయాలా సార్? ఇప్పుడు నెక్స్ట్ ఆ బ్యాలెన్స్ షీట్ పట్టుకొని 20 వాళ్ళు చేయాలా. 20 వాళ్ళు ఏ చేసినా కానీ వాళ్ళ లెవెల్కి వాళ్ళు చేసిన వాళ్ళని కూడా ఏం డిస్టర్బ్ చేయదు సార్. నెక్స్ట్ వాళ్ళు తీసేసుకుంటారు అంతే, మన లెవెల్లో మనం ట్రై చేస్తాం అంతే.
ఆడిటెడ్ రిజల్ట్స్ 2019 ఉన్నాయి కదా మీకు.
బ్యాలెన్స్ షీట్ ఆల్రెడీ ఇచ్చేసినాం.
బ్యాలెన్స్ షీట్ కాదు, బ్యాంక్ స్టేట్మెంట్ తో సహా వాళ్ళకి ఇస్తే వాళ్ళు సబ్మిట్ చేస్తారు.
కాదు సార్, ఆడిటెడ్ అకౌంట్ చేసిన తర్వాత ఫైనల్ బ్యాలెన్స్ షీట్ అని ఉంటది. ఆ బ్యాలెన్స్ షీట్ ఎప్పుడు వస్తుంది అంటే నువ్వు ఆడిటింగ్ సబ్మిట్ చేసిన తర్వాతనే యూ విల్ గెట్ బ్యాలెన్స్ షీట్. Unless until you do auditing, you won't get, nobody will get balance sheet. Once if you get balance
sheet, bank account,
balance sheet, అదే
bank statement,
bank statement తర్వాత bank statements అన్ని ఆడిటర్ సబ్మిట్ చేస్తేనే పైసలు కడితే బ్యాలెన్స్ షీట్ వస్తుంది. బ్యాలెన్స్ షీట్ ఊరికే ఆడిటర్ ఆఫీస్ IT ఆఫీస్ నుంచి రాదు. ఆ బ్యాలెన్స్ షీట్ అయిన తర్వాతనే మిగిలిన 18 లక్షలు నేమ్ ఆఫ్ IADVL తెలంగాణ FD చేసేసి ఆ రోజు AGBMలో ఇవ్వలేదు, మళ్ళీ నేతా సారే అందరూ ఇన్స్టలేషన్ సెరమనీ ఇచ్చేసి అది అక్కడికి అయిపోయింది సార్. దాని గురించి డిస్టర్బ్ చేయదు. నెక్స్ట్ 20 వాళ్ళు ఉన్నారు, వాళ్ళ బ్యాలెన్స్ షీట్ పట్టుకొని చేయాలి, వాళ్ళ లెవెల్ వాళ్ళు చేసేది చేయాలి సార్.
Every year the president and secretary of that year or the executive is paying the GST as well as the income tax. Okay, right?
అవును.
So consequently the previous body also should pay the income tax and
of course సార్. అది అంత అయిన తర్వాత కాదు సార్, అది మానవ సరోవర్ల ఒకటి గణేశ్వర సార్, మానవ సరోవర్ అప్పటికే మనకు 10 లక్షలు పెనాల్టీ అదే డ్యూ వచ్చింది. 7 అప్పుడు ఏం డిస్కస్ చేసినాము, ఎక్కడి నుంచి వచ్చింది వదిలేసి కట్టేమని. తర్వాత అదే రకంగా GST కూడా 38 లక్షలు వచ్చింది సార్. అది ఒక్క కాన్ఫరెన్స్ ఒక్క నిమిషం సార్, అదే ఎక్కడి నుంచి వచ్చిందో తెలియదు. అదే 38 లక్షలు అంటే ఇప్పుడు ఎవరు ఉంటే వాడు రిఫ్లెక్ట్ అవుతుంది. నాకు వచ్చింది నీకు వచ్చింది కాదు, మన IADVL తెలంగాణ మీద ఇంత నేను చెప్తా. అది ఎప్పుడు వచ్చింది అంటే 2019 కన్నా ముందు చూపిస్తుంది. అది 2019 కన్నా ముందు ఆ డ్యూ చూపిస్తుంది.
ఇప్పుడు now they want to know this balance sheet what you have given.
అదే 2019 కన్నా ముందు ఆ జిఎస్టీ చూపిస్తుంది, ఇప్పుడు ఏడ చూపిస్తుంది? ఒకటే రెండే విషయాలు సార్, ఇది అదే ఈ జిఎస్టీ ఇది ఎక్కడికి వెళ్ళి వచ్చింది వెరిఫై అయినా చేయాలా, లేదు అంటే కట్టేయాలి ఇక.
అదే జిఎస్టీ 2008 మాది అయిపోయినాక నేషనల్ బాడీ కూడా సబ్మిట్ చేసింది. 15 lakhs చేంజ్ సబ్మిట్ చేసినాక జిఎస్టీ నిల్ ఉంది. తర్వాత
మళ్ళీ ఎట్లా చేస్తుంది?
అదే అంటున్నా, అది
ఇప్పుడు
క్లారిఫై చేసుకోవాలి.
2019 కన్నా ముందు
GST paid receipts from our dermatologist.
2019 కన్నా ముందు అది రిఫ్లెక్ట్ అవుతుంది, అది అంత రిఫ్లెక్ట్ కాకూడదు, ఎట్లా అవుతుందో తెలియట్లేదు.
I request everybody to speak to President, otherwise it will be chaos and you are not going to end the meeting today. You take the permission of President and talk, whatever you want to talk.
Definitely close this today.
After the permission of the President only I am talking. He only told me to sort it out. Because
we will pass a resolution today.
We have to finalize this because every year this is happening.
Let us not
So
postpone this. Finish.
What are all the you fix a date for the next meeting for the President Secretaries to get their audited accounts? Audited accounts of all the previous 4 years.
రెండే విషయాలు సార్, సార్ ఒకటే నిమిషం సార్. 2019 వరకు అందరూ చేసుకుంటూ వచ్చిండ్రు, అయిపోయింది. ఇప్పుడు రెండే డ్యూస్ ఉన్నాయి, ఆ డ్యూస్ కట్టేద్దామో కథం ఇక అయిపోయింది. కట్టేద్దామంటే కట్టేద్దాము, ఇంకా దానికి ఏం ఇష్యూ లేదు. IADVL కట్టేద్దామంటే కట్టేద్దాము. ఆల్రెడీ ఇంత ముందు మానసరావు వల్ల కట్టేద్దామని యునానిమస్ రిజల్యూషన్ తీసుకున్నాము, అది ఆపినాము ఎగ్జామ్షన్. కట్టేద్దామంటే జిఎస్టీ పెనాల్టీ కట్టేద్దాం, అయిపోతుంది.
34 లక్షలు కడతారా?
It is not your choice, Gumesh. It is not our choice. It is a choice of income tax or GST people to take it. So మనము we cannot decide కట్టేద్దాం అంటే కాదు అది. If we have to pay, we have to pay. That's all.
అదే పెనాల్టీ వచ్చింది కదా, కట్టేద్దామంటే కట్టేద్దాం, వెయిటింగ్ అంటే వద్దు.
అదేనమ్మా, ఎంత ఉంది అది ఆమెకు వచ్చింది వాణి గారికి, అది
కాదు మేడంది వాళ్ళ పీరియడ్ లో వాళ్ళు చేసేసేయమనండి. ఒకవేళ పెనాల్టీ ఉంటే కట్టేయమనండి, ఏమైనా డ్యూస్ ఉంటే.
వాళ్ళకి నయా పైసా రాలేదు, వాళ్ళు ఎట్లా కడతారంతా?
సార్ వాళ్ళు కట్టారు. మన IADVL తెలంగాణ FD ఏదైనా బ్రేక్ చేసి కట్టేయటమే, వాళ్ళు ఎందుకు కడతారు? వాళ్ళంటే IADVL కదా,
బ్రేక్ చేయాలంటే మనీ ఎక్కడికి వెళ్ళి తీసుకోవాలా?
మన FD ఏదైనా ఉంటే బ్రేక్ చేసి కట్టేయాలా?
ఏది
మన FDs ఇప్పుడు ఇంత
ఎవరి దగ్గర ఉన్నాయి, మీరే చేయాలి కదా.
ఇక్కడే ఉన్నాయి అన్ని FDs.
మళ్ళీ FDs ఉంటే మళ్ళీ మీరు అన్లెస్ యూ క్యాన్సిల్ ఇట్, హౌ కెన్ దే?
కాదు, మీరు కట్టేయమంటే అందరు AGP అందరు కట్టేయమంటే బ్రేక్ చేసి కట్టేద్దాం అంతే.
అది లాస్ట్ టైం డిసైడ్ చేసాం.
డోంట్ గో అవే.
వెంకటకృష్ణ సార్, ఇప్పుడు FDs ఒకళ్ళు బ్రేక్ చేసి పెండింగ్ కట్టేద్దామంటే అయిపోతుంది, వన్స్ ఆఫ్ ఆల్ కథం.
సి గుమేష్, నేను చెప్పేది వినండి. Unnecessarily also we should not waste money which we are eligible for.
38 కాదు 29.
Let Manmohan speak, please maintain silence.
We will make this President Secretary's meeting from the inception of Telangana IADVL. We'll meet with a chartered accountant, experienced one. We'll meet in some place in Gandhi Hospital or some other place. Don't put again the office, we cannot come that day because in the weekdays it is difficult for us. Then secondly, last time I was blamed that I have not closed the account. I have shown it to Mohanlal, took him to the bank and shown him that my account is closed. Satisfied Mohanlal? Now also you have to also do the same thing next year. Remember that. And under bank accounts ekkada close chesedi. Is the purpose of
permanent single auditor, single account.
Single account.
Single account,
Canara Bank.
Auditor also.
And the IADVL మన ఆఫీస్ మెయింటెనెన్స్ కూడా మనం రెగ్యులర్ గా చేస్తున్నాము, ఆ మెయింటెనెన్స్ కూడా అట్లనే కంటిన్యూ చేసుకోవాలి. ఒకటి డర్మా ఫౌండేషన్ అన్నది ఏపీ తెలంగాణ ఉంది. మన ఇప్పుడు ఆల్రెడీ ఏపీ వాళ్ళు ఏపీ డర్మా ఫౌండేషన్ వాళ్ళు ఫామ్ చేసుకున్నారు. సో లెట్ us ఫామ్ ఏ తెలంగాణ డర్మా ఫౌండేషన్. మన గౌరీ మేడం మీరు ఆల్రెడీ చెప్పారు, ప్రాసెస్ నడుస్తుంది. దట్ వి విల్ క్లోజ్.
Once you get this, immediately you will be credited with 66 lakh rupees into your account.
What is the resolution passed today now?
Madam is ready to tell you the details about that. She has been waiting for the constitution and a license. You have to take Neta Miru.
Not regarding Dharma Foundation.
Dharma Foundation.
Not regarding that.
Okay. So this we are meeting with the audited accounts and get a certificate from all the banks that you have closed your accounts there.
Yeah.
Is it agreeable to everybody in the house?
With due respect, sir, let me talk on this topic.
Yeah.
Yes, sir. Sir, regarding this transfer of account into single this thing, we are last time conference we discussed Dr. PNR sir was there and they discussed that since the PAN number was same, so it doesn't matter how many banks we have, but all should be in FDs. All the amount is in FDs. Whichever bank it is there, it is in FDs. It is better to have smaller FDs every place because
not every place. At least
a few places.
Let it be
See,
SBI.
you are having an affection to Canara Bank, fine. You can have
let
it.
it be on
This is an
SBI.
association account. We'll make a uniform bank that is State Bank of India.
No, 100% sir, agreed. So what
ఇప్పుడు
we have decided is,
SBI లో మన లాకర్ ఉంది సార్, ఆల్రెడీ లాకర్ ఉన్నది కాబట్టి దాన్ని కంటిన్యూ చేసి ఇప్పుడు
అదే నీకు ఎన్ని లాకర్లు కావాలా? How many lockers you want? Tell me.
లాకర్ ఉంది కాబట్టి
ఉన్న అకౌంట్ కి they'll give 10 lockers free.
సార్ ఇప్పుడు లాకర్లకెళ్ళి తీసుకొచ్చినాము, ఆ లాకర్ ఉంది కాబట్టి SBI లోనే ఉంది, అదే కంటిన్యూ చేసేసాం.
SBI account number.
sir,
SBI అకౌంట్
let
నంబర్
me complete sir. So
కోయిగూడలో ఉంది, గాంధీకి ఎదురుగా ఉంది, అందులోనే కంటిన్యూ చేసేద్దాం.
No, because this account I started first in SBI Usmania, that is being carried to the Venkatakrishna time also. That is also, I told Vani, introduced her and I told her to carry on the same account. I don't know what happened. So one account is already there. Why small annexes? You can all get them and put it here.
Sir,
ఇప్పుడు ఇక్కడ SBI లో కూడా 15 నుంచి 19 నుంచి 21 వరకు ఇది కూడా అదే క్యారీ అయింది సార్. నడమల ఒక రెండే తేడా అయింది. ఒకటి
మేము అక్కడ ఫిక్స్డ్ డిపాజిట్ చేసింది 70 lakhs. మీరు ఇక్కడ ఎంత చేసినారు? ఆ ఫిక్స్డ్ డిపాజిట్ మన అకౌంట్ మూల దగ్గర చేస్తే దే హావ్ ఎ సాఫ్ట్ కార్నర్ ఫర్ us.
ఇందులో కూడా ఆల్మోస్ట్
ఫర్ గివింగ్ కన్సెషన్స్ ఆన్ ద లోన్స్ అండ్ ఆల్.
ఆల్మోస్ట్ 18.5 అంటే ఒక 25 lakhs FD ఉన్నాయి సార్.
ఎట్లుంటది? మా అక్కడే 70 కి మీద 25 ఉంటే ఎట్లా డిఫరెన్స్?
SBI ఇది అక్కడ ఉంది, దీనా బ్యాంక్ లో ఉంది, ఇక్కడ ఉంది.
సరే, వాట్ ఎవర్ ద బాడీ డిసైడ్స్.
సో ఇప్పుడు లాకర్ ఉంది, లెట్ ఇట్ బి కంటిన్యూ.
No, but I am also insisting, let it be continued in SBI.
Just a moment.
Online banking. Let us continue with the
just a moment.
First one only.
See, we thought of changing the signatory authorities. So whoever is the present body. So as of now we submitted that to Janardhan sir on basics day. We gave that paper.
ఇప్పుడు signatories అనేది
let me complete up please. So fast ga ayipotadi. So already we have submitted those papers to Janardhan sir. Then as discussed, they said it is better the next body takes up. So fine. So again I brought the papers for next body to change the signatory authorities. So whoever is the next body, they can sign and take over the account in the Canara Bank.
They have finished their tenure, no? How
yeah, next body. Whoever is there now.
They have finished their tenure. What will be those signatories?
Next body, sir. Next body.
Should have given to that body.
This body, sir. This body we are supposed to give, and we have given the papers. Yes.
Yeah, you can.
Yes.
That's what I'm saying.
Not with my authority. I cannot close the new body. Whoever is taking, they have to change the signatory authorities.
No, sir. Whoever are the signatories for that bank?
No, presently what we will do is, we will change the signatory authorities first, and whoever is the present body, let them transfer.
Give a letter saying that these are the signatories, and it will be transferred.
Yeah, transfer, and then whatever they want to do this. And
so
here
from
also
tomorrow onwards, Yes. Yes, one of that should be either.
Okay, done, taken. So next is that is over. Please close. And this committees, all those things, it is a discretion of EC. Almost the EC they will take care as per year. And even that.
Dr. Bhumesh, this is very important. If you are closing the Usmania account, you are going to lose on your fixed deposit bonds. When you don't account,
అది ఎక్కడైనా అవుతుంది సార్, అది ఎక్కడైనా అవుతుంది.
ఇక్కడ 1 crore కి పెట్టుకుంటావా, నష్టము అక్కడ నువ్వు 20 lakhs కి పెట్టుకుంటావా?
అది ఎక్కడైనా అయితే సార్, అది ఎక్స్పైర్ అయిపోతుంది, దాని పీరియడ్ అయిపోతే కాదు.
When I am telling something question,
మీరు చెప్పింది నాకు అర్థమైంది సార్.
25 లక్షలు ఎక్కువనా, కోటి రూపాయలు ఎక్కువనా?
మీరు చెప్పింది నాకు అర్థమైంది. ఆ పీరియడ్ అయిపోతే
అభ్యంతరం ఏంటి? ఆ అకౌంట్ తీసుకోవడం వల్ల మీ అభ్యంతరం ఏంటి?
నాకేం అభ్యంతరం లేదు.
తీసుకోండి, అదే కంటిన్యూ చేయండి.
నాకేం అభ్యంతరం లేదు. ఇంకా అయిపోయింది కదా సార్, నాకేం అభ్యంతరం ఉంటుంది?
1 crore వర్త్ FDs పెట్టుకున్నారు. 1 crore వర్త్ పెట్టుకుని 80 lakhs ఇచ్చిండ్రు. 55 lakhs సార్ వాళ్ళు రిటర్న్ చేశారు. ఇంకా 25 lakhs అట్లానే ఉంది.
నాకేం అభ్యంతరం ఉంటుంది సార్?
మరి ఇప్పుడు మేము అకౌంట్ క్లోజ్ చేస్తే Ganesha has to sell down all the thing and then pay the money because you have taken it as a loan.
Yes.
So once we close the account, FDs automatically will be cancelled and that will be taken to the new branch. So why all this unnecessary? We'll make it same number, you use SBI here only.
No, you want us to pay back the amount?
No, I am saying that will be a problem for you.
What for?
You have to pay back the interest, no? You are taken from the bank, no?
That's true.
So once you close the account, bank will not entertain you for the loans. Once you are taking out your FDs, they are collaterals, you have given it to them.
No, we are not giving any collateral to them.
Our bonds are collaterals for your loan.
Okay, in that case,
Usmania we cannot close.
I know. No, why can't we bring a proposal wherein we can pay the amount, because we have fixed deposit about 25 lakhs now from the Canara Bank. We can pay that amount if the body decides, so that we will get released your bonds.
ఇంకోటి కెనరా బ్యాంక్ లో కూడా వాళ్ళు అట్లనే లాస్ అవుతుంది అంటే అట్లనే ఉంచింది సార్. ఇప్పుడు ఉస్మానియాలో కూడా లాస్ అయితే అదే జరుగుతుంది.
Let us see, if the president permits, my suggestion as a member is, let us have one account. It is always, I feel Usmania account is the first one and the oldest one, where 3 conferences were attached, myself, Venkat Krishnas and Dr. Vanis. The same number can be used, because on that we have deposited 1 crore rupees and then they have taken loan on the same account. So it is better if you continue that account instead of your account. I don't know. Why you are so particular about changing to this? That is also SBI, this is also SBI. So
okay, next
all the members
so
agree,
we will try for single account. That's one. Next, the committees will be the discretion of the EC, and that TSJD the chief journal another last year last meeting lo every 1 year notification ivali, every year notification ivali, notification prakaram the editor, the chief editor for the journal, it has to be continued. So is it okay, or every 2 years? And another important, members. So every year 4 members they are adding. So last year those who have completed 2 years, so those will be exchanged. Ante at a time oka naluguru paata vallu untaru, oka naluguru kotta vallu add avutuntaru. So by that the work will not. The TSJD journal.
Okay. That is all scientific persons, they can decide.
Or with the president, as per they will take. Regarding the journal last year it was decided every 1 year chief editor post marali, దానికి నోటిఫికేషన్ ఇవ్వాలంటే లాస్ట్ టైం కూడా we have given issued the notification and we have received the application forms. As per that we have gone, it will continue as like that only every year. You have to issue the notification. And regarding members, ఒకటేసారి అందరిని తీసేస్తే డిస్టర్బ్ అవుతుందని 4 లాస్ట్ టైం వాణి మేడం 4 members రిక్రూట్ చేసింది. దిస్ ఇయర్ 4 members రిక్రూట్ చేసాం. సో అంతా లాస్ట్ ఇయర్ ఆ 4 members ఈసారి వెళ్ళిపోతారు. ఇప్పుడు అంటే వాణి మేడం ఉన్నప్పుడు 4 members వెళ్ళిపోతారు. ఇప్పుడు 21లో ఉన్న 4 members రిటైన్ అవుతారు. ఇప్పుడు మీరు 4 members రిక్రూట్ చేసుకుంటారు. మళ్ళీ నెక్స్ట్ ఇయర్కి వచ్చేలాగా వీళ్ళు వెళ్ళిపోతారు. సో ఎట్ ఏ టైమ్ 4 members పాత వాళ్ళు ఉంటారు. దట్ విల్ కంటిన్యూ ఫర్ ద, లేకుంటే ఏమవుతుందంటే కొత్త ఒకటేసారి డిస్టర్బ్ అవుతుంది. బట్ చీఫ్ ఎడిటర్ పోస్ట్ లాస్ట్ టైం మన మీటింగ్లో డిస్కస్ చేసిందంటే ఎవ్రీ ఇయర్ నోటిఫికేషన్ ఇష్యూ చేయాలి, దాని ప్రకారం పోవాలి.
Sir, President, sir, you are agreeing with that we should have only one account, that is the account which is...
I want one account.
From Usmania account we will take?
Okay, no.
Is it passed in the general body? Please tell us. No, you have to take a decision now.
No, I am taking a decision.
Right. So all the other accounts should be closed.
All the other accounts will be closed and only one working account in SBI at Usmania will continue.
Yes. And then secondly, they should get the bank closure certificates to the President Secretary meeting. Preferably it should be held just before Sankranti also.
Before Sankranti?
కాదు సార్, ఇప్పుడు ఈ బాడీ ఇది మార్చి వరకు ఆడిటింగ్ చేస్తుంది. మార్చికి ముందు క్లోజ్ చేయడానికి కుదరదు. ఎందుకంటే మినిమం మార్చ్ 31st వరకు ఇప్పుడు ఫార్మా వాళ్ళ నుంచి ఇంతవరకు పైసలే రాలేదు.
Again you are coming back to
క్లోజ్ చేయాలంటే చెప్తున్నాను నేను.
See, let us not find reason.
క్లోజింగ్ అంటే చెప్తున్నాను.
TS IADVL as a fixed amount, that account will run.
The FDs okay, no problem.
All those TS
లాస్ట్ గానీ ఏమన్నా గానీ ఒక అకౌంట్ లో చేంజ్ చేయండి. ఎప్పటి నుంచి అనుకుంటున్నాం కదా, FDs will be shifted to one account.
చెప్పనియండి సార్, మీరు చేస్తాం 4 ఏళ్ళైనా ఏం కాలేదు. అందుకే చెప్తున్నాను, let us decide once for all what is this ఊరికే కమింగ్ ఎవ్రీ ఇయర్
అంటే మనం అందరం కలిసి చేయట్లేదు. నేను ఒక్కని కాదు, మీరు ఒక్కరు గారు మీరు ఒక్కరు
కాదు, ఎవరు చైర్ లో ఉన్నా వాళ్ళు చేయాలా, మేమేట చేస్తాం. నేను చేస్తే ఇస్తారా ఒకసారి? So you call get a certificate of all
Mr.
the accounts.
President sir, so the transferred amount should also be made into fixed deposit.
Yes.
That's what I mean. That should be clarified. Yeah.
So, and then on that meeting, you preferably as early as possible, let them get closure statements from the banks and the amount.
I want to inform everybody now that our account for this financial year, we will definitely give an audited account 100% before 31st March of next year.
And the 2020 body, they have to submit the balance sheet. The final balance
that
sheet
they will give it on that particular day of president secretaries. Everybody is supposed to get
audited balance sheet he has to submit.
Yeah, they will do that, and all the previous president secretaries audited things should please get it.
Secretaries and treasurers, are they agreeing to meet after Sankranti or before Sankranti? After Sankranti we will meet.
After Sankranti means before next Sankranti?
No, no, hello. Before the
We
end of
want a date,
January,
sir.
before the end of January, that is 4th week, we will meet.
Okay, take it, please take it as a general body meeting point.
No, I am telling you,
and
shouting.
inform all the president secretaries. Unfortunately, some presidents and then president-elect is also not here. He is the president from today.
Yeah, we got a message because some emergency health issue is there, so that's why he sent a message.
Okay.
So that is one point you have to clear.
And so all of you, sir, let me read the minutes of meeting. So
హలో మినిట్స్ అంటే అయిపోయినాయా మీటింగ్ అయిపోయిందా అండి
మేడం
లేదా మీటింగ్ అయిపోయింది అడుగుతున్నా మరి మినిట్స్ ఎట్లా రేట్ చేస్తారు
చెప్పమ్మా
Okay, we will go to the further.
లేదు జర్నల్ గురించి మాట్లాడుతుండే కదా యాక్చువల్లీ నేను
This AGBM is being telecasted, I believe, YouTube. YouTube లో వస్తుందంట లైవ్.
అది యూట్యూబ్ లో రావద్దు తీసేసి
చెప్పాలనా వీళ్ళకి
warm welcome to CUTICON 2021 Hyderabad, Telangana, the Indian Association of Dermatologists, Venereologists and Nephrologists, that is IADVL. It is 7 long years and 7 beautiful years. I just wanted to tell 2 words about this organization, and that is this organization is the largest representing official society of Indian dermatologists. Can we all give a round of applause for this beautiful gathering first of all? Gatika chappatlu. Okay, so let us be a little more creative and energetic. When I tell one, I request all of you to please clap once. When I tell 2, that is twice. That is 1 tap and 2 taps. So let's see. Ready? 1. All together, we all learn when we should sign in. I request all of you to please come out of that official mode and get into the night gala mode. Ready? 1. Super. 2. 3. 4. 2. 1. 100. Yes, we're going to be clapping the whole day so that, we'll be a little energized and we'll be more boosted to give a wonderful entertainment to a beautiful gathering. I'm Neha, and firstly, I thank the organization and the event manager for giving me this wonderful opportunity. And once again, we'll start this beautiful day with a round of applause. Loud round of applause. Alright, so as any function or any start should be started by God's blessings and God's grace. So here we go. We have Ganesh Vandana presenting by Mahesh Master and team. Can we all once again give a round of applause and invite them onto the stage? Thank you. Alright, so meanwhile the dancers come. I see a lot of cute little kids sitting in here. So I request all of you to please come onto the stage. Alright, do you want me to come here or on the stage? Where do you want me to go? We'll go on the stage, right? So I invite all the kids onto the stage. Can we all give a round of applause for kids? Kids are equal to God, right? So let us start with the beautiful kids who are here, gathered here, alright? So I am going to count down so that I request all the kids onto the stage within the countdown. Here we go. So with a small music, can we have a small music? Ready? Here we go. 10, 9, 8, 7, be fast, 6, 5, 4, 3, 2, and 1. I request all of you to please come in the center. Here, please. Can everybody use the music, please? Alright. So, firstly, let us introduce ourselves, right? Alright. So, what's your name? Taksh. Wow, that's a really wonderful name. And Taksh, right? Your name is Taksh. Your name? Dhriti. Dhriti, beautiful. Your name? Sahasra. Wonderful. Your name? Megha. Beautiful again. Your name? Pranav. Oh, that's great. And your name? Suhas. Alright, so we have all the VIPs. I tell them VIPs of today, right? Alright, because they are coming firstly on the stage. Alright, so now there's a small little game that is, ice-breaking. We need to make everybody a little alert. So this is a kind of a game where I'll be asking you for a thing. Okay? So you have to get into the crowd. You can go to anybody in the crowd here. And you have to get the thing first onto the stage. Within the countdown, whoever is getting the thing which I ask first will be the winner. Alright, so when I tell you 1, 2, 3, and then only you need to go to the crowd. Alright? Okay, so please, ladies and gentlemen, I want all of you to please concentrate on what I am telling, because only you can make them win this game. Alright? Here we go. So firstly, get into the crowd and get me a watch. And listen to, wait. And listen to me also in the between. Alright? When I tell you 1, 2, 3, and then only you have to go. Please be safe, don't rush. Alright? And now, you have to go to the crowd and get me a watch. Ready? 3, 2, 1, and go with the music, please! Here we go! 10, 9, the watch shouldn't work. The watch shouldn't work. Take the watch and work. Not yours, from the crowd. Here we go. 10, 9, 8. You can get it from there. 5, 4, all right. Go get that watch. Go get that watch. Someone please go get that watch. I need you to get watch, not a mobile. Oh my God. That was great. Be quick. Come fast with the music, please. Let the background music run. Alright, so let me check. I think the first person was you who got the watch. You have the watch with you? Do you have the watch? Yours is there, alright. And let me see, does this watch work? Okay. It shows the correct time, but this doesn't work. So let's see, who is the owner of this watch, please? Who is the owner of the watch? Is that you? That's great. It's my event manager. Can you all give him a round of applause? Because, you're a very busy man. That's the reason. All right. And the next watch, I've seen this watch which is not working. Is that so? Yes, it is not working. Who is the owner of this watch? May I know your name, ma'am? What's her name? So can you all give a round of applause for Lakshya? She has a lot of work and she did not get time for, putting the battery on it. Everybody's watches will work, man. Come on. We are the kind of people who wear watch only for style. Me too, the same thing. That is great, all right. And the next person. This works, right? This already works. And that was the end of the first game. And who will be the winner? Winner will be you and you. So can we all once again clap for them? So I think you will come for the second round and it is going to be a different game. Okay? Thank you. I request all of you to please take your respective seats. Can we all once again clap for these beautiful kids? And I think the dance team is ready. Is the dance team ready? Alright. And now it is going to be the audience turn. Alright? I am going to sing a song from the between. ఆ సాంగ్ మీరు అందరూ గుర్తించాలి. ఏ సాంగ్ అనేది మీరు అందరూ గుర్తించాలి. ఎవరికైతే ఆన్సర్ తెలుసో మీరు బయటకి చెప్పండి. డోంట్ టెల్ ఇట్ అవుట్ సైడ్. Please lift your hand. So someone will get the mic to you so that you can sing. Whoever lifts the hands first will get the chance. Alright? Please don't sing the song outside. So if you know the answer, please lift your hand. Alright? So this song is really very famous song and this song is in 80s. Alright? So I request you to please give a little effect to the mic. Alright? I'm gonna hum the song first or I'm gonna sing it from the between. Alright? And it is Ramarao Gari song. Namadine mandirame All right, so I've seen the first person who lifted their hand there. So can someone please pass the mic to you? You are in the first row. Yellow saree. Here. All right. Can you please sing one hum for us, please? One line for us. Just one line for us.
Recognizing is okay. If I say
I'll sing along with you. I'm going to sing along with you.
no.
So somebody else knows the song, it seems. So who is going to help you? Is that so? Alright, the song is Nannu Dochukunnata. May I know your name, please? Don't bring the mic very soon. Let her tell you your name.
I'm Savitri.
Sorry? Can you increase the mic volume?
Savitri.
So Dr. Savitri Gariki, gatiga chappatlondi, but the answer is Nannu Dochukunnata. It starts this way. Nannu Dochukunnata, Nannu Dochukunnata, Kannala Dochukundu Nannema Swami, Nannema Swami, Nannu Dochukunnata. That was great. And the second question is, this song is also very famous song, and it is very beautiful song too. And it starts this way. I'll just hum the song. If anybody knows the answer, please lift your hand. All right? And the song is. Okay, so I've seen the person there who lifted his hand. Can someone please pass the mic to him?
Veena.
Yeah, that's great. So can you please hear for us? Can you please increase the volume of the audience there, please? Yes, please.
నీవు లేక వీణ పలుకలేనన్నది
నీవు లేక రాధా నీవేనన్నది నీవు లేక వీణ. Please sir, can you sing once again for us?
Oh, thank you.
ఇప్పుడు మీ వాయిస్ బయటకు వినిపిస్తుంది అన్నమాట.
I think you did a good job.
Yeah, thank you. All right, please, for us. మీ పేరు?
Narasimha.
So can you all give a round of applause for Dr. Narasimha Rao garu? That was great, sir. Your voice is really very beautiful, and we expect that you sing a song for us. All right, and is the dance team ready? All right, so we'll have one more song. Let us go to the new trend. All right, so the song is this way. Yes, can you please someone pass the mic to her? Here, the second row. Manohara Nahurayamani Umayavaniga Malachina Nanpuradevara Athenani Utummayane Nagihundanta Nagundelalo Nitarame That's great, ma'am. What's your name? May I know your name, please?
I'm Dr. Geetika.
Sorry?
Dr. Geetika.
So, Dr. Deepika Gariki Gatiga Chapatlu, and round of applause. That was great singing. We loved your voice again. And now I request all the kids to please come back again. Please come back again. Tundariga vacheyali. Ready? I'm going to count down only 5, 4, 3, 2, 1. All right, ready. So now I'm going to ask you one thing that you have to get from the crowd. All right, ready? Please listen to me in the between also. నేను చెప్పేది మధ్యలో కూడా వినాలి, వినకుండా పరిగెట్టద్దు. Okay, ready, 3, 2, 1. మీరు ఇప్పుడు crowd లోకి వెళ్ళి you have to get me 5 rupees. Right? Ready, 3, 2, 1 and go! 4, and I think she has done a great job. So who was all these people who has given you changes? Can all of you please lift your hands? Whoever gave them, donated them the changes. Tell the thank you for them. Thank you. Once again, thank you. Thank you. Because they're going to take the money and buy chocolates for them. Can you all give a round of applause for the kids? Are you happy? Go buy some sweets for yourself. Alright? Alright, thank you so much. You can take your respective seats. And now I think the dance is ready. Here we go. Let us start with the God's blessing with a beautiful dance team presenting by Mahesh Master and team on the stage. Ganesh Vandana in a few minutes. So why? Because we are waiting for the main dignitaries to be arrived. So once they are here, we are going to start this Ganesh Vandana, and sorry for the inconvenience. And before that, we have lot of, as I told you, we have lot of entertainment, as I told you. And now this is going to be again this song. I'm going to sing a song. You have to recognize the song. So let's be energetic till the dignitaries arrive. All right. And the song is చిట్టపట్టనడు ములవోపలో ఒక ఇరుసును అలసలు కలవగా విసిరిన కసి కసి వయసులో ఒక ఎదనిస పదనిస కలవగా కలవదు కలవదు అది లేదంటుంది నడిపడు ఏమంటున్న మదనుడు తెగ ప్రేమించాక వదలడు చూస్తా సగసు కోస్తా వయసు నిలబడు కౌగిట. One person there, I think she is in the 5th row. Can someone please pass the mic to her? Can someone please pass the mic? All right. So can you please tell me the song? Can you please pass the mic to her? Can someone please pass the mic? Yes, there. Yes, ma'am.
అమ్మని తీయని దెబ్బ.
Yeah, that's the correct answer. May I know your name, please?
సౌమ్య.
సౌమ్య గారికి గట్టిగా చప్పట్లు, and that was great. చప్పట్లు అంటే అందరూ కలిసి. Can we all give a round of applause to them? All right, and the next song. It is. All right. And this is going to be a Hindi song again. The song is प्यासे प्यासे दिल तेरे लबों के लिए मिलने वाले को सारवाद किए. Yes, I've seen the first person out there who lifted their hand. Can someone please सोला सोला के आंखें बिछा जा दिन की ज्वाला ठंडी हो जाए ऐसे गले लग जा. Alright, that was great. Your name, sir?
Narasimha Prasad.
Please come again.
Dr. Narasimha Prasad.
Okay, so Dr. Narasimha Prasad gariki marokasari gట్టిగా చప్పట్లు. Can you all give a round of applause to them? All right, and the next song is okay. I think this song we are hearing from so long time, and this is a really very famous song, and it is Jadu kosam Guduki Visidi తెలుసుకో అమ్మాయి గారు. Sir, I think you are the main person out there. You know, he knows every songs. And once again, can you all give a round of applause for Narasimha sir? Sir, వేరే వాళ్ళకు కూడా అసలు కొంచెం అవకాశం ఇవ్వండి, మొత్తం మీరే పాడేస్తే. All right, and the next song. Okay, this is a new song. మీకు ఎవరికైనా తెలుసు అని తెలిస్తే ప్లీజ్ లిఫ్ట్ యువర్ హ్యాండ్. The song is నీ ప్రేమలో ఆరాధనే నీ నిండుగా మునిగాక నీ కోసమే రసానుగా నా కళ్ళతో బియ్యలేక చేరునో చేరదో తెలియదుగా జీవితం నువ్వు నా కోసమే వెనకపడని మనసు పడిన మనసే ఇష్టమైన సకుడా ఒక్కసారి చూడరా పిల్లడా చక్కరా. Yes, I've seen one person out there lifting her hand. She's in black color dress. Can someone please pass the mic to her? All right, I think she is in 1, 2, 3, 4, 5th row.
Priyatama.
Yes, that's the correct song. Can you please sing one line? Priyatama, palikinadi sirama. That's great. Your name, please?
Nikhila.
So can you all give a round of applause for Ms. Nikhila Garu? That is great. And the next song is, and this is my favorite song. Let's see. I think everybody knows this song because it is a really wonderful composition, and the composition is by composition అన్ని కూడా చాలా బాగుంటాయి. So this is one of them, and the song is ఉడికించే చిలకమ్మ నిన్నారించే ఉలికించే అందాలే ఆలాపించే అచ్చట్లు ముచ్చట్లు తానాసించే మస్తులా చిందేసి ఆరాధించే మోసాన చిన్నది నీవతనున్నది. Okay, here we go. I have the first person here. He has lifted a hand in the front. Can someone please pass the mic? Either front. All right, with red coat.
That's it.
Please sing for us, sir. Yes, that was correct. Any middle. That was great, sir. That was superb. Your name, me peru?
Prakash Rao.
So can you all give a round of applause for Dr. Prakash Rao? Thank you so much for participating. All right, and now I think we have the beautiful musicians here. And may I know your names, please? Me peru, sir. So can you all give a round of applause? We have in keyboard we have Satish Garu, and again in keyboard we have Santosh Garu, and with electric pad we have Nikhil Garu, and in tabla we have Umesh Garu, and we have singers Sridevi Garu, Alex Garu, and this beautiful music band is organized by Shalan Garu, and it is Shalan Band. Can we all give a round of applause for this band and let us learn the beautiful songs for them, and you can carry the memory to your home. Let us come out of that official part and let's get into the gala, and this is the 7th annual conference of IADVL Telangana. Thank you. Music track back of the office set.
Check on testing. Hello.
So that was wonderful start and was beautiful song. Can you all give a round of applause to them, please? Gatiga chapatlanడి. All right. చాలా మంచి సాంగ్ ఇది సో మనందరికీ నచ్చింది అనుకుంటున్నాను. దిస్ ఈస్ వెరీ బ్యూటిఫుల్ కంపోజిషన్. సో కెన్ యూ ప్లీజ్ ఇంక్రీజ్ ది వాల్యూమ్, కొంచెం వాల్యూమ్ ఇంక్రీజ్, కొంచెం.
all the delegates of CUTICON 2021, please come forward. I request Dr. DBN sir, Dr. Janardhan, Dr. Ramesh, Dr. Mohanlal, Dr. Puttasini sir, Manmohan sir, PNR sir. ముందుకు రావాల్సిందిగా కోరుతున్నాము.
Alright, so I think మీ అందరికీ ఇక్కడే సర్వ్ చేస్తారు. మీరు ముందుకు వచ్చి కూర్చుంటే దిస్ itself. ఇప్పుడు I think our organizing chairman Mr. BBM మూర్తి గారు ఇక్కడ వచ్చేసారు అనుకున్నాను, తనకి స్వాగతం పలుకుతున్నాను. అండ్ ఆర్గనైజింగ్ సెక్రటరీ భూమేష్ కుమార్ గారు కూడా వచ్చేసారు అనుకున్నాను. సో వెల్కమ్. అండ్ ట్రెజరర్ జనార్దన్ గారు కూడా వచ్చేసారు. అదే కాకుండా లాస్ట్ బట్ నాట్ లీస్ట్ ఆ సైంటిఫిక్ చైర్మన్ గారు జి నరసింహారావు నేత గారు కూడా వచ్చేసారు అనుకున్నాను. సో వీళ్ళందరికీ కూడా స్వాగతం సుస్వాగతం పలుకుతూ I request all the doctors to please come occupy your seats in the front so that we can start this beautiful day with Ganesh Vandana. All right. All right, so I will once again request all the doctors, the respective doctors, to please come to occupy your seats in the front so that we can start this beautiful day with Ganesh Vandana. నాకు తెలిసి గణేష్ వందన చేస్తూ ఉండగా మీరు అందరూ వచ్చి కూర్చుంటారని. Here we go, let us begin this beautiful day again with the God's blessing. Here we go, Mahesh, Master and team onto the stage. Thank you. with this beautiful award, wonderful dance performances, and there's one more occasion today. It's a very big occasion. Today is Christmas, so I wish all the doctors and all the family members here Happy Christmas, Merry Christmas, and a prosperous New Year ahead. And with this, I give the stage to the live band that is Sharon Band and team to give a beautiful performances for us. Thank you.
Check your answer. Gita